went to college. Went to college and medical school at UVA, and then decided to be an East Coast transplant to the West Coast. I was just telling Priscilla, it's hard sometimes to get used to calling people by their first name. I've been on faculty for 7 years. I'm now mid-career, which is crazy to imagine, but I still also pause before, calling my kind of senior attendings Bobby, but I would encourage you all, please, to call me Ira whenever you see me. My kind of training path, I did medical school at UVA in Virginia, went to residency in San Francisco at UCSF, internal medicine, and kind of did the primary care track. So I'm a primary care addiction medicine doctor, board certified in both. I actually didn't do the addiction medicine fellowship. I was asked to be a chief resident, and so I did an extra year as a chief resident, making very little money. And I was like, I cannot be a fellow for more time and make no money. I wanted to support myself and my family. And so went to faculty and really did a lot of self kind of guided trainings, much like this, on the weekends, on evenings. When we still needed an X waiver to prescribe buprenorphine, I did my X waiver training on a vacation day. A lot of kind of my own self-directed learning happened, and I did the practice pathway, got board certified in addiction medicine, and then founded and I direct our addiction medicine clinic at UCSF primary care. So just kind of a whirlwind trip. Now I'm our associate program director for our residency and our primary care residency, the same one that I did many moons ago. And I'm in charge of our kind of resident addiction medicine education. So this is a kind of brief distilling of a lot of the content that we'd share with the residents. And I also am kind of big in medical education and making sure that we're doing the things that are most engaging. So I am wearing our Curbsiders Addiction Medicine shirt because I'm a producer for that podcast. And I want you all to think about, hopefully, I think Priscilla sent out the information for the podcast to listen to for this particular session, but there are 2 seasons of just delicious content for y'all to check out when you're commuting, exercising, kind of just want to get some more knowledge nuggets for yourself around addiction medicine. Please do that. I would really highly suggest that. All right, enough of a monologue about me. Let's turn it. Thank you for putting that in the chat, Priscilla. Appreciate it. Let's get started. I'm gonna find my PowerPoint here, and then I am going to check. Maybe Priscilla, you can give me a thumbs up depending on. My goal is for you all to see the slide, not the presenter mode. So
you are in presenter mode right now. I can see the slides, but it's still in presentation.
Okay, how about now?
Yes, perfect.
Now it's okay. All right, let me move you all so that I have 2 screens here. I can see you. Okay. Again, us 26 people here gathered on a Saturday. Feel free to kind of drop things in the chat. I'm going to lead on Priscilla. Thank you so much for moderating. And if there's questions, please ask. But we're going to be talking about alcohol and stimulant use disorder, a few best practices in this realm. And we're going to do a little bit of foundational content as well. All right, we cannot start a talk without learning objectives. So by the end of this hour, and I hope we have some time before the hour, but by the end of this talk, I would like for you to be able to develop an approach to diagnosing substance use disorders. Specifically, we'll be talking about alcohol use disorder, AUD, or stimulant use disorder. To recognize first-line evidence-based treatments for commonly encountered SUDs in clinic, and describe 2 harm reduction strategies you can review with your patients at your next visit. And this is regardless of clinical setting, right? It could be psychiatry clinic, it could be primary care clinic, it could be, who knows, surgery clinic. But I want you all to bring these tools and these skills to that practice setting. How are we going to accomplish those objectives? This is our roadmap. We're going to go through a little bit of background, kind of use a case to shine some light on the situation, go through how do we diagnose and treat DX and TX, specifically around alcohol use disorder and stimulant use disorder. We'll end with some harm reduction kind of tips and philosophies, and then hopefully save some time for reflections, next steps, and Q&A. So before we kind of launch into a case, and I know many of you have listened to the podcast, you might have questions around it, something comes up. I want you kind of to imagine a patient that you've cared for who maybe drinks alcohol or uses stimulants in chaotic ways. And that kind of pattern of use is not healthy for them. I want you all to keep this person in mind when we go through this talk, and what you might do differently, maybe the next time you're interacting with that patient, the next time you see them, or maybe the next time you see somebody else who has a similar kind of chaotic pattern of use. This talk is meant to be applied in that situation. I find that if we visualize a person in mind, kind of it's much more applicable. So consider kind of a patient that you have seen or may see in the future. I'm going to share a patient with you who I saw in clinic, one of my patients, and this is somebody who us all are seeing together in clinic. We've seen him a couple times kind of as part of our longitudinal kind of clerkship experience. And at your last visit, you actually talked to him that you were worried that he was developing an opioid use disorder. And he actually shared that, he has been having trouble managing his cravings for hydrocodone. This is something that was prescribed to him for his back pain for the last couple of years. And actually, he's had to use his friend's oxycodone to help him with cravings and withdrawal from opioids when he didn't have them. And actually, the last time you saw him in clinic, y'all started him on buprenorphine to treat opioid use disorder. And he chose to start buprenorphine in a low dose, kind of slow approach at home, cutting the films to get to a dose that works for him. And today he's following up with you. And he actually says, his pain's okay. And he's not having any cravings. His opioid use disorder seems to be managed thanks to the buprenorphine. He's now on 8 milligrams sublingually. And he asks if it's okay for you to take the buprenorphine with alcohol. He has a nightly kind of drink in the evening, and he notices that he gets a little tired when he has this drink and the buprenorphine. So this kind of brings up a question of, does Mr. TM have an alcohol use disorder? And I want you all to pause for a second to think, do I have enough information to really kind of diagnose that? Because I might suggest that we need more information. And as we think about kind of diagnosing alcohol use disorder, I want you all to think about kind of the branch points that we have when someone tells you that they drink alcohol. And the branch points for me are kind of, are they drinking within healthy limits, or are they drinking in unhealthy ways? And if we're in the unhealthy bucket, are we in the alcohol use disorder, which we'll get to in a second in terms of diagnosing, or not quite in that chaotic use, but still drinking more than healthy limits, which we call kind of at-risk alcohol use. Now, how do we diagnose? This kind of image in the corner here tells you the limits, healthy limits, based on CDC and the NIAAA for men and women. So on a single day for men, no more than 4 drinks, and for women, no more than 3. And then per week, no more than 14 for men and 7 for women. And what I might ask you to do, this is a screenshot from the podcast show notes, because every podcast episode comes with notes that you can kind of check out online. I might ask you to think for yourself, like, how can I get at this question? How can I find out how much people are drinking? And there actually is a single item screener that we use in primary care that's been validated. And we ask the question, how many times in the past year have you had X number of drinks or more in a day? And that X is what I just mentioned, 5 for men or 4 for women. And the 5 and 4 correlates to, again, above healthy limits, okay? And so if you get a question of, or an answer of, yes, I've had, at least one time in the past year that I've drank 5 more drinks as a man or 4 more drinks as a woman, then we have to kind of assess the question around, do they have alcohol use disorder? And we'll get to that in a second. And before we even ask this question, we have to know, like, what is a drink, right? What does it mean when you're asking somebody that question? So I have put kind of the website and the screenshot from the NIAAA's kind of guidance around calculating drinks, because I don't know about y'all, but I find that people have all sorts of drinks, and I am so confused on what a standard drink may be or may look like. So I turn to this website typically. And there's even a cocktail content calculator, because yours truly, who loves pina coladas, I had no idea that that's actually 2 standard drinks in a day when you're having a pina colada. So just like knowing for yourself that what a person tells you they're drinking, I would check to see how many standard drinks. Because if somebody says, I'm actually having 3 pina coladas on Friday, that's 6 standard drinks, which is more than healthy limits for men and women in a single time. And if you're wondering, like, what is Ira talking about? What is a standard drink? The same NIAAA website also has definitions of how many ounces of wine, how many ounces of liquor actually kind of correlate to a standard drink. So I would kind of even pull this up quickly when you're talking to somebody on the computer to just see, what am I meaning by standard drink? What does this actually mean that the patient is drinking? All right, so let's say somebody does ask you, or does say, actually, I have been drinking kind of 4 drinks at a time on a Friday, or 5 drinks at a time on a Saturday for a man, and you're starting to wonder, is there chaotic alcohol use or kind of unhealthy alcohol use that matches alcohol use disorder? And this is where we have to think about kind of 2 quick terms, dependence and addiction. And I know this is within the like psychiatry interest group and kind of thinking about how the DSM has evolved. We have now differentiated between old terms of drug dependence and drug abuse. We don't use that abuse term anymore. We have evolved to think about, what is addiction actually? How do we kind of quantify that, qualify that, and the awareness of stigmatizing language when we say things like substance abuse. So that's no longer part of our verbiage, but thinking about kind of biologically these 2 terms helps us understand what's happening for people. Physical dependence, this is the biologic adaptation. I want y'all to think about, Mr. TM, we saw him many moons ago. We started him on buprenorphine, but when he was using his hydrocodone, there's a certain degree of dependence that's expected over time with the chronic opioid use. And this dependence includes the syndromes of withdrawal, so the symptoms that happen when you take away the substance, and the syndrome of tolerance, needing more of the substance to have the same effect. So this is kind of physical dependence. When we think about addiction or opioid use disorder, or in this case, when we're talking about alcohol, this is where we start seeing a behavioral component and kind of that chaotic use where you have loss of control, cravings to use, continued use despite harm or in harmful situations. So continuing to drink despite kind of operating machinery or while driving, or kind of losing control of how much you're drinking. So these really behaviorally mediated kind of changes that happen, neuroadaptations, is when we get the kind of syndrome of addiction as opposed to dependence. And dependence can take anywhere from days to weeks to develop, versus addiction or opioid use disorder or alcohol use disorder. In this case, this is longer. These are neuroadaptations that are different than the ones that are happening for tolerance or otherwise. And this tiny figure in the corner is really kind of an image of which parts of the brain kind of address the aspects, the neuroadaptations that I'm talking about that happen over time when people use substances in chaotic ways. There's this like preoccupation and anticipation of use. Then there's the binging and intoxication, like the actual use. And then there's the withdrawal pattern. But I will tell you all that most people, when they're kind of longer into their addiction or more severe addiction, people aren't using for that initial kind of high or euphoria. Most people are using, whether it's alcohol, opioids, stimulants, or other things, just to avoid the negative effects of withdrawal, because that withdrawal piece is just so kind of terrible. And so you'll hear people saying, like, I just want to feel well. I just want to feel normal. And that's because in that cycle of neuroadaptation, they're trying so hard to avoid that withdrawal because it's so terrible. And in general, this kind of image for me is how I think about addiction. And I want you all to think like overdose deaths, or kind of somebody you might be seeing in clinic for after like a DUI or something else. These are really the tip of the iceberg of addiction. This is kind of why we're seeing people in clinic or in the hospital. But there's so many root causes that got that patient to that place, whether you're seeing them in clinic after, let's say, an overdose, or in the hospital, maybe they're admitted for a skin and soft tissue infection. These are all end organ manifestations of their disease, the disease of addiction, and there's so much that lies beneath. So thinking about this patient, Mr. TM, there might have been pain, depression, racism, isolation, all of this kind of involved in the patient's narrative, and helping us like kind of take a step back to see this bigger picture will ultimately help us take better care of the patient who's in front of us.
And there's a question in the chat, that says, so if a patient is developing tolerance but does not exhibit withdrawal symptoms upon stopping use, would they still be considered physically dependent on the substance?
Great question. Generally, dependence does include kind of both, but I think if you're noticing at least tolerance, that does show that there is a significant dependence. I'll have to kind of, if we were by the book or by the letter, usually it's both with tolerance and withdrawal. But once somebody has developed tolerance, that's kind of indicating that we are in the spectrum of dependence, kind of potentially moving towards addiction. But you generally want to have both of those symptoms. But I think if you're noticing somebody's developing tolerance, like that should be a kind of a spidey sense to you, like, maybe we're in a state of dependence on whatever substance. And this could be, this isn't just alcohol or isn't just opioids. There's many people, many substances, many medications that we prescribe to which people develop a dependence to. All right. One kind of big picture today, part of our objectives is that I want you all to have a framework or an approach to diagnosing substance use disorders. And this may have been covered in kind of undergrad, medical school, but I do feel like I want folks to have a quick way of doing this when they're approaching patients in the office, in the ER, in the hospital. Generally, we have the DSM-5, and this is the DSM-5 criteria for opioid use disorder. Tiny letters, apologies, but that's really not the point. The point is that you could look up all 11 criteria and, kind of sit there and like read it out to the patient. Like, do you take alcohol in larger amounts and for longer than intended? But I kind of think about, are there other ways that I can get at this criteria that helps me understand what's going on for the patient? And I do want to highlight that these numbers, like out of the criteria, if you have 2, 4, or 6 for mild, moderate, or severe, for me, that means more how much is this substance or this, whatever it is, impacting the person's life. So when we think about severity, think about that as more of like, what is the role that this use disorder or addiction plays in that person's life? I think more about the 4 C's and the 4 R's, which is something I would want you all to walk away from. Is there role failure for this patient because of their alcohol use? Are there relationship troubles because of the stimulant use? Are they using in risky ways and kind of causing harm? Have they tried to cut back on their alcohol but haven't been successful? And these are the R's. And then 4 C's, this is where we talk about those criteria, the behavioral criteria that kind of take us from dependence to addiction. Is there a loss of control? Is there cravings to use? Is there a compulsion to use? Behaviors like, I always take the same route because I'm going to pass this one bar because I know there's alcohol there. And consequences of use, meaning like, somebody injects fentanyl or heroin and they're having abscesses relative to that. These are all consequences of use. So 4 C's and the 4 R's. If you want to get really quick, is there use and consequences of use? So if you're seeing somebody coming into the hospital for a kind of near overdose, or again, a skin and soft tissue infection or infective endocarditis, that is enough for us to diagnose a use disorder. And maybe when we saw Mr. TM kind of at the last visit, when we had prescribed him buprenorphine after we made the diagnosis of opioid use disorder, maybe we saw him running out of his hydrocodone early. Maybe we saw something unexpected on the urine drug screen. Maybe he was seeing multiple providers trying to get hydrocodone or visiting his friends to try to get oxycodone. Or he wasn't really focused on any other part of his health, but just solely focused on the opioids and how can I get more of them. And this is a slide where I want y'all to take it home and think about, how would I actually say this out loud to a patient? How would I, in a patient-centered way, talk about diagnosing a substance use disorder? And what I typically ask patients is, first, you get permission. Can I ask you about your relationship to alcohol? Then trying to figure out kind of within kind of principles of motivational interviewing, what do you like about alcohol? What do you not like about the cocaine? What are your future plans regarding the alcohol? Do you plan to reduce, continue, or increase your use? And then kind of bringing in the community feeling. What do your loved ones think about your cocaine use? Kind of just trying to get a sense for that patient of how much of a role the substance is playing in their life, maybe what harms is it causing, and how do we balance that with maybe the benefits that somebody is getting from their substance use? All right. So let's go back to our kind of diagram of when someone is drinking above healthy limits, do they have alcohol use disorder, or do they not meet criteria and they're in this kind of at-risk alcohol use area? And if I could have a little, like a tiny bit of practice in terms of retrieval practice is one of our science of learning techniques. Can someone kind of think what we had just mentioned around the 4 C's and the 4 R's? What would we ask Mr. TM? Does anyone want to throw that out? Any of the 4 R's or 4 C's that we just talked about? Feel free to unmute or drop it in the chat, whatever works.
Well, we could ask him if him trying to maybe get the hydrocodone from his friend has maybe put a stress on that relationship, or if there's any more changes going on with other relationships that he has because of his use.
Love that, Priscilla. So kind of what has changed about his, especially relationships, relative to either the kind of hydrocodone or oxycodone use, or even maybe with this like nightcap situation, what's happening there? How is that affecting his life? What else?
I would say control. It sounds like he's out of control to the point where he's not wanting to make the conscious choice to continue. It sounds like from the fact that he feels like he's just trying to get back to that normal by having to use his friends.
Mm-hmm. Mm-hmm. Exactly. Kind of patients are trying to do their best. They're like, how can I escape these feelings of withdrawal? Because he's having them and I need to use the oxycodone. Thank you, Jordan. I see Brooke in the chat has mentioned, has he tried to quit or reduce his use? Yes. One of the R's kind of, has there been repeated attempts? I love that. Nice job, y'all. Well, let's move on and think about Mr. kind of TM a little bit in the context of what's going on nationally. So I just want to give you all a little bit of kind of graphics to put into perspective relative to what we know about alcohol use disorder in the kind of nation's demographics. We get data from the National Survey on Drug Use and Health, or what we call NSDA. And this is actually from a phone survey that extrapolates from thousands of calls data for basically the US. And so we get data about the last year's kind of phone calls, and the 2022 data is still coming out. But what we know is that among the 130 million current people who are using alcohol currently in 2021, 60 million of those drank heavily in the last month. And the percentage who were most likely to actually drink heavily, or what we call binge drinking, were in the age group of 18 to 25, followed by those age 26, okay? And then in terms of what's happening kind of alcohol use disorder wise, which is where we're kind of moving towards diagnosis, this graph shows that roughly 30 million people with alcohol use disorder, and 7 million of those have a drug and alcohol use disorder. So let's think about Mr. TM that we started this case with, right? He has opioid use disorder. We started him on buprenorphine, and now he's also having a nightly drink, which we haven't said whether he has alcohol use disorder or not, but he might be in that category of kind of overlapping 7 million people in this country with drug and alcohol use disorders. I see there's some things in the chat. Perfect. Okay. And then on top of this, y'all, the actual percentages from the NSDA data of people with alcohol doubled from pre-COVID to intra-COVID. So kind of thinking about how many of those people who have alcohol use disorder are actually getting treatment. Well, spoiler alert, it's like less than 3%, very few people. So let's think about treatment. And the pre-work, which was kind of the Curbsiders Addiction Medicine podcast on alcohol use disorder medications, really gets at that question. What can we do? What is FDA approved to treat alcohol use disorder? And you'll see in this image that once we diagnose moderate or severe, so that's 4 or 6 criteria for the use disorder, that's when we have kind of tools in our toolbox to treat this condition. And that's because, y'all, the FDA approval is for patients with moderate to severe alcohol use disorder. So with that stat, that less than 3% of patients who have alcohol use disorder are offered treatment, and we want to change that statistic, what treatment modalities come to mind? What have you heard, or what have people mentioned to you? Maybe there's some FDA approved medications, maybe there's some not FDA approved medications, or even non-medication approaches that we'll talk about in a second. What have people heard to really address and offer treatment for alcohol use disorder?
So I often hear, at least antiquated, that the number one treatment is AA, but I know for sure that doesn't work for everyone. And obviously there's other like psychosocial treatments that you can get involved with, such as like harm reduction groups, or even just individual one-on-one therapy to like motivational interviewing, CBT, kind of changing the patterns of thinking. But I'll let others speak to like maybe medication or other treatments.
So in the chat, sorry, go ahead.
No, go ahead, Priscilla.
So in the chat, Jacob says CBT plus medications like naltrexone, and then Vito says antabuse, Ramona says Camprol, and then Zinat has their hand raised.
Yeah, so I would say we can differentiate the treatment in non-pharmacological and pharmacological treatment. If we go with pharmacological, there are 3 FDA-approved medication, which is naltrexone, disulfiram, and acamprosate. And there are some non-FDA-approved medication as well, and I have seen patients did well on that too, like gabapentin. We can try that. And for non-pharmacology, as prior candidate mentioned, that we can go with the therapy, AA meetings, and yeah, I think so.
Yes, y'all have hit the nail on the head on this one. There are medications, the 3 approved FDA ones. Yes, I see topiramate in the chat. Great. We'll get to that in a second, Ramona, and appreciate also the psychosocial approaches that y'all are mentioning, anywhere from CBT to AA. There's a lot of people, Priscilla's mentioning smart recovery, Dharma recovery, exactly. So these are kind of in the group therapy component that we'll get to in a second. But that was perfect. Y'all are on the right spot. So this is a graphic from our podcast episode that kind of puts into perspective the medications that are FDA approved and that are not. And so I'm not going to go through in detail on this, but I just want you all to know that this exists and would be kind of the thing to turn to when you're thinking about the patient sitting in front of you and what's the best medication for them. I've developed with colleagues a few kind of similar tables that I want to highlight for y'all. So our first line medication, and these are within the FDA approved meds, is always naltrexone. Naltrexone, naltrexone, naltrexone. The best data is actually for the extended release injection. I'm pointing to kind of the gluteal area because that's where we give the injection. The best data is actually for the extended release naltrexone, the injection, brand name Vivitrol. We typically do test doses of PO naltrexone before we do that. I actually have plenty of patients who are doing well on PO naltrexone. The key here and why there's a blue box is that we want people to be able to tolerate this medicine. And I found that when you start a patient out of the gun on kind of 50 milligrams daily of naltrexone, many of them have headaches, stomach upset, they just feel crappy, they can't sleep. And so they abandon treatment. And so our goal is to kind of start it in a way that people are like, oh, I'm not really feeling anything if that. So yeah, I'll continue this. And so I start people on 12.5. That's literally them taking the pill cutter and cutting the pill in fourths and taking 1/4 of that tablet in the morning with food and having them kind of tolerate that for 1 or 2 days, then moving on to half a tablet, 25 milligrams for 3 days, and then moving on to the 50 milligram tablet dose. Okay. And that's one that we take every single day. And the number needed to treat to prevent heavy drinking or abstinence is 12 and 20 respectively. So really low numbers. And for extended release naltrexone, something like 4. So it's, again, very effective. The thing for that people may have seen coming up in the literature kind of is, why do I have to take naltrexone every single day? Can I take it on a PRN or as needed basis? And I will say there's a signal for people to be able to take that on a PRN basis, showing kind of reduction in heavy drinking, if that is their goal. However, that's only been studied in a kind of particular population, actually done in San Francisco, where I am with kind of gender minority patients. And I will say that I have not made that a standard practice. Our kind of evidence is still for either the medication taken daily or the medication as an injection monthly. The second FDA-approved medication, a Campersate, I will tell y'all, if the patient's goal is abstinence, I am not drinking again, this is not what I want ever again in my life, this is the medication that we often start with, in addition often to naltrexone. And I will say that the only issue with a Campersate is that it is a heavy pill burden. So it's 2 pills that are each 333 milligrams per kind of capsule. So you take 2 of them and you take that 3 times a day. And then if there's any CKD or kind of creatinine, GFR fluctuations, then you're dose reducing it. So it is a lot of pills. Okay. But there was just a meta-analysis, I think like 2 weeks ago, that showed that in terms of the FDA approved medications, if the patient's goal is abstinence, a Campersate is the best one. And I see a question in the chat. Are there any medications that target the dopamine reward pathways in addition to opioid receptor activation? So naltrexone is a opioid, mu opioid receptor antagonist. So it blocks that receptor. So that is kind of directly active there. And a Campersate is one of those medications that we kind of like hand wavy, where it kind of modulates glutamine kind of pathway. And I will say that the dopamine reward pathway, or that reward pathway in general, nucleus accumbens and all of it, kind of what I showed y'all, that picture of the brain and the neuroadaptations that happen, glutamate is part of that as well, even though we know that dopamine is kind of the main actor. So all of these kind of indirectly or directly, in the case of naltrexone, address that that same pathway. Disulfiram is kind of highlighted in a very light color, and to signal that often, y'all, I don't use this medication. This medication has been studied actually to be effective in places where you're literally observing somebody take the medicine. So DOT, directly observed therapy, and often we're just not doing that. And for the patients who maybe are in certain professions where they need to kind of show that they're taking a medicine and not using anything else, maybe this is a medication that you can suggest. But I will tell you, I often, and actually in my last, 7 years of faculty practice, I have not used this medicine at all, inpatient or outpatient, because I do both. But it is on the potential list and on the 3 FDA approved medications.
Dinah, I see you have your hand raised.
Yeah, I have a question. So, so for naltrexone, if it's okay, if patient is actively drinking alcohol, we can start with naltrexone, right? But how about acamprosate?
Say that one more time. Sorry.
My question is, what I understand that for naltrexone, we don't have any like prerequisite of not drinking alcohol or stop, right?
Yeah.
I mean, can drink, but they can decrease their drink intake. How about for acamprosate? Is there any recommendation for starting acamprosate for the patients? Because I hear that patient should be alcohol free for a while, and then we can start acamprosate.
We don't have that as like a firm recommendation. I think there's not the same interaction that we think about for disulfiram, where you actually have kind of physical symptoms if you are drinking on this medication. It's not the same thing. It is kind of recommended that if your goal is abstinence and you are not drinking, that this is a medication for you. But it's not the same thing where if you have alcohol, there's going to be some sort of negative reaction. In general, patients come to me in the office and they have usually either already made a decision to say, I'm not going to drink, or I'm going to drink less. So starting a Campersate in that moment is totally fine. There's no prerequisite. They have to absolutely not be drinking.
Yeah. And what's your experiences? Have you tried naltrexone along with acamprosate together?
Yeah.
And if it's, yeah.
Yeah, and those, I would say naltrexone is always your first line unless there is a contraindication. And the only contraindication for us actually in the hospital or in clinic is people with cirrhosis Child-Pugh class C, or people whose cirrhosis is actively decompensated. Those are the only 2 contraindications. After that, naltrexone is always your first go-to. If you want to add certain things onto naltrexone, like a camprosate or gabapentin that we'll get to in a second, that's totally fine. I think that the reason that a camprosate is just used less often is because people's goal is often not complete abstinence. And the data, the strongest data is for a camprosate in people whose goal is abstinence. So that's why I find myself not always reaching for that medicine on top of naltrexone. And also, most people are just not able to take 6 pills a day. So I think there's just a lot of kind of barriers to staying on both of those. And if people are having success with just naltrexone, often they will kind of self-decide to only take naltrexone. Great questions though. Okay, y'all, just to move us along, because I noticed that we have 20 minutes and we still have another use disorder to get to. I want to highlight 2 second-line medications. And again, these are not FDA approved, okay? And that's partially why they are second line. But gabapentin has been shown, there's been some signal for, again, reduced heavy drinking. So in the same way that we talk about naltrexone, if someone's goal is I want to drink, binge drink less or have less heavy drinking days, this might be the medication for them. I typically am using naltrexone first and then combining it with gabapentin, because I'm finding that a lot of times, one, I can't get patients to the doses that they need to get, the 600 milligrams TID. So I'll just use like a little bit, maybe 300 or even 100 TID. And naltrexone is kind of like my foundation. To Pyramate, I will say there's been a lot of excitement around Pyramate. Somebody mentioned it for cocaine use disorder. We'll get to that in a second. This is a great medication that also has shown a signal for helping patients reduce their heavy drinking days. I will say this is a medication that's often really tough to tolerate. It has kind of cognitive changes. People feel like they're like not able to just think the way that they used to. They just don't feel like themselves. They have random like tingling. It's just they might be sedated more than they were before, even more than with gabapentin. So I have found that some patients have just had difficulty maintaining this medicine, and I've had difficulty getting them to the actual doses that has been studied, which is 150 milligrams BID. Often we'll start people on 25 milligrams BID, and that's like all that they can tolerate. And then I heard some folks mention at the very beginning, what about kind of AA? What about CBT? And that is a great question. And actually, there's a lot of good data for the psychosocial treatment. We're going to kind of skip through the what have people heard about this, because people have clearly heard about this, but I like to talk about individual therapy or that component of psychosocial therapy as what we can also do in the office. So motivational interviewing, or MI, this is a way for us as providers to explore and resolve ambivalence with patients around behavior change. And all that MI is, y'all, is a facilitated conversation. There's 2 kind of acronyms here, PACE via ORS. So PACE is like, this is the spirit of MI. We're partnership, that's the P. We're in this together. We have acceptance, meaning that we're non-judgmental about where patients are in their kind of addiction or recovery journey. We're going to meet them wherever they're at. The C is compassion. So my goal is to do no harm and just to be there with you. And then the E is evocation, or like trying to figure out what's important to patients. What are the changes that they might want to make? Okay, so that's the spirit of MI. And we figure all that out via ORS. ORS is another acronym that stands for open-ended questions, affirmation, reflection, and summarization or summary. This is basically how you do MI. And I think that y'all are probably doing all of this with patients all the time, kind of asking open-ended questions, affirming their behavior or a certain characteristic, reflecting, which is really the bread and butter of MI, hearing somebody say something and saying, wow, family is really important to you. And then in the summary or the mega reflection, you're also listening for change talk, like words that could be reflecting someone's desire or ability or maybe reason that they need to make a change. And then you elevate it, you reinforce it to them, you reflect it back to them, and kind of think about what are our next steps relative to that. CBT, which I heard folks mention as well, is really kind of thinking and doing. So if we change how we're thinking about, let's say, substance use, it can affect our feelings, which can influence our behaviors. And this is, again, kind of how do we adapt that CBT mechanism maybe to return to use prevention. So kind of helping people recognize, how do I, if I've made this change, how do I continue my goals of not using? And CBT kind of crux is like recognize, anticipate, avoid cues or triggers. What are the people, places, or things that might make me want to drink again? And how do I develop coping skills to help me in those situations? One phrase that came from a different Curbsiders Addiction Medicine podcast around psychosocial kind of treatment is called catch it, check it, change it. And I would commit this one to memory because it's very easy to talk about with patients. Catch it is like, I catch the thought or the craving, you know, like, oh man, I see that bar that I used to go to, and I pause. And the check it is the pause that allows you to respond, maybe reflect, but not react. Change it is the piece where maybe you change your behavior. Oops. Maybe you don't go to that bar. Maybe you don't go to that liquor store. And if your impulse was to go to the store, maybe you respond and walk by, or maybe you call a friend or use a different coping skill to kind of move past that. So catch it, check it, change it. Really nice and quick and easy kind of individual CBT approach. Group therapy. Group therapy, y'all, really kind of hits on the power of the peer group when it comes to addiction, because we know that for addiction, this kind of community is so powerful. We talk about the isolation and the opposite of addiction being connection. So how do we get people together in a group where they can think about, you know, what are my group dynamics? What are the things involved that can kind of help me be a part of an agent or be an agent of change? And that peer cohort is super important to make changes. And that's kind of the foundation, honestly, of AA, is that peer group is powerful and it's like super easy to connect with people. Mutual aid groups like AA, they do have generally a spiritual or abstinence only model. And I will say AA is like free all over the country, easy to participate. You get introduced to a peer cohort, that group therapy model. It is probably kind of universally known as the thing that is the first step when we think about group therapy and psychosocial treatment. But it's not for everybody. So Celebrate Recovery, Smart Recovery, Refuge Recovery, Dharma Recovery, all of these, they have different components. Some of them might be less spiritual. Some of them might be not abstinence focused, like Smart Recovery is more moderation tolerant. Or even moderation management, which is literally a group of people who are focused on harm reduction. And then there's also acceptance and commitment treatment. And this is actually a combination of basically CBT and mindfulness. And you'll also see a lot of people doing contingency management, which is what CM stands for. And that's that operant conditioning where you get a reward and you're reinforcing a particular positive behavior change with that reward. And so there's been some movement around contingency management for alcohol use disorder as well. But I will tell you all, in general, my approach is I combine psychosocial treatment with medications, meaning I offer to patients kind of that, you know, medications and psychosocial treatment together might be the best one for them. So maybe they are on naltrexone and they're also going to a mutual aid or 12-step group. And this is based on data that we've gotten in the last couple of years that have been Cochrane reviews, JAMA meta-analysis that really support this combination of maybe CBT and therapy as opposed to them separately. All right, so the future also is bright. We've talked about FDA-approved medications. We've talked about second-line medications. We've talked about psychosocial medications. What about psychedelic treatment like psilocybin? So I will say that there is some clinical trial evidence for the potential of psychedelic substances in the treatment of PTSD, depression, and addiction, actually, in alcohol use disorder. A paper out of NYU just, I think, a year ago, actually, talked about how psilocybin-assisted therapy reduced the percentage of heavy drinking days for patients with alcohol use disorder. So we do see a signal for this. Obviously, we don't have a FDA-approved approach for this or even kind of a way to get people this in a large scale. And then I wouldn't forget harm reduction. So this is kind of a safer use strategy sheet out of UW that I often will go through with patients, which is just like small changes they can make that, you know, can change how they drink or how they kind of have their spend their evening or spend their weekends. And if people are, their goal isn't to stop drinking or to even reduce their drinking, they just want to do things more in a safer way, I will often kind of walk through the sheet with patients. All right, let's talk about Mr. TM really quick. So you mentioned the alcohol and your concerns with buprenorphine, and you talk about how the safety of buprenorphine, that respiratory depression ceiling that we love, that's the effect that we get from the partial agonism, it goes away when bup is mixed with alcohol or benzos or other medications. And there's also sedation and impaired judgment. You also discussed that the alcohol, because that's kind of the question that we had here at the very beginning, does this person have an alcohol use disorder? And he says, you know, I have a glass of wine at night, but no more than 2 at a time. And weekly, I probably drink 7 to 10 glasses because he remembers that he finishes at least 1 bottle of wine a week. So now that he knows that your concerns are with combining the bup and the alcohol, he says, you know what, I think I'm just going to have 1 glass of wine Friday through Sunday. So you see him a month later and he's doing well on the bup. He hasn't had any more sedation with the alcohol. He feels like he actually is pretty awake with it and stable on the buprenorphine. He hasn't used any other opioids. His pain's actually pretty good. He's a glass blower, and so he has kind of exhibitions of his work, and he's been able to do those projects. You do check a kind of routine urine drug screen for the buprenorphine, and the results are as follows. You see that it's positive for buprenorphine, which is in the 2-to-1 ratio of norbup to bup, and that's what we expect, y'all, on the urine drug screen. And you see benzoylecgonine, which is the cocaine metabolite, but there's no other opioids, nothing unprescribed, so no oxycodone, no hydrocodone. So what do you do now? Does this mean that he has a stimulant use disorder because there's cocaine in the urine drug screen? I'm going to move us along and say that the answer is no, y'all. Just because somebody has a certain result on their urine drug screen does not mean that they have a use disorder. We have to kind of go back through and remind ourselves about the 4 C's and the 4 R's to talk to Mr. TM about, to see, is there actually an issue here with the cocaine or not? Just so y'all know, this is kind of the metabolism of both heroin, like we would expect to see morphine in the urine, or oxycodone, we expect to see oxymorphone. And that cocaine metabolite, the benzoylecgonine, is super, super specific for cocaine. And oftentimes in my clinic, what we're doing is getting a comprehensive mass spec urine screen, and that's going to show us exactly everything that patient's taking. Caffeine, if they're drinking coffee, cotinine, if they're smoking cigarettes or using kind of tobacco or nicotine, their acetaminophen, if they're using Tylenol. It'll show you everything. And so that cocaine metabolite is super specific for actually cocaine. Now, I will say one thing that might be helpful as we go through this last section in 8 minutes is that if y'all haven't had a chance to, I would take a listen to the stimulant use disorder episode from the Curbsiders. It's fantastic and really goes through some of the things that we're going to talk about in more detail in a second. So if he did have a cocaine use disorder, which y'all, again, I am not saying he does. We have not gone through the 4 C's or 4 R's to show that he has that. We have no FDA treatment. So nothing is FDA approved, okay? There is some signal for, again, topiramate, just as I think Ramona mentioned in the chat. The only question is that, can we get people to the right dose? So that 150 milligrams twice a day is the dose that they've shown higher rates of abstinence. So their goal, their predetermined outcome was actually abstinence, no use, as opposed to kind of less use or healthier use. It has been very difficult to get patients to that dose. So that is one thing to keep in your toolbox, but just knowing that you might find some resistance around sedation, cognitive slowing, and maybe you get to 50 milligrams BID, but maybe we can see some improvement with that, okay? The other piece that I will tell you about is that mirtazapine has been trialed as well in patients, actually also out of San Francisco, one of the trials. by Coffin and JAMA in 2019, they looked at doses of 30 to 45 milligrams of mirtazapine that also had reductions in urine drug screens for methamphetamine, okay? And then the combination of bupropion and naltrexone was studied by Trivedi and Nejum in 2021, and that also showed a signal. The only thing is that they were using naltrexone injection, okay? And they were doing that every 3 weeks. I have enough trouble getting the naltrexone injection approved for patients who have alcohol use disorder, an actual FDA-approved medication for alcohol use disorder, that there's basically zero way that I've been able to get the naltrexone approved to do it every 3 weeks for methamphetamine use disorder. So I will say that is one that hasn't been as rolled out because of the logistics behind it. But bupropion by itself also shows promise. So knowing that kind of topiramate, bupropion in your toolbox for stimulant use disorder. The one thing that has the most evidence, a number needed to treat of like 3 to help people to basically prevent or to have a urine drug screen of no methamphetamines, is actually contingency management. Just like we talked about, this is a reward strategy where we reinforce a urine drug screen that has no methamphetamine or no cocaine in it with a prize. So for some people, that's a gift card. For other people, that's a statement of inspiration, like, you are doing great today. But as long as they come to clinic and as long as they are kind of able to produce a urine, and whether, ideally it has no methamphetamine in it, but they get a reward and they get to choose kind of from this raffle. And that has been shown to be very effective. The issue is really if it's available. This is a slide in looking locally in San Francisco. I think many of y'all are not in San Francisco, but California has done a really great job actually getting contingency management covered for patients on Medi-Cal, our version of Medicaid. But I would look around, depending on where you are, in Detroit or elsewhere, what are the options for my patients with substance use disorder, specifically stimulant use disorder, to be able to get this. Maybe there is kind of movements from the DPH, your Department of Public Health. Maybe there are other clinics who are doing this work, but I would definitely check it out. And I'm realizing we have 4 minutes left, and I am wondering if, so Grant asks in the chat, why are those medications not FDA approved for stimulant use disorder? The reason, Grant, is that there are, for the amount of studies that are kind of showing a positive signal, there are studies that are showing no signal. And so there has not been enough of a push for the FDA to give bupropion or naltrexone, or bupropion and naltrexone, or topiramate, or mirtazapine in FDA-approved indication. I think many of the people who are running those trials, including some of the folks in San Francisco, are trying to push for that. But so far, the FDA has not, there has not been enough of a signal to rise to their level of approval. Okay. This is basically Mr. TM telling you that he doesn't want to stop using cocaine, but he does use it in a safe way. So this is where we think about harm reduction and the principles of harm reduction, which is I'm going to minimize as much of the harmful effects and maximize how we can keep patients healthy. This is not coercive, not judgmental, and maybe, as we were mentioning throughout this talk, maybe stopping drug use isn't always the goal. Maybe that's not actually the definition of success. Maybe the patient staying alive, which is what I think about, is the definition of success. And the most that I've learned from harm reduction has actually come from patients. So I think patients are our best teachers in this, and really getting a sense of what patients are doing to keep themselves safe, I think allows us to take better care of the next patient. This is kind of images of how people use. So just so y'all know, in terms of what we should all be doing, whatever practice setting you're in, making sure people have access to naloxone, I think, is my biggest thing. In California, we actually can get it from pharmacies, other states very similarly. I would encourage that if there's anybody who is using any substances, whether it's recreationally or kind of being prescribed opioids, I would make sure that people have access to Narcan. If you are kind of meeting people in primary care, screening them for any infectious diseases that might come up, STIs, and immunizing as we're able to, and then treating for any infections that come up. Sharing information, meaning like, do you know where there's a safe environment to use? Do you know who your supplier is? Do you trust them? Do you know where there's a close kind of syringe exchange location? Where can you get safe supplies? And how can we support you more? What else can we do? This is kind of a growth mindset area for us as providers, as clinicians, to think about, what have we learned from our patients? How can we do better by the next patients we see? And always, always continual learning. All right, I know that we are basically at time. This is what we talked about today: approach to diagnosing substance use disorder, first line medications, specifically evidence-based medications, and then a few harm reduction strategies. Would love for us to take a minute to kind of think about, visualize that patient that we visualized at the beginning, and think about, what can I do differently next time I'm seeing that patient, whether they have alcohol use disorder, whether they have stimulant use disorder. What can I talk about with them that might be a new practice for me, something different? What can I share with a colleague too? I want y'all to kind of really take that in and maybe spend like 15 seconds thinking about that, and then I will stop sharing screen. All right, let's get back here. Priscilla, I know it's 10 o'clock, and I'm sure other people need to join, but I just wanted to see if there was any questions, and I can also drop my email in the chat too, if that would be helpful.
Well, I don't have a question necessarily, but I would just like to say thank you so much. I know a lot of us are students and we don't get a lot of this very concrete like techniques in school. So I really appreciate it. And thank you for, that was going to be my other thing, was whether or not you could drop your email. So thank you.
Yeah, of course. Thanks, Jordan. There's a lot of, things that we obviously didn't cover. We were kind of like zooming in on the alcohol and stimulants. And I think the goal, as I'm mentioning, I'm a bit of a like evangelist relative to podcasts, because I feel like we have so much time in our commute or other things where we can kind of get in the zone that way. So I might encourage y'all to think about like combining this type of session with an episode to really maximize that learning.
Well, thank you so much, Era. I really appreciate you taking the time to talk to students. And like another student said, there's not been as much of a push for substance use education in medical school, maybe as there should be. So again, we just really appreciate you sharing your knowledge with us. And like everyone said in the chat, we really appreciate it. And this has been a wonderful talk. So thank you so much.
Awesome. Thanks, y'all. Have a great Saturday. Bye.
So for anyone who is still on or just arriving for the Addiction Psychiatry Fellowship panel, I think we're still waiting for two of our fellowship directors to join. So I think we'll be probably starting at about 10:05. I think that's what we're going to aim for, just to give everyone a chance to take a bathroom break, and anyone else who is planning on joining.
Hello.
Morning or afternoon. Is it still morning for you or is it afternoon? I know there's probably 5.
It is still morning here.
Okay. I think we're still waiting on Dr. Foster. I'm going to make sure she has the correct Zoom link. But I think if she's not on by 10:05, we can just start with introduction. And then when she joins on, then she can introduce herself.
Hey, Alexis.
Hello.
How are you?
I'm okay. How are you?
Good.
Oh, come on, cat. Go away.
Dr. Vito, I think it's totally okay if your cat jumps in too. I think I heard you saying, "Go away, cat," but
Yeah.
definitely think
No,
the
there's 2
students-
here. Yeah.
Definitely think we'd be okay with a cat
Yeah.
photo bombing or whatever. Okay, well, why don't we go ahead and let's get started. So who would like to start introducing themselves first?
I don't think it doesn't matter to me, that's for sure. So just let us know what
Okay.
order you want to go
You go, Alexis.
Okay.
in. Okay. You want me to go ahead and start?
Yeah, go ahead.
Okay. So hi, I'm Dr. Alexis Ritvo. I am an assistant professor at the University of Colorado, where I'm also the Addiction Psychiatry Fellowship Director, and then do a lot of work with the Education Committee at the American Academy of Addiction Psychiatry and helping organize all of our programs across the country to for applications and recruitment and such.
And then you can go ahead.
Yeah, and Dr. Rivo undersells herself. She does a lot of work for the Education Committee and helped revamp how we actually select addiction psychiatry fellows. So I'm Jonathan Buholtz. I'm the fellowship director at the University of Washington in Seattle. And I am an addiction fellow trained psychiatrist. I've done all of my training at the University of Washington. As you can see, I'm in purple today. I have a little bit of a demented attachment to the university. So thanks for having us here. We're very happy about the interest that the younger generation has in taking care of these patients. And so thank you for your interest.
Yes, so thank you so much for being here. I know there's a lot of increased interest in addiction medicine, addiction psychiatry. So I wanted to give students the chance to ask any questions you have for Dr. Ritvo or Dr. Buholtz about their careers, or also just what it's like to be an addiction psychiatry fellowship director, or any other questions you might have. And feel free to raise your hand or put your question in the chat, and then I can read out the question for you.
Good morning. Sorry about the delay.
Dr. Foster, would you like to introduce yourself? We were just starting with introduction, so you're totally on time.
Okay, I'm Bella Elizabeth Foster. I'm the program director for addiction psychiatry at University of New Mexico. I am a child and adolescent addiction psychiatrist, so I'm triple boarded, and I'm glad to be here.
So I have a question for Dr. Vito. So how did you get started with AAAP? So I recently joined and I'm going to the annual conference, but it sounds like you're pretty involved, and I was just wondering what that process looked like for you.
Yeah, so definitely encourage everyone to get involved as medical students, and then as residents. They make the membership for medical students and residents fairly inexpensive. I don't know, I can't remember, it's something like $40. It might be a little more for residents. There's also, I think as a medical student, I applied and got one of the travel scholarships to go to the annual meeting. So the annual meeting right now is always the beginning of December. They keep talking about maybe moving it because it's a kind of right in the middle of the holidays, and usually alternates between being on the West Coast and the East Coast. And there's a lot of opportunities for trainees to get support, financial support to attend, whether that's presenting a poster or a case conference, as well as just there's regional awards, and then there's some bigger national awards, and usually you have someone, a mentor, write a letter of support. So definitely encourage that, as well as if you're a member, you get free access to a lot of the learning opportunities that AAAP has, including we're part of Dr. Bocos and I believe New Mexico is often participating. There's a monthly psychotherapy curriculum, addiction psychotherapy curriculum, that is both live streamed like a Wednesday once a month, as well as recorded. And they've put together kind of national leaders in different areas of therapies related to addiction. So there's a lot of really great opportunities through AAAP. And then within AAAP, there's a bunch of different work groups. Most of the fellowship directors are at least part of the education committee, which kind of has a subgroup for the fellowship directors. But then there's a bunch of other areas of interest, and you just kind of write one of the coordinators for the group, say you're interested, get on their email list, and you can attend their monthly or quarterly group meetings.
So Hope Van Buren has a question. What drove you to addiction psychiatry as a career? And then what do you like most about the job? And I think this is a question that everyone on this panel can answer, might have, a different story. So it'd be great if everyone could go around and share a little bit about that.
Dr. Foster, do you want to go?
Sure. So I kind of have a unique entry into addiction psychiatry. I was a child and adolescent psychiatrist for 10 years. I worked 5 years on the Navajo Indian Reservation in Chinle, Arizona. And then I did 5 years in Marshfield, Wisconsin. I think that when you're I wasn't a typical child and adolescent psychiatrist in the sense that I liked the full spectrum. I worked in a clinic that was, provided consults for geriatric psychiatry all the way to my child and adolescent panel. But what I found after a while is that the patient that brought the most interest, challenge to me was patients that had substance use disorder, and that wherever I went, I ended up in that area. Like if it was an inpatient unit, nobody else wanted to cover the addiction psychiatrist when they went on leave. So that was sort of my way. So after 10 years, I returned to New Mexico and did an addiction fellowship. I like the education. I like the science. It was one of those areas where there was so much science that I felt like when I said, okay, naltrexone is going to decrease your drinking, I knew that that would be true for all the patients, not, okay, here's sertraline, that might not work, we'll try fluoxetine. And so I really liked that kind of like I could offer something. And then finally, in terms of education, it's the most challenging because the first thing you work with is stigma, from the medical students all the way up to the residents that have required rotations. I find working with that the most satisfying and then moving on to helping residents see that there's a future of incorporating addiction medicine into your normal general psychiatry or child and adolescent psychiatry fellowship. So that's kind of my long-term goal, is to graduate residents that really see substance use as a part of their practice and integrate it into their practice versus separating it out.
So I'll go next. I came into addictions work actually prior to medical school. I worked in shelters for people experiencing homelessness. Primarily actually started a shelter for youth experiencing homelessness in Seattle, and I became the director of that. And I knew that was the patient population that I wanted to work with in medical school, and I didn't really know exactly how I was going to get there. And I considered family medicine, I considered internal medicine and psychiatry, and it just, for me, came to the fact that I was really more interested in the complex biopsychosocial interplay of patients' life stories and how that manifests. And so the substance use aspect for me is, as Dr. Foster said, just one of the most interesting things, because you see kind of the crux of all of the biology, sociology, and behavioral aspects of patients come together. And substance use is kind of the great equalizer. So we a lot of times talk about how much people return to use and how challenging that can be, but you also, on the opposite end, see people who are really, really impaired by their substance use get treatment and actually then go on to live very successful, very enriching lives. And so that delta in terms of how much you can help somebody is pretty remarkable in the field.
I will echo, I think, a lot of the things they've had to say. So I had some, I guess, lens into it from an early age, because my father is also an addiction psychiatrist and was the first addiction psychiatry fellowship director at Colorado. So I haven't done much original, but I could tell, that he found the field extremely engaging and fulfilling. Worked at the city county hospital for several decades, and then eventually at our facility with our affiliated with our university hospital. And I think, these are kind of the most, as in my when I was doing a master's in public health and doing some stuff with a psychiatrist, he said, well, if psychiatry is the black sheep of medicine, then addiction's the black sheep of psychiatry. So these are often the patients that that people struggle to kind of engage with and to check their own stigma against these individuals. And yet I actually find that they are, if you can engage them and you can make them feel like you genuinely care, curious, and have hope for them, that they do get better, and they do often turn their lives around, and that if they can have a positive therapeutic relationship and feel like you actually see them for more than just their addiction, you can really just see people really change things, and then that helps give you the fuel to hang in there with the folks that continue to really struggle or have difficulty getting into recovery. I find it's super rewarding to get to teach in this area, whether it's medical students, residents, the fellows, and actually colleagues. So most of my clinical work is embedded in just a general psychiatry clinic with our residents. And I think in this, 6 years that I've done that, to get to see some of the shift from kind of the feeling of oh, we can't help with those patients. They need to go somewhere else for their care, to, oh, well, let's talk to Dr. Ritvo about, how we might help this patient, and think about, what we can do here and what we should offer as far as maybe other care. So it's just, there's a ton of opportunity. I think I mean, as evidenced by this panel, I like that both locally and nationally, it's a very open, collaborative group of colleagues. And everyone's kind of in it together. And that's been, I think, is absolutely necessary, especially when working in a field where at times you can, deal with some difficult patients that are having great difficulty, and or we have a lot of good outcomes, but we also have bad outcomes. So.
So in the chat, there's a question from Brooke Mannion. What are some exciting, interesting changes that you foresee happening or are happening right now in the field of addiction psychiatry?
Jonathan, do you want to start? I realize I don't know if you prefer Jonathan or John.
Jonathan.
Okay.
I think that the things about being in the field of addiction that are exciting are the need to be adaptive and nimble, because the substance use landscape changes very frequently. And, I think right now, I don't know that exciting is the right term, but fentanyl is, ravaging the country, and our treatments for opioid use disorder, particularly in the era of heroin, are really successful. And so methadone and buprenorphine, both wildly successful with those substances. And fentanyl is causing more problems, and our need to actually think on our feet and do some innovative things with the treatments of substance use in that field, in that area, I think is really interesting and also challenging. I think that, as Dr. Foster said, one of the really cool things about addiction work is that we actually have a foundation and a basis of understanding of some of the reward pathways that we can really intervene on with medications that work. So, new medications will continue to come out, but I think for me, the exciting thing that will take some time is the recognition of health systems and education like this one, of the recognition that we need to actually increase our support for substance use treatment and integrate substance use treatment into more mainstream approaches, particularly psychiatry. I am of the strong belief that every psychiatrist in the country should be able to do this work and understand how to do this work. Yeah, that's what I would say.
Feel free to go, Dr. Foster.
Okay, you can call me Bella Elizabeth.
Okay.
So I'm kind of a little bit different. I like the controversial areas. First, I'll talk about methamphetamine use disorder. The idea that we can do contingency management and that can be successful, and having been part of a program where it has been successful, where now insurance companies don't feel like they should pay for it. So instead of kind of having a movement to incorporating contingency management into our programs, I find that we're moving more away from that, and people get discouraged about treating methamphetamine use disorder. And so there's all this debate about using amphetamines to treat methamphetamine disorder. And, we have different feelings about that. All of a sudden, I'm in this clinic where patients with methamphetamine use disorder all have ADHD or treatment-resistant depression. And I feel like we're really pushing the boundaries. And I think that there's pros and cons about that. And I like the debate. I mean, I'm kind of really solid down the line. I'm not someone who's gonna prescribe that. And I have like multiple, I mean, that's an FDA not approved treatment. And that's on one side of it, because I don't want to push the boundaries in something that has consequences that we don't know. The other side is just the psilocybin research that's coming out of UNM. It's that we have programs, we're going to do studies. It's not all FDA approved yet, but being a part of that and seeing the future is, you know, I don't know, you're right. I don't know the right word is exciting, but it's an example of how in addiction psychiatry, it's always growing. And I don't get bored. I'm not treating an 8-year-old with generalized anxiety disorder over and over again. It's like I go to work and there are no common, you hear new stories every day, and new opportunities.
Yeah, I would just echo that. I mean, to see the landscape change from, I mean, I know my father would talk about, like, you know, what a huge opportunity buprenorphine provided in the early 2000s, and then starting in 2017 being able to have monthly injectable buprenorphine has like been a huge opportunity for a lot of patients, both helping them stay on the medication and also allowing an opportunity for patients to taper off in a much more manageable and tolerated way if and when they choose to, as well as helping people if they end up incarcerated not go through horrible withdrawal. Like, just so many ways that it keeps expanding what we can offer patients. I know they're doing some research here at Colorado on the like the GLP-1 medications, so like the Ozempic, because they saw that so many people that were on those for weight loss ended up not having any, you know, minimal or little desire to drink. So I know they're looking at that for alcohol use disorder. I agree. I think methamphetamine use, whoever can figure out some good evidence-based treatment medicine, because we do, the contingency management can be quite successful, but it can be hard to get support for. So yeah, it's a field of great opportunity. I know someone asked about, like, what do you do for the use disorders that don't yet have like an FDA approved indication? And I think, I mean, a lot of times what you're doing is, you know, you're always assessing what are the other co-occurring disorders. How do I try to adequately support and treat those simultaneously? How do I get them engaged in psychosocial support, whether, you know, individual psychotherapy, some sort of recovery community, and that can take many different forms. For some people, that's a, you know, traditional 12-step, but we have a lot of other opportunities. And I think just them, you know, trying to really impart on people how important social connection and support is, and that often is one of the things that they start to lose or have lost in the setting of their addiction. And without that connection, kind of further breed the shame and stigma of your use, and it kind of feeds itself. So I think, you know, when we don't have FDA approved medications, you have a lot of other ways to try to address things and try to, you know, we have a lot of good evidence-based psychotherapies. And so there's still a lot of ways that we can help our patients, while still, you know, having research going on in all sorts of areas to see what else we can find that will be useful.
So Pranav has their hand raised, and then after that, there's I got a direct message about a question. So we'll answer Pranav's question first, and then we can go with Grant. And then I know is it Ramona? Yes. So Ramona, you had a question, but I think Dr. Vito pretty much covered it. So if you don't mind, I think we'll go with Pranav's question now.
I just had a general question. I know there's like other paths to addiction medicine, and I'm a little bit familiar with that. You know, you can do addiction medicine fellowship, doing after like a non-psychiatry specialization. So, like, how would you say that addiction psychiatry differs in its scope in like what you can do with your patients and then what you can do for your patients?
Well, I'll try to dig up. There's like 1 or 2 articles. One I co-wrote with someone, and then a longer one that some other AAAP folks wrote about kind of this. I'll be curious what my colleagues here have to say too. I mean, we're a little biased, right? We're psychiatrists, so we actually in our program, as I think is similar in many others, do a lot of work with our addiction medicine fellowship. We do a lot of our didactics together, and it's really nice because you have all these different areas of expertise. I think, you know, and you can apply in both. That's actually, so we join the match, and specifically join the match with the medical and pediatric specialties so that psychiatry residents would have the opportunity to apply to both addiction psychiatry and addiction medicine fellowships that you, on the same match date, and could rank both. Addiction psychiatry has the benefit, I mean, we are the experts in evaluating and treating and managing co-occurring disorders. So the substance use disorders and the other psychiatric disorders. And I think really trying to, you know, understand that biopsychosocial interplay in a way that, depending on our medicine colleagues' backgrounds and training, they may not feel as comfortable with or have as much experience with. I certainly know some that, you know, I kind of consider almost psychiatrists, but others that don't feel as comfortable kind of in trying to address those both simultaneously. So I'd say that is the real, you know, with even more focus on the different psychotherapies and treating, evaluating those co-occurring disorders. I don't know what Elizabeth and Jonathan think.
So this is kind of a problem, and thank you for the question. We had residents that were going along the ASAM practice pathway. And it was interesting because I actually was able to recruit somebody that was headed down that way, because I feel like so many of the patients are dual diagnosis. And when you look at the focus of addiction medicine versus addiction psychiatry, we kind of divide up the didactics. The first 6 months is set up by the addiction medicine, and the next is set up by addiction psychiatry. And we were just discussing motivational interviewing, and there were 2 lectures on it. And then I'm starting our didactic series with 4 on MI. And it's actually in the classroom, role modeling, practicing, and you can really see the difference between that interest by the addiction medicine people to learn more about the psychiatry piece. Whereas with the addiction psychiatry residencies, I don't know if that fellowship, I don't know if that's in your programs, but we have what's called the medical walk-in. So all of the fellows are doing alcohol and outpatient detox, inpatient. And so we are able to do both. And I think the idea that addiction medicine are the people that are going to manage, you know, outpatient withdrawal, and addiction psychiatry is going to work with the dual diagnosis. We just have an integrated program. So I think doing addiction psychiatry allows you to continue to grow your psychiatric piece and know that the medical piece is going to happen. Whereas I think it's harder for addiction medicine to develop the psychiatry skills needed to work with dual diagnosis patients, which is pretty much like what 95% of all the patients we see.
So I definitely agree with both. And the other thing, just in terms of the different sort of national group. So AAAP is psychiatry. There also is the American Society of Addiction Medicine, which is more of a internal medicine, family medicine folks who do work with patients experiencing addictions. I think the other thing is, you know, psychiatrists, I mean, we're trained in psychiatry, right? So when we're taking care of a patient, we think about the psychiatric aspects, we think about the substance use aspects. And addiction medicine really has just the sort of approach of primary care, right? Or of internal medical care. So though patients may be getting naltrexone from addiction psychiatrist or an addiction medicine person, you're still thinking about a pathway to what you're interested in how you take care of patients. Do you want to, be responsible for cardiovascular management and management of patients' diabetes and things like that? Or are you more interested in the psychiatric issues, depression, anxiety? And these patients have both, right? So as Bella Elizabeth said, and Alexis said, when you get into this work with, especially with patients who have severe disorders, and a lot of people who experience substance use disorders never even come to a medical attention. But the patients who do have a higher sort of severity in their disease, and I think we would all sort of agree, the more work you do in this, the more you recognize that these patients have substance use disorders, but underneath all of it is psychiatric disorders, is trauma, is difficulty in coping with the world that has a lot to do with development. And a psychiatrist in your training, really, that's how we view patients, because we think about life stories and we think about the context of the environment and the social aspects and the behavioral aspects to someone's life. And that tracks along incredibly well for how you actually conceptualize substance use, in terms of not only the severity, but what behaviors are occurring, right? You can put patients on medications and sometimes they work and sometimes they don't. And to understand why they work and why they don't often comes down to what else is going on and what other kind of challenges. And those are often psychiatric ones. And so obviously we are biased, but when I do teaching with psychiatry trainees and medicine trainees, the ones who have psychiatry training have a lot easier time figuring out how all these pieces go together. And addiction medicine, I think the residents are just like very, very eager to learn all of these things. But, as if I tried to manage, somebody's complex COPD, that would not go well. And so when you're trying to manage someone's complex PTSD and substance use, you're a little bit of a fish out of water. So it just depends on what you want to do. If you want to be a primary care doctor or an internal medicine or family medicine physician, you can go that route and work with these patients and help them. If you want to be a psychiatrist, you can go that route and help these patients.
Thank you.
I would add a little bit in terms of the difference between AAAP and ASAM. I feel like they're, in terms of just kind of the comparison and the educational opportunities, the diversity, the size of the organization, ASAM really stands out. AAAP is kind of getting swallowed alive by the growing ASAM aspect, which I think will kind of change because they're recognizing that the practice pathway is actually going to be going away and there's going to be more focus on fellowship. And I feel like with that addiction medicine fellowship, if you don't have it paired with an addiction psychiatry fellowship, it can take you down a totally different path. And so I am drawn to the ASAM and incorporate both, but I wish that the ASAM and AAAP worked better together so the ASAM organization had more ability to incorporate the psychiatric co-occurring diagnosis in their didactics.
One thing that I would add, I don't think we mentioned this, is if you're a psychiatry resident, you can apply for addiction medicine or addiction psychiatry. if you're an internal medicine person, you cannot apply for addiction psychiatry. You have to have psychiatry training in your residency to do our fellowship.
And as an addiction psychiatrist, you can also belong, I mean, even if you get boarded in addiction psychiatry, as we have, I belong to both ASAM and AAAP, in part because, yeah, ASAM is much bigger. They're able to do some policy work and other stuff that AAAP just isn't able to do quite as much because they just don't have the size and complexity. And I'd say, I don't know about currently, but in the past, I mean, ASAM was probably about somewhere around a third or 40% psychiatrists.
And if anyone has more questions about AAAP, we have a talk this afternoon with Dr. Vito and Michelle Dirst, who are very involved with AAAP. I know Dr. Vito, you are as well, but they could answer a lot of your questions. Specifically, the talk is actually about AAAP's advocacy efforts, but they're both very great people and will be very happy to answer any questions. And then there's a question in the chat about Iboga or Ibogaine for substance use disorder. I personally have not heard of that, but the student
Ibogaine.
is Ibogaine. Yeah, if you have any input about that or thoughts, Grant Haley would love to know more about that.
I don't know if I think as New Mexico have been.
I was
doing
gonna
some
say New
research, I don't know
Mexico.
about Washington.
We don't want to put you on the spot.
Yeah.
But
I think it's so new. And I feel like there's basically what I have to say about it is that, yeah, that's one of those things that's further along in the process, and being a part of it to discover it is interesting, but it really isn't. It's at such an early research stage that the best part is to teach yourself about it and kind of, if you haven't, look for areas that you would like to be involved in. So it's a good example of it's at the ground level, then move on. And you could be a part of that movement, just like, you know, other things are happening in addiction psychiatry. If that's a vague enough answer.
And it's, I mean, for others, it's another one of the psychedelics that's being used to, and evaluated for treating psychiatric conditions, including substance use disorders, along with psilocybin and MMDA.
yeah,
Can't get all my letters right.
I think the other part of this is, there is research being done, but because of legalities around these and the history of psychedelic research kind of going sideways in the 60s and then being fairly demonized in the Nixon administration, we're further behind than we probably could have been. And the way that some of this is happening is that people have been using these substances for, sometimes thousands of years. And so there's cultural aspects where people are doing this, really not knowing for sure how or to what degree to use. And so it's not actually terribly evidence-based yet when it comes to how should we be doing it, what kind of protocols should be done. So there's a lot of these private entities where our patients are, flying to Mexico or going somewhere, and not all of them are bad, not all of them are good, but there's high variability in this, and I think that we need to pump the brakes a little bit in patients going out and just doing it right now, as much as there is a huge, I think, potential for psychedelics moving forward to help patients with substance use and depression and other psychiatric disorders like PTSD. But if we don't do this in a scientific way and really get some good data, my worry is that people will have bad experiences, and that can derail some of these processes. Ibogaine, for instance, if done correctly and in the right setting, can be very, life-changing for people, but that it also is fairly traumatic at times. And people can get really sick, and that's kind of the part of the process. And if you're not with somebody who understands what's going on, and or if you have a psychiatric history, including psychosis or bipolar disorder, there's some risks. So I'm very encouraged. New Mexico's ahead of us in terms of the infrastructure for the research. We started a psychedelic center 3 years ago, and so we're trying to catch up. And I think a lot of different universities across the country will continue to get involved in this space, but we're not fully there yet.
I guess, I think when I saw that question, I was thinking about it in a totally different way, obviously, because what I find is that as we're learning and in addiction psychiatry, there's sort of like psilocybin, you grab onto one thing, and there are people that are attracted to our program because that's happening in New Mexico. And so without really understanding, sort of caught up in the media idea, Oregon has passed laws. We're going to start doing that with people that aren't trained. And so I do really encourage, if that like stimulates you, that idea to do the research, because that's kind of how the interest to me, or the forefront, began in addiction psychiatry. And that's one of the things that you're like, oh, I could be that. I could learn about that, but you can also be the person that can explain the pros and the cons and how it impacts patients. So you can be a reasonable resource to, the people in your community, your patients. I feel like our research is behind, again, very similar to what happened with marijuana, is the world around us our research is kind of lagging. And we don't have the information to give our patients. I have patients, well, would you recommend X? And I can go to Oregon. Why can't I go to New Mexico? And so we have to be able to really understand it and know the evidence so that we can explain it to our colleagues and our patients who are interested. I would like to add one thing, and I know that it's not a question, but I'd really like to talk about just briefly about burnout and how that you say fresh in addiction psychiatry. Would that be a topic briefly? Okay. So, yeah. Okay. So I had this eye-opening experience because we're interviewing residents right now. And one of the things is I have a resident that is really interested in addiction psychiatry, a medical student, and, is like what you would like, someone who's got a lot of experience and has no basically volunteer work. What is their volunteer work? And it was so interesting to me because I thought, do you know what I do for a living? I'm an addiction psychiatrist. And I just feel like the way that I stay fresh and I enjoy teaching is I come home and I watch, Korean dramas, and I don't spend time with other people. And the idea that I would be volunteering, and this just happened yesterday, was just like, whoa, I'm not going to not pay attention to this candidate because they don't they don't volunteer. And so I don't know what you guys both do, but I feel like it's a really important question. We're asking these days, work-life balance. And I think that that's really hard for my generation of psychiatry and addiction psychiatry. So I have to build in those things. And it's something to really think about as you explore this profession, because I think the burnout rate is a lot higher than other areas of psychiatry.
Yeah, I mean, I would just echo, I think both making sure you have good supports. I mean, I think this is similar to others in psychiatry, and maybe even more so, we're making sure you have those colleagues to lean on and process things with and share some of that sense of responsibility. And then outside of work, really trying to make sure you make space for other things in your life, because you will burn out if you only have it revolve around your work. I mean, I have 3 small kids at home, so that makes it hard for doing things that aren't related to them, but even trying to, through that, whether it's getting outside or going to different events, connecting with friends and neighbors. I mean, you need to have a life that isn't just defined by your work.
I think I would add to that, and both of those things are very relevant for me as well. There's a personality type too, in terms of, if you went to medical school to be the person who knows the answer, who's going to fix the problem, that's orthopedic surgery. This is a chronic disease model. And one of the things that medical school sometimes doesn't prepare you for is the reality of medicine in taking care of patients who have chronic diseases, that you're not curing disease, you are healing. And part of that is a process that includes ups and downs and good things and bad things, but it's I think a field that if you can be alongside your patient and not actually feel responsible for everything that occurs, because you can do only so much in these situations. And if you are a person who's more sort of on the side of like, I want the diagnostic picture here, and then I'm going to solve the problem, infectious disease for you, not addiction work. And so I think I think the people who do well and stay in the field have that kind of mindset and have that understanding. So just to be aware of that when you're approaching this work.
I would add to that one of the best things is the people that are drawn to addiction psychiatry. I find that my personality fits, even though like there'll be big debates like right now, Adderall for meth. Although there's big debates, we come together, and when there's a difficult patient, we support each other. And right now, fentanyl overdoses are really showing me, because it's like consistent 1 or 2 patients easily in a week that have died from overdoses, or family members that have lost family that we work with. So I think that's the 2 things: the sense of humor, the sense of colleagues, or 3, and just the ability to support each other. We have to be able to do that for each other. And if you like that collaborative aspect of it, of team teaching and being in that room, I think this is really a good field for you.
So I think we have about 5 more minutes left. If anybody has been holding on to a question for the past hour and has been waiting to ask it. Okay, well, I can ask a question. Maybe it's a little bit more general, but I know some people are in interview season right now, and 3rd years will be, I guess, applying in the next few months or so. Everyone here is interested in addiction and psychiatry. So just thinking about residency, how do you kind of parse out which programs actually have good experiences and exposure to treating people with substance use, dual diagnosis? I'm assuming if there's a fellowship program, that would probably make sense. What about for community programs, or if they don't have an addiction fellowship?
I mean, I would, and I can try to find it, Priscilla, you might be able to find it on the AAAP Addiction Psychiatry Fellowship page. There's a map that has pins of where all the programs are across the country, and that's a good way to then look up those programs. So yeah, certainly if a residency has a program, they're more likely to have, more faculty and sites. Certainly you can also, see if there's a fellowship program in the area that you're in. Asking what the addiction psychiatry rotations are, because it is a required experience for psychiatry residency. So what those opportunities are, and connecting with those faculty members. And then I think, even if it's not as robust, but you like other aspects of the program where it is, then looking for those opportunities through AAAP, ASAM, for mentorship and connection. I mean, I think a lot of people are working on various projects, or would be happy to connect with someone that might be interested in fellowship in the future.
Additionally, I think the worry that you might have about going to a residency program that doesn't have addiction training, I think that is a totally reasonable worry, and everything Alexis just said is totally relevant. But also to know that if you have your own interest in this, the patients exist. I promise you they're there. And you can, be an advocate, and you can go to AAAP, and you can, learn more about these things. And when it comes time to doing a fellowship, we have plenty of places for you to go. Every year, we actually have more open positions for addiction psychiatry than we have applicants. And that's something really important to recognize and to know. And that's an unfortunate part of the current sort of climate of what's happening in the field of addiction. We're getting more people interested, but don't be worried that you're not going to be able to be an addiction psychiatrist if you go to a program that doesn't have a robust addiction program built into it. Because if you are interested, there will be a place for you somewhere.
Oh, I think you ended up muted.
I would also add, our program is very, we're everywhere, starts in medical school, a lot of experience. But such that we have had 2 addiction fellows leave New Mexico. We've encouraged them to do their fellowship. Like, one went to UT, one went to San Diego, because, both of them could have run our major program. And so we do like to encourage people. So pick where your residency is. It's 4 years. Don't go somewhere where you're going to, have to grit your teeth for 4 years. And like you said, I encourage you to plan to go somewhere where it's not your institution. And if you put that in your plan to begin with, it can help you go, okay, I want to go to UC Davis, but I want to do my addiction training in New Mexico. That's different ways that you can look at it. But debt is really a problem for us, because there are people that are very much interested in it by the time you get to your 4th year and you're looking at your loans and you're looking at how much money you can make, that can be, a disadvantage for addiction fellows. So if you really want to do addiction psychiatry, but that is kind of pulling on you, pick a program that has a strong addiction psychiatry, because in the end, you might not have the privilege and the financial ability to do addiction psychiatry, no matter your interest and love of it. So, you got to weigh those 2 things. Do you have an invisible house payment when you graduate, and that's going to pull you? So pick according to that.
And also, look, there are increasingly, loan repayment programs that do look for I mean, that specifically for folks that are going to work in addiction. Certainly the VA has them as well. I had one fellow that I let do half time so they could start some of their loan repayment program with one of the HRSA or Health Service Corps programs. So, you know, places are often want to and will try to be flexible with you. And we're trying through AAAP to try to connect and publicize more about those opportunities, because we do know that debt is a big driver of deciding not to do a fellowship.
Well, I think we are just about out of time, but thank you so much for joining. I know all the students learned so much today, and it looks like y'all put your emails in the chat, so if there are any further questions, yeah, but thank you so much. I really appreciate you taking the time to talk to students.
Have a great weekend and Thanksgiving holiday.
Have a good match, everybody. We wish you the best.
Yes, fingers crossed. Bye.
Take care. Thank you.
Hi, Dr. Suzuki. So we just finished up our last session. So I think I'm going to give everyone just a minute or two to go to the bathroom or just, you know, get some water, anything like that. And then I think a few people might be joining on.
Sure. Just let me know when you want me to start.
Okay, wonderful. And I made you a co-host, so you should be able to share your screen as well. If there's any issues, just let me know. And then I'm going to monitor the chat.
Priscilla, are you seeing? I'm just wanting to make sure that I can share my screen. Is it coming through?
So it is coming through. It's not in full present. Okay, there we go. And then I know you have a lot of slides, so why don't we go ahead and start? And then if anybody joins on later, they can always watch the recording if they missed anything.
And then are you seeing the correct? I have multiple monitors, so are you seeing the correct screen?
Yes, it's the motivational interviewing PowerPoint.
Right, so not the presenter side, right?
Nope, not the presenter side. It's the presented view.
Right. Okay, good. So should I get started?
Yeah, that would be great. Thank you.
Well, thank you so much for the invitation. I'm really excited to be here, and I'm very impressed when folks do weekend stuff. I'm sure everybody's very busy and a lot of things to do. And it's always nice to have a group of students interested in psychiatry. And I did catch you just the tail end of the last, part talking about addiction psychiatry. There is a tremendous need for more addiction specialists, whether it's addiction medicine or addiction psychiatry. And I can't guarantee that the job landscape will look good, but I'm going to make a guess that, even at the time that you guys are finishing residency, 3, 4, 5 years from now, there will be still remaining a tremendous, need for additional addiction specialists. And so I always tell my fellows that each graduating fellow, there's a tremendous recruitment that occurs. And so I know that student loans, of course, those things are a concern, but job security is largely guaranteed for a very long time. Unfortunately, the need for this treatment is gonna stick around for a long time. Now, so I'm delighted to be able to talk about motivational reviewing, because I think it ties in really nicely with the practice of addiction, psychiatry, or any addiction related. However, I would argue that motivational reviewing is a foundational skill set for any healthcare provider, particularly anybody who's in the business of helping individuals change behavior. And I would argue, and the evidence base will support this, that excuse me, motivational reviewing is probably the most evidence-based approach in helping patients change behavior. There are many ways to do it. Motivational reviewing is not the only one. However, I would argue that this is, one of the most evidence-based. It's been researched for 30 or 40 years, and it's empirically based, meaning it's not just a theory that somebody came up with. That's how it started, but it's been tested and retested for decades. It's one of the most highly researched behavioral health, behavior change strategy that exists in healthcare today. If there's something else, I'd love to know because I'd love to learn it. So for all residents and fellows, I would argue this is a critical skill set to learn. So what I'm going to provide today is a very brief overview. You can't learn motivational reviewing in an hour. In fact, it takes practice. Like any other psychotherapeutic strategy, it's going to take practice and feedback. And hopefully many of you have had some exposure during medical school and then during residency. But the reality is, I run a fellowship program, and I rarely meet residents who are actually competent in motivational reviewing. It takes a lot of time and practice, and it's typically in the fellowship time. There are some residencies that provide really good training in motivational reviewing, but it's actually still remains largely uncommon. And so this is just a exposure. It could be a review for some of you, and I'm hoping that many of you will continue to learn this during a residency and beyond. Yeah. Let's keep moving on. So I don't have no financial disclosures. I don't get paid by companies that do motivational reviewing. I do run training courses, although not since COVID. I haven't been doing any of the workshops that we used to run at least twice a year. But regardless, I make no money teaching motivational reviewing. But I do get grant funding from the NIH. That's largely my role today. So the objectives for today for us is to go over two things mainly. One is to really describe the spirit and the four processes of motivational reviewing, and then really kind of hone in on this concept of change talk, which is sort of features prominently in this sort of when we try to understand what we're trying to do in motivational reviewing. So let's start here. What is motivational reviewing? It's actually pretty simply defined today, and it's considered a form of communication. It's not like a script that you read. It's not a protocol necessarily. There aren't treatment manuals per se. And so when people initially want to learn about motivational, they're a little confused because they think it's a group of questions you ask, or you trick people to do something, or do pros and cons. And all those things are somewhat true, but it's really about how to be with another human being. It's how to communicate. And it's really, if you had to really pin it down, it's sort of a guiding style of communication. And when you think about ways of talking to your patients, for example, one way, on one spectrum, one extreme of it is to be very directive, prescriptive. You're telling them what to do. And this is actually required in certain situations. If you're in the hospital, I'm sure you've done your clerkships, many of you, and somebody is in the hospital for some serious life-threatening illness. They had a heart attack. They need some emergent surgery, whatever. Patients play a little bit more of a passive role. You're the one diagnosing. You're the one helping to come up with a treatment plan. And in the most extreme case, for example, if somebody's suicidal in the emergency room, I have to force treatment on them, even if they want to go home. I might not be able to. So the more acute the situation, the more emergent the situation, the more we're required and obligated to be prescriptive and directive. And so there are times when we're required to be that. But in healthcare, most of healthcare actually occurs outside the hospital. And so if you're managing diabetes, hypertension, or mood disorders, or anxiety disorders, or substance use disorders, simply telling patients what to do and giving them advice alone is not going to cut it. I wish it were. Then our jobs would be a lot easier. We just tell them what to do and they do it. But the reality is, and clinicians, and you all have experiences already, is that simply telling the patients what to do is not enough. There are patients who will follow your advice and guidelines and advice, great. But motivational reviewing is needed because for many patients, they first have to have the desire, the motivation to actually engage in that whatever treatment that you're recommending. And this is where the guiding style really comes into play. That we're not, it's sort of a, there's a certain directionality to what we're recommending. For example, I'm always going to recommend less heroin use. I'm never going to recommend more heroin or more, methamphetamine, more alcohol. We're always going to be recommending, a certain direction. So the directionality to things but I can't just force it on people. And so that's really the art of motivation. I mean, how do you, recommend behavior change without forcing it on people, but guiding? And the way to do that is really there's a particular focus on the language of change. And I'll talk more about this concept of change talk. And then finally, ultimately, what we're trying to do is evoke this from the patients, themselves, not our own reasons for change. I know why I wouldn't smoke crack, but that's not important to my patients. It has to be about why they wouldn't want to do certain things or what they're trying to achieve. So this is really how motivation is defined today. It's also helpful. And so, yeah, the directive style of communication is sort of in between this being, I'm sorry, so the guiding style is in between being directive and following. There are times when you follow, like you assert no agenda whatsoever when you've just given bad news, or if you're providing supportive counseling, for example. So there are certain times where you really have no agenda on your own, and so guiding style is sort of in between. Okay, another thing to really point out is what motivation is not. The first thing is that it's not psychotherapy. It can be done in a context of psychotherapy where it's really not the same thing. Again, it's really about how to be with another human being. It's a way of communicating with somebody, and it's really not done as psychotherapy itself. Now, there are situations in which it is the form of therapy, but usually it's not. And that may sound a little confusing, but it's really, you can do motivational reviewing concurrent with anything you do, with your regular medical visits, with your CBT, with pharmacology visits. I'm sure if people here are interested in psychiatry, there's always a split of medication and therapy. The reality is, even if you do just medication work, you're still providing some form of therapy. It's very important to understand that. And so motivation can be done regardless of what you're doing. It can be done in the context of an intake, a consult, emergency room, practice. So it really can be fluidly combined with anything else you're doing. And so it can be combined with psychotherapy, but in and of itself, it's not. Another thing that may be confusing is that I'm sure you've come across this concept of the stage of change model, pre-contemplative, contemplative, et cetera. And that's a very useful model. But it turns out that model is a theory, which then became applied to clinical practice, but largely it's not driven by empirical evidence. And so when it's been used as a clinical practice, it hasn't really been that effective. As a conceptual model, it's really helpful. So that, I still use those terms, pre-contemplative, contemplative, et cetera. But as I'll explain a little bit, and I hope you'll appreciate by the end of this, hour, is that there's a distinct difference between the stage of change model and motivational review. And the key difference is that in motivational reviewing, we account for you, the therapist, the physician, the helper in the room. So the stage of change model does not. And it's simply missing an important part of the behavior change process. Pros and cons, or decisional balance, also can be used in the context of motivational reviewing, but it's not the same thing. Motivational reviewing also is not for every situation, every patient. Like I mentioned, the more, if somebody's bleeding to death in the emergency room, you don't do motivational reviewing, and that's kind of obvious. But it's not for every situation, for every patient. You pick and choose the different tools that you have. And then finally, the most frustrating for me as a trainer is that it's actually not easy to attain competence. It does take practice. Now, there are some individuals who are like kind of naturals at it. I never was. Most people aren't either, and there are some people who are, and I'm really jealous of them. But for most mere mortals, we have to continue to practice and maintain skills, and keep practicing it to develop skills. So it's okay to not feel like you can do this right away. It may be perceived as a relatively straightforward skill set, but it actually is quite complicated and deep. Takes years to master it, but so learnable. That's the beauty of it. It's really a learnable skill. There's a tremendous amount of evidence based on motivation reviewing, like I alluded to. This is one example. This is a systematic review of reviews. Okay, so there's a robust number of trials and reviews and systematic reviews for all kinds of target behaviors, whether it's healthcare related behaviors, substance use, medication adherence, physical exercise, or outside of healthcare too. It's used in criminal justice, correctional settings, education, etc. And so it's used very widely in many fields. But certainly healthcare is where it started. It actually started in substance use treatment settings. And for rather short of the reasons, but when it comes to addressing substance use, motivation is particularly effective. And so if you're going to do any kind of addiction related work, I would argue, and many people would argue, MI is critically important. So what I want to do is actually show a video that really captures the sort of the concept nicely. And actually, I forgot to do the, so let me try this. And then Priscilla, can you let me know if the audio is coming through, the video is coming through?
Yeah.
Is it coming through?
I heard it for a second and then it stopped.
Okay, so let me stop the share. Then I have to always remember to do the thing where I have to share sound. And then some people tell me not to do the optimize for a video clip. Let's try that. All right, let's see. How's that?
That's working.
Okay, full disclosure, today's title is an overstatement, but only a little.
Those of us with a bad habit have probably heard all the guilt, pleading, and logic for change a million times. We're prepared to resist and combat every logical or emotional attack.
Especially smokers. More than most anti-addiction, they've seen the anti-smoking ads, the horrific images of cancerous lungs. Everybody's told them 100 times to just stop. And does it work?
Of course not. So let's look for BS you can use. All right, first let's find some smokers. And a couple of Confederates. In the control condition, we'll have Cole and Josh try the traditional lecture approach.
Excuse me. Hey, you know smoking is bad for you.
Yeah, I know. Yeah. Yeah.
Would you like to know where you can get some help? If you want to quit, then...
Hardly any takers.
Thank you.
90% of the smokers responded resentfully. Just under half even took the paper when it was forced into their hand. So reminding people of something they already know but don't want to think about didn't work.
Now here comes the BS you can use. This time we'll have our intrepid Confederates try something different. We'll replace a tired lecture with an influential question. This time, Cole approaches the subject with a fake cigarette and asks for a light.
How about a light? Why not? Why?
Don't break. You like to move, go fast?
This is fascinating. The adults are now telling the boy why he shouldn't smoke.
It gets even better. Now that the smoker's making the anti-smoking arguments, the kids turn it back to the smoker with an influential question.
So if you care about us, what about you?
Just look at the body language this time as compared to the control condition. You don't see defensiveness, you see openness.
Exactly. In this condition, close to 90% of subjects not only lectured the boys about the evils of smoking, but committed to trying to quit themselves. And it gets even better. One of them saw the boys later and came back to continue the rant.
Take it from me. Every time somebody bring it to you, or you see it, or you see somebody smoking, remember my word. It's not good. But I will quit, for sure, I have to. Otherwise, I will die in air.
Now, the skeptical scientist in me wants to ask, so was that motivation just temporary? Sure, they pocket the paper, but do they actually do anything?
Good question. When Ogilvy and Mather conducted the experiment in Bangkok, calls to the quit line actually went up 40% on the day of the experiment.
Wow.
We don't know if they actually quit, but we do know that their motivation lasted past the interaction.
Yeah, so let's talk about this. Why did that work?
I see a few things going on here, but let's focus on one of them. When you're trying to influence people who need motivation and not information, don't offer more information.
Your only hope is to avoid provoking what psychologists call reactance. The best way to do that is not with speeches, but with questions. Give them a safe environment to explore motivations they already have.
Exactly. The kids' approach allowed the smoker to feel emotionally safe, which allowed them to acknowledge their own ambivalence about their habit.
So I have to reintroduce them to values they already believe in by tricking them with a cute kid or a puppy.
Close. Stop forcing them to take the wrong side of the argument by lecturing them. Instead, use questions to help them explore their own motivations at their own pace. And it works too. Go ahead, try it at home.
So the reason why I like that video, can you hear me? Am I coming through? Okay, good. And so the video came out okay? I just want to make sure.
Yeah, it did.
Okay, good, excellent. The reason why I like that is that it really nicely captures some of the key concepts in motivational learning. Number one is that there are two conditions in that experiment. In the first condition, the kids walk up to the adults, saying something like, "Don't you want to quit smoking? Don't you know it's bad for you?" And so with that comment, the reason why the adults responded the way they did, which is resentfully, they had their guards up. They were really saying, "Get away from me. Who are you to tell me this?" Because they've heard this before. They know that the lecture is going to follow about smoking is bad for you, and it's you're going to get cancer and blah blah blah. They know this already. So underneath, they may have some interest in quitting, but if confronted with this, with this immediate lecture or advice to stop or recommendation for quitting, their reaction is get away from me. Now, in the second condition, the kids don't do that. They approach the adults with something alarming, can I have a light? Of course, that generates its own kind of dynamic. However, the point is, after that comment about can I have a light, they're not expecting the lecture to follow. So in that context, the more honest view of the adult's own ambivalence about their behavior emerges. Now, of course, that's colored by the adult's desire to help the kids. However, the point is, depending on the interpersonal environment that you create, the apparent motivation changes. So in the first condition, I would guarantee you, the vast majority of the adults that walked away resentfully, there's a part of that adult that wants to quit. In fact, that's true for most individuals engaging in unhealthy behaviors. It's pretty unusual to have a patient who says, "I have zero desire to quit smoking." They exist. But actually, again, maybe I didn't say it, but I'm an addiction psychiatrist. So my entire career, that's been what I do, is treat substance use disorders and psychiatric disorders. But it's pretty rare for me to meet a patient where I cannot find any desire to change. That's actually pretty rare. And so depending on the kind of interpersonal context you create, it actually leaves open the possibility for change or not. And so this is precisely why the stage of change model has failed. If you don't account for your influence on the behavior, then you're completely missing it. One of the ways in which we practice motivational learning in the hospital, for example, we just go up to the floor as a team, and then we find smokers. And we simply go into the room and say, I heard you smoke. Would it be okay if we spend 15 minutes talking about your smoking? Now, if I hypothetically walked in and said that and said, "Hey, you need to quit smoking right now. Give me your pack of cigarettes. I'll throw it away. I'll flush it down the toilet. You should never smoke again." What do you think the patient will tell me? Here's a doctor that they've never seen before. Suddenly, he's like lecturing them about quitting smoking. What do you think that patient might tell me? Like, any guess? Well, I'll tell you, it won't be anything nice, like, get out of here. What? Who are you to tell me this, Now, if I walk out of the room, am I allowed to say, "Oh, patient's pre-contemplative"? Right. I mean, it's sort of, obviously how I interact with the patient will influence their apparent motivation. And so in motivational learning, what we're trying to teach is that actually the way we should approach the behavior change discussion is to adopt what's called the spirit of motivational learning. And in a way, if you're able to embody this, you're actually most of the way there doing motivational learning. Because if you're able to really put this into your practice, you are doing most of the motivational learning. And this is actually what's called client-centered sort of approaches. And there's 4 key concepts. And the first is acceptance, then partnership, evocation, compassion. There's a new version of motivation that just came out this fall. And so this is slightly changing, but I think this is still okay to use this. Embedded within the concept of acceptance are 2 main issues. One is respect for autonomy, and the other is accurate empathy. And the 2 things are on the same sort of the two sides of the same coin in a way. Respect for personal autonomy is probably one of the most important things to understand and to be able to embody and demonstrate through your behavior. And it's actually easier said than done. And when I say respect for autonomy, it's sort of like one of those concepts that we assume that we all understand and agree upon, because it's been a dominant theme in sort of Western civilization for several hundred years. This sort of sense of self-determination, right? Nation states and, personal freedom, and like it's a pillar of medical ethics, right? Autonomy, right? So, and nobody's here going to say, oh, Dr. Suzuki, respect for autonomy, that's I don't believe that. No, I think everybody here believes it or agrees it. It's foundational. It's pretty basic stuff. But when it comes to behavior change, it's really about honoring individuals' ability to make decisions that we disagree with, that we need to be okay with. Now, we need to be okay with their ability to make that decision, not the decision itself. So if a patient tells me, hey, doctor, thanks for the advice, but I don't want to take Suboxone for my opioid addiction, I'm not going to say that's great. I think it's great that you keep using heroin. No, I'll say I respect your decision, but I'm still going to recommend that if you change your mind, let's talk more, that sort of thing. Like I can still respect their ability to make decisions. That's at the core of this concept of respecting autonomy. On the flip side is this ability to then understand where they're coming from, to be able to demonstrate that you understand that, and again, this is why it's called accepting it. Whatever decisions our patients make, ultimately we want to be able to accept it and demonstrate a sense of positive regard in a genuine way. And what's paradoxical about behavior change in a way is when we're able to accept people for who they are, even if they're making these poor choices, then they're more willing to listen to you. And that's a sort of paradox of behavior change. The more willing to step back and say, you know what, it's really up to you to make a decision to keep using cocaine or not. And paradoxically, then they're more likely to listen to our advice. And so acceptance, again, it's about respecting autonomy and demonstrating accurate empathy, are two critical ingredients to this concept of acceptance. Partnership is sort of another interesting one. It's the idea that, you're trained to be doctors, you're spending many hours, in classes and clerkships, and so you're becoming an expert. And oftentimes, the dynamic between you and the patient is that of an expert and a novice. And in many situations, that's true. That's actually true. But when it comes to behavior change discussions, a far more effective way to approach this is to actually you don't abandon your expertise as a physician. You're the one who understands diagnostic criteria and treatment plans and practice guidelines and side effects and costs and the evidence base, and that's why you go to school. That's why you train for many years. You don't have to abandon your expertise. However, when it comes to behavior change, patients themselves must become the expert in how to implement the recommendations. I used to be a smoker. When I quit smoking, my doctors did not do it for me. I had to do it. So I quit smoking. I'm the one who had to suffer through the withdrawal. I'm the one who did it. So I had to be the expert on how to quit smoking. No, so my physicians and others help me, of course, but ultimately I have to be the expert on how to do it. And so we as physicians should honor that and treat our patients as the expert that they are. If patients lose weight, who gets credit for it? They do, because they became the experts on how to do it. And this can apply to even the most, minor things you can imagine. Taking a pill each day, sounds simple enough, but as medical students, this is sometimes not a simple matter. But patients have to learn and become experts on how to be successful. So it's about partnership of two experts. And when we're able to do that, I think that it feels more, more conducive to discussions about behavior change. Right. And then evocation, I kind of alluded to this already in the earlier slides, that we're trying to evoke from the patients their own reasons for change. It's not, it may be important why I would not, like inject heroin and not exercise. I have my own reasons for doing what I do, but what's much more important, in fact, what's critically important, is why the patient, him or herself, would want to do this and engage in behavior change. And then finally, we should do all this for the benefit of the patient, for compassionate reasons. All right. And now, like I'm already saying, it's not enough to believe them. I'm pretty sure everyone in here will agree with this. Like nobody's going to say, oh, compassion, that's overrated. Like, of course, everybody's going to agree with this. But in motivational learning, we strongly argue it's not enough to believe them. You have to demonstrate them. You have to embody them. And so what that means is if I listen to your conversation, I should be able to tell based on what you say. And of course, the next, the more nuanced levels is sort of the nonverbal, behavior and communication styles. But ultimately, your verbal behavior must reflect it. And so if I listen to somebody having this conversation, within 10 minutes, I know how good you are in motivational learning or not. And that's another sort of beauties of motivational learning is we can score it fairly reliably, like how good you are. And people who are not good at it can't demonstrate it, and it becomes quite apparent. So here's some examples of how you might demonstrate through your verbal behavior the spirit of motivational learning. So things like accurate empathy, setting agendas together, asking permission before giving advice, which seems so weird, but it turns out giving unsolicited advice is one of the easiest ways to disrespect somebody's autonomy. Respecting somebody's ability to make their own decisions. Even if you disagree with them, you can still honor their ability to make those choices. Reinforcing personal choice and responsibility, like saying to a patient, it's really your responsibility to quit smoking if that's what you want. Because it's true, it's not my responsibility and I can't do it for them. Affirming positive qualities and strengths, et cetera, et cetera. And avoiding coercive strategies, using judgment, shaming people, stigmatizing, marginalizing people. Those generally don't work. Now, again, this key thing is that, there's a distinction between respecting autonomy does not mean you have to agree with their decision. It's a very important distinction. And this comes up in the context of like harm reduction versus like abstinence model. I can't believe it's still an ongoing discussion, but it still is, because people assume if you do harm reduction, it means that you're not like intervening. And somehow not intervening may seem like you're condoning the behavior. For example, giving clean needles to people who inject drugs. Then it seems like you're condoning it. But again, we're simply honoring people's ability to make these choices and try to reduce the harm for those choices they make, but not punishing it or not intervening does not mean I agree with it. So even if I give out clean needles, it doesn't mean I think it's great that they're injecting heroin. I'm still going to recommend treatment and not using. I hope that makes sense. This seems like a simple matter, but it comes up all the time. And this distinction is actually quite critical to, in sort of, being clear. All right, we're already halfway through, so I'm going to try to move along. So I want to sort of talk about, the sort of the key unifying feature in motivation. It's about the change talk, all right? And then external motivations are important at times. And so what we mean by external motivations is that it's the clinician saying to the patient what to do, being directive, giving advice, giving recommendations, recommending treatment, referring people to therapy and whatnot, giving a prescription. These are all externally driven sort of ways to change behavior. They can be important. In fact, there are times when you're mandated to do it. If you're in the emergency room, somebody's psychotic and they're not safe, you're gonna like coerce them into treatment. So that's like an most extreme form of external motivations. But ultimately, when it comes to behavior change, it really has to be about their own reasons for change. It has to come from within. So when I quit smoking, it was because I wanted to quit smoking, not because somebody else wanted me to. I mean, that was part of it. That's usually often an element of it. But ultimately, if I didn't want to quit smoking, it wasn't going to happen, right? That's kind of easy to understand. But the problem with internal motivation is it's hard to see it. You can't really directly see it. And so in motivation learning, we use a concept that's a little bit more apparent, and it's the concept of ambivalence. And as I mentioned in the, referring to the videos with the kids, the vast majority of individuals engaging in unhealthy behaviors are ambivalent about it. Meaning, at the same time, they hold two opposing views. I want to change, I don't want to change. Now, it doesn't mean it's 50-50, all right? It just means that this ambivalence exists. It could be 1 in 99, so disproportionate on one end, But this is one of the most important contributions in my mind of motivational learning to the behavior change kind of concept. The side of the person that wants to change, we call change talk. The other side we call sustain talk. And so these are competing ideas within the person that's constantly fighting inside. The change talk and sustain talk both exist, and they're constantly fighting. And this is not abnormal. This is not pathological. This is normal. The vast majority of decisions you make in life, from trivial to major, what to eat for lunch, which medical school to go to, what residency you apply to, who to marry, whether to have kids, where to live, you know, all those decisions, you're never 100% certain. Now, maybe you might come close, but it's actually considered healthy to have a degree of ambivalence, because with further information, you're able to change your decisions or behaviors, and that's considered healthy. So in psychiatry, there's a term, if you have a fixed belief that happens to be false, you guys know what we call that?
A delusion?
Yeah, the delusions, fixed false beliefs. And they're pathological, not because they're false. We all have false beliefs, whether we like it or not. It's pathological because it's fixed. It's not modifiable with further information. That's considered abnormal and pathological. And that's why the teaching is never argue with the delusion, because you're not going to go anywhere with it, you know. So this ambivalence is normal. Now, we as healthcare providers, because giving advice and recommendation is what we do as clinicians and helpers, we recommend change. We say, okay, Mr. So-and-so, you know, you're depressed, you're willing to take medication, here's Prozac, you know, take this medication. If they're willing to accept it, great, that's fine. But we're talking about this here because that doesn't always happen that way. You know, patients don't necessarily just simply accept what we say. Ambivalent patients, like in the video, those adults who just happen to be walking by, you know, you need to quit smoking. There's a tendency when you do that, when the clinician argues for change, there's a tendency to push people to the other side of the ambivalence, meaning they try to defend themselves and they argue against your recommendation. I'm sure that every one of you in this room have had that experience when you're being told what to do, even though you agree with it. Because you're being told what to do, you have this tendency to want to reject it. Now, it turns out this pattern or this tendency is very natural to humans, and it begins to emerge in humans at age 2. This is the Ericksonian stage of autonomy versus shame. This is a terrible twos, because kids, you know, when they're like very small, they do whatever you say. It's really lovely. But around age 2, they learn, like, oh my God, I can say no. And they love it, you know, and it's an important milestone that humans go through to assert, you know, autonomy. It's a very important theme that emerges throughout the rest of our lives. This is true for us. This is true for our patients. This is true for little kids. This is true for depressed people. This is true for people who are using substances. So we want to take advantage of it. We know that people like to preserve their sense of autonomy, to maintain an internal locus of control. So what we try to do in motivational viewing, instead of us arguing for change, we want to evoke change talk from the patient. We want them to argue for change. So in the video, in the first condition, the kids argued for change. Hey, don't you want to quit smoking? You should get treatment. And then the adults, you know, it's like, hey, get away from me. In the second condition, the kids were like, you know, can I have a light, which again alarms the adults. But the kids then turned it around, right? Well, if you care about me so much, what about you? He didn't say, don't you want to quit? It was more like, hey, you care about me, what about you? And the adult responded with some version of change. I know I need to quit. If I don't, I will die. I know I have to quit someday, right? Those are all language that comes from within that indicates movement towards change. This is what we're recommending. It's not that you can never give advice to patients. Of course you can. But if your goal is to change behavior, that alone is not going to get you that far. There are times when giving advice is the right thing to do, and you'll learn more about that. And you'll do plenty of that, you know. But here, this is a different way of helping patients change by evoking and strengthening this side of the ambivalence that already exists within the patient. All right. And so, in one way to think about it is, all of us within us have these two sides, sustain talk and change talk. And when behavior is not changing, it just indicates that the sustain talk is stronger and change talk is weaker. And all you have to do is change the balance, and then change will naturally occur. What we clinicians is believe that we need to get rid of the barriers and the sustain talk, and then change will naturally occur. That's our tendency. So we might say, okay, so what gets in the way of you quitting smoking? Or you get anxious, then let's go through some relaxation strategies, you know. Oh, you don't have time to exercise? Let's find a way to get you more time. But honestly, if I had an extra hour each day, I'm not going to do things that are necessarily healthy for me. I mean, you know, so removing barriers may help, but it doesn't necessarily lead to change. However, if there's a greater desire for change in the person that's stronger than the sustained talk, then change should naturally occur. In fact, that's the whole point of this, is that if we can simply make the change talk stronger, then change is more likely to occur. And it's coming from within. All right. Of course. So I wish I had more time, and I don't. And so I'm going to try my best here. And so that's the spirit of motivational wing and the change talk. And then another thing to keep in mind when we teach about motivational wing is the idea of 4 processes. The evoking and the strengthening change talk is really in the evoking phase. But before the evoking, we recommend doing at least 2 things: engaging and focusing. And then once you evoke, you can do planning. And the idea is that with every encounter that you have with your patients, you could potentially do all 4 to try to maximize the time. But if all you have is 1 minute, you can do this in 1 minute. If you have 10 minutes, do it for 10 minutes. If you've got a whole hour, like a therapist, do that. But the key thing is that don't expect behavior change to occur after just a 10-minute encounter. You would then iteratively do this over many encounters. And the reality for some patients is that behavior change may take weeks, months, years, decades, or never. Meaning you could have these conversations with patients that they may never change. But that doesn't change our task. We will continue to engage with our patients, evoke and strengthen change talk with the hopes that someday change will occur. But the engagement thing is critically important. It's this idea that I already alluded to before. It's creating the conducive interpersonal environment that's accepting and collaborative. The more patients believe that you accept them for who they are, and that you're going to listen, that you're going to empathize, and that you're not going to simply assert your agenda immediately, then they're willing to actually listen to you. And so this concept of engaging is important. It's this understanding that it's the relationship that you have with your patients is the basis for the change to occur. It's really important for you to understand that. And this is true whether you're doing psychiatry or primary care or surgery or emergency medicine or OB, it's all the same. It comes down to the relationship you have with your patients, all right? I mean, that's true regardless of what you do, right? Nobody's going to argue with that. But when it comes to behavior change, it becomes critically important for you to understand that the nature of this relationship that the behavior change really hinges on. Focusing is the idea is that at least make some effort to align agendas. When a patient comes see you, they have their own agenda and you have your own agenda. Like you have a list of things you want to talk about, the hemoglobin A1C and the blood pressure and the meds and this and that. But if that's not what the patient wants to talk about, it ain't going to happen. So you have to make some effort to align agendas. And then evoking is when you're trying to strengthen change talk. And then planning is when you come up with a plan. Here's a prescription for fluoxetine. I think you should go see a therapist. Here's a referral. That's your plan, and the hope is that you've increased the motivation sufficiently that they're willing to engage with that. All right. So in the next 10 minutes, I'm going to kind of quickly go through a little bit more deep in concretely what the actual, what this actually looks like. But the engagement, again, is critically important. We talk about the 4 micro skills: using open-ended questions, affirmations, reflections, and summaries. But they're actually, the last 3 are all types of reflective listening statements. Now, it's not that closed-ended questions are bad. It's simply that you may want to consider using these things intentionally, and open-ended questions tend to be more inviting for the patient. And reflections, affirmations, reflective statements, and summaries are all ways to demonstrate your understanding of the patient. It turns out to be one of the best ways to demonstrate empathy. If there's a better way, please teach me, because this is actually, it's not unique to healthcare. People use this in journalists use reflective listening all the time. It's a very effective way to demonstrate empathy. And it's a basic idea is that whatever the patient says, you're repeating back what you heard. However, in a simple reflection, it stays close to what they said. So, I want to stop using heroin, she said. And the clinician might respond, you want to quit heroin. Now, in this instance, It doesn't seem like anything interesting is happening here. But I would argue that the clinician is demonstrating that she heard. She's not saying, oh, I hear you. That's one way to try to demonstrate it, but that doesn't actually demonstrate. It's like telling a patient, you know, I'm really empathic. You may be, but you're not really demonstrating it. You know what I'm saying? And so here, even though it's a very simplistic kind of example, the clinician is demonstrating her understanding. Of course, the understanding is superficial, but and the other point is that actually it's not a question. It's not, you want to quit heroin? That's a question. It's not a reflective statement. All right. It's a subtle difference, but I'll just kind of end it there. For a reflective listening, you want to keep it as a statement. So the intonation goes down. But the goal in motivational review is not to just repeat back everything they say. That's really annoying. All right. It's actually to complexify the reflections. In fact, the majority, if you're a competent motivational reviewing clinician, the majority of the reflections are complex in nature. And what I mean by that is that you're adding substantial meaning. And this actually is somewhat complicated to really to master, but here's some examples. So the patient says, I need to take my medications. An example of a complex reflection might be, your recent hospitalization made you realize the importance of taking medications. So that's not what you said. You're making an educated guess. Now, what's interesting is that, you know, a lot of clinicians, when they first hear that, say, whoa, 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 that's like, you're putting words in her mouth. And that's true. But if you're listening and paying attention, you can make educated guess. And what's really interesting is that if you're right, if you're actually close to the truth, the patient will say something like, yeah, and they'll keep talking about it. If you're wrong, what's even more interesting is that as long as you've created this, you know, respectful, accepting environment, the patient will say something like, no, 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 that's not what I meant. What I meant to say was, and actually tell you what they meant. So either way, you actually deepen the understanding, deepen the rapport, and this sense of curiosity gets conveyed. And you're sort of being very humble about, okay, I want to understand. Like, oh, sorry, I got it wrong. Help me understand. The end result is deepening of empathy, deepening of alliance, deepening of rapport. Now, if you're wrong 10 times in a row, that's really bad. You're demonstrating that you're not listening. All right. So the only way to do reflective listening or active listening, as a lot of people call it, you can only do it well if you're listening. That's the whole point. Let's see another example. You realize how important it is to stick to your treatment plan. Again, this sort of, you know, you realize the importance. She didn't say that. You're making this guess about it. Again, if you're close to the truth, the patient will say some version of yeah and keep talking. And this is one of the interesting things that is that, you know, the more correct you are, the more it draws people into the conversation. Another interesting way there when we do these, you know, workshops, we give a long pages and pages of examples of you know, complex reflections, and one of them is actually called the double-sided reflection. It's actually reflecting the ambivalence. And so the patient says, I don't need to stop drinking. You're not convinced you need to change. Yet there's a part of you that wants to. So you don't want to change and you want to change, kind of a thing. All right. This is an example of a double-sided reflection. Let's see another one. You like to drink. I hear loud and clear. And there's also part of you that recognize something needs to change. All right. And so reflective listening, again, is one of the best ways to demonstrate empathy. It also becomes a skill that you use throughout the 4 processes that I talked about. Affirmations is a unique type of reflection. It's a statement that really focuses on sort of affirming somebody's strengths or qualities, which is distinct from compliments. And this may be a subtle distinction, but affirmations really stay about the person. You know, you're really committed to your recovery, as opposed to good job, good work. Now you can do compliments. It's not bad, but it tends to be a judgment. It's like me judging that it's good. Affirmations kind of remove me a little bit. It's more like, this is important to you. I hope you see the difference. It's subtle, but I think it's an important one to understand. But affirmations, you kind of talk about, it's like salt. Little goes a long way. Too much starts to sound very ingenious and inauthentic, right? Focusing is the idea, again, is that to align agendas. And just very quickly, you know, in most clinical encounters, there's a clear focus, there are multiple options, or there's no clear path. And so the idea is to sort of use strategies to kind of align them. And ask, tell, ask very quickly is a strategy to use. It's asking permission or asking what they already know, give the information and then asking back. This is one way to either give advice or to come to some decision together. And so let's see some examples. Would it be okay if I share some thoughts I have about the importance of medications? Interestingly, the vast majority of patients, when you ask for permission, will say yes. Say, okay, then give your permission, and then you say, what do you think about that? The asking permission is like knocking on the door. You're asking to be invited in. And then if they let you in, they're more likely to hear you. Because the other way to get in the house is just simply kick down the door and just barge in. All right, just don't ask permission, just say it. But then depending on how you get in, actually influences how you're received. All right, so how would you use this for, shared decision making? So what is the most important issue for us to discuss today? Patient says something like, okay, pain or whatever. Okay, great, we'll talk about that. And I also want to have a chance to talk about the results of the blood test from last visit. Is that okay? All right. And so ask to ask is really nice kind of, it's not unique to motivational learning. It comes from all kinds of different places. And so, but ask to ask, sometimes it's called elicit, provide, elicit, or EPE. And it's a great strategy, right? Now, and then evoking is really the part I talked about, sort of, evoking and strengthening change talk. And I kind of use this hill analogy. The height of the hill represents the strength of the motivation. And our patients who are struggling to change are typically at the bottom. And our goal is to help patients, motivation go higher, with the hope that at some point, if it's high enough, change will occur. And so sometimes we'll hear about, in motivation, you meet where the patient's at. Harm reduction also, that's another way to conceptualize it, meeting where the patient's at. That's very true. That's about engagement, accepting who, our patients for who they are, where they are. That's really important. But actually, in motivational review and in healthcare, we ultimately want to meet them where they would rather be, where they dream to be, where they aspire to be, right? I would argue there's therapeutic value in accepting people where they are. That itself has therapeutic value, no question about it. But I would argue that's not all we can do. We can do a lot more. We can actually, again, meet our patients where they would rather be. And our hope is that we can guide them towards that, all right? And so, again, this task of elevating their motivation is a lifelong work. For some patients, you do it for 10 minutes and they change. Sometimes it happens. It's like, hallelujah, it's amazing. But most of the time, it takes weeks, months, years, or more, right? And so, again, external motivations are helpful, but that's usually not enough. You have to actually, so there are many ways to use external strategies, but ultimately, we have to use internal strategies, meaning increasing, affirming, validating, strengthening internal motivation for change. So again, we talked about the change talk. Instead of us arguing for change, we want to evoke that from our patients, right? So if you argue, that has a tendency to push people to the other side. And so we want to evoke change talk and strengthen it, all right? And so change talk itself this is sometimes we kind of, categorize. It's called DARNCAT, desire, ability, reason, need, commitment, activating, and steps taken. These are different types of change talk. And this is language that indicates movement towards change. Now, it's not about the sentence itself. So it's not like, in the old way in school, you have to write on the blackboard, I will not do this, this back. Bart Simpson writes on the blackboard, right, at every start of the episode in Simpsons. That's not what we're talking about. We can't just tell our patients, repeat after me, I will stop drinking. Say that 1,000,000 times and it'll be very motivated. I wish that were the case. It doesn't work that way. It's something happening inside the patient that's generating this language. So we can't force it. Again, it has to be in there that we evoke. All right. Okay. So how do we actually do that? What does that actually look like? So sometimes we call this introductory questions, taste of MI questions. And these are the ability, reason, need types of change talk. What would it take to be successful in quitting smoking? The answer to that question is change talk. Well, I don't know, maybe I took the patch and did some counseling, or I don't know, did more exercise, whatever. Okay, that's how you would quit. Well, but let me understand why, what are the 3 most important reasons why you want to quit smoking? The answer to that will be change talk. This final one is another interesting example. On a scale of 0 to 10, 10 being completely ready, 0 being not at all ready, how ready are you to quit smoking? Or this is drinking. I'm sorry, I kept saying smoking, but the example is drinking, but it's the same idea. Patient might say 7, but it's not the number that we care about. It's the follow-up. Okay, why'd you pick 7 and not a 4? Why are you not a 2 or 4 or 3? The answer to that question is change talk. All right. So this is a distinction between me telling the patient, you should quit drinking, quit smoking, exercise, take your pills. You could do that, or you could evoke change talk. Again, this aligns with the ability, reason, need. There are many, many other examples of how to evoke change talk. A really easy one is looking back at past attempts, prior attempts. You were going to methadone clinic last year. Why'd you do that? You were able to come back on drinking last year. How are you so successful? Another example is, like when I did the training for the HIV clinic, it became very clear when the patient comes back to a visit and say, oh, I didn't take my HIV meds. The natural inclination for the clinicians to ask, why didn't you take it? Which makes sense. You can ask that. However, an interesting thing to ask is, okay, were there days you were able to take the medications? Okay, why were you so successful on those days? Right? So evoking change talk is looking at prior success, not prior failures, but prior success. Looking forward, how would you see your life differently from now? And is there anything that would happen that would change your mind? So there are many ways you can do this. And the scaling, there are lots of scaling questions, etc. But one of the interesting things to also think about during the evoking phase is this concept of a selective responding. This is what a patient might say. I don't drink more than my friends. And sure, I could probably cut back, but it's really not a big deal. It's harmless. When clinicians hear this utterance, we hear a pre-contemplative patient, unmotivated, not interested in change. But when you actually look at this, you realize this middle part. Do you know what we call this middle part? Anybody?
Change talk.
There you go. That's change talk. The first and the last part, that's sustain talk. I don't want to change. I don't drink more than a friend. That's harmless. It's no big deal. But this middle part, it could be a reason for changing. And I could cut back that ability. So that's the type of change talk. So the classic MI response might be, ooh, you don't think cutting back would be an issue. Tell me about that. How would you be successful? It's ignoring the sustain talk. It's when you say, well, actually, based on your screening questions, you're at the 90th percentile of people at your age and gender and drinking quantity, and actually your liver enzymes are elevated, so it's actually harming you. That's how the discord happens, and the patients immediately fight back. You already have the gold in front of you. You're hearing a potential reason or some change talk, and so you ignore the sustain talk. And during the evoking phase, that is what you're supposed to do, is you're actually supposed to, as much as possible, sidestep the sustain talk, not argue with it, not engage with it, but actually engage with the change talk, evoke and strengthen change talk. You don't think cutting back would be an issue. So how would you be successful? You thought about cutting back. Tell me more about that. All right. Let's see another example. It's such a hassle to go to meetings. I know I should go. I'm usually glad when I went, but I'm usually busy. It's just not worth it. Again, when we first hear this, we hear a unmotivated, pre-contemplative patient. But actually, if you look at it, there's change talk in there. So our goal is to, again, ignore the sustain talk and respond to the change talk. Despite the hassle, you find a way to get there sometimes. What's different about those days? All right? You have good reasons to go to meetings. Tell me about that. And ignore the sustain talk, right? And so the key thing is, if you hear change talk, the goal is to actually do something about it. And it becomes our task to discern change talk, sustain talk. Patients aren't consciously aware that this is change talk and sustain talk. It's just coming out. It's all that's why they're ambivalent. Our job as clinicians, in a way, is to have this sort of ability to detect change talk as it's happening in real time, and then doing something about it. Meaning, we call it the ear. Ask for elaboration, affirm it, or reflect using active listening. It's sort of like saying, look, at all these, pretty reasons why you're telling me why you want to change. And that's exactly, let's see, okay, I'm running out of time. I'm gonna go skip through this. This is some of the evidence based around whether change talk actually makes a difference, and the evidence says yes. And this is a model. The more change talk we evoke, the more change will actually happen. In fact, you have control over this part of the process, meaning you can behave in ways that maximize the likelihood of change talk emerging. But ultimately, patients themselves have to translate that to actual change. We don't have control over it. All right. So when I quit smoking, I was in control. Now, what this means is that as clinicians, your control is very limited. And so we like to think that when patients do well, it's because of us. Well, it's only partly true. Now, if you're a trauma surgeon, you're doing a lot of work, all right? But if you're a psychiatrist, addiction specialist, managing chronic disease, for example, our patients have to do the work. Just no way around it, All right. The final thing I want to talk about is this concept of a change talk bouquet. And if there's anything that people remember, oftentimes this is the one thing that people remember. And it's the idea that, throughout the conversation, you're evoking and reflecting change talk. And that this transition to the planning phase, a cool thing to do is actually give them all back as a bouquet. Here's an example. You're tired of being so out of breath and you're confident you can stop smoking because you've done it before. Adding insult to injury, cigarettes are like costing you a fortune. And then you combine this with what's called a key question. So where does that leave you? It's like, look at all these reasons why you say you want to quit smoking. So what are you going to do about it? Let's see another example. You used to exercise a lot and you have a good idea what changes you need to make in your diet. You want to set a good example to your kids and you don't want to be overweight anymore. Change talk bouquet. Where should we go from here? Key question. Final one. The recent hospitalization was a wake-up call. You never thought you would need surgery to deal with infection from injecting drugs. You realized that going back to the clinic makes sense and the counseling was really helpful. What will you do? All right. So this is a change talk bouquet and a key question combination move that I think it's very, very effective. And then if they say, yes, I want to change, then smart planning, this is not unique to motivational. It's more about just being very concrete about a change plan. Some patients might say, I don't know, I've got to think about it. And that's okay. The planning might be deciding when do we talk about it again. A confidence scale here might be useful. If their confidence in the plan that you decide, they're not very confident, then that's not a good plan. Generally, you want a plan where their confidence is going to succeed. And a confidence scale can be helpful. And then finally, this is an ongoing discussion. It's usually not a one-off thing. And so when can we talk about it again is basically the idea. All right. So practice is required to get better at motivational young, but as helpers, as future physicians, you're going to be recommending behavior change all the time, whether it's taking a pill, going to treatment, anything that you recommend generally requires behavior change. And so motivational young will come in handy. But to get better at it, you need feedback. And so it's a very important concept. It's hard to learn this just by reading the book. In fact, we would argue you can't. These are the recommended texts. The one in the middle in particular, it's a workbook. And so that's a recommended suggestion. And the new edition of Motivation just came out on the left. And then for a website, www.motivationalmeeting.org is a website that's chock full of useful information. And then finally, a learning group can be a very helpful way to actually support clinicians and others to not only develop but maintain skills. And so we do this twice a month. People bring tapes, we listen to it, and we get feedback. Here are the references, and I think I got it done with 1 minute over.
Thank you so much for that talk, Dr. Suzuki. We actually do not have a talk right after this. So if you have
I have a few minutes.
And if anybody has questions, I don't know if anybody was holding it. Okay, so it looks like there's a question from Jacob. He says, after providing the patient the change talk bouquet, what is the approach if the patient does not want to change at that time?
Yeah, so again, this is going to happen as well. So the change here to discuss, maybe to, again, agree to keep talking, right? And I kind of said earlier that just the act of demonstrating your acceptance to the patient has therapeutic value. I truly believe in that. And so it's not like it was like, oh, that was a failure. Just because patients don't change doesn't mean the thing was a failure, and so ideally, patients will be agreeable to something, but it's not like the only thing you're looking for is like, okay, I'm going to quit drinking. It could be something as simple as, let me try taking a medication, or let me look into a local AA meeting, just check it out, or talk to a therapist about different options, so the change behavior that we're trying to recommend can come in all kinds of varieties. And so when you say the patient doesn't want to change, well, there are things that the patient's probably willing to do. And you want to try to find a way to align with that. But the point is, it becomes an ongoing discussion. And it's just finding the balance between accepting who they are, where they are, and then gently guiding them towards change. right? But at every step of the way, you're trying to reinforce with them their own reasons for wanting to change, right? It's really evoking and strengthening what's in there already.
I have less of a question and more of just a comment, but I really appreciated how you drew a distinction between motivational interviewing and assessing stages of change. I was a little bit taken aback at first by that, but then recognized through your talk that I think we as clinicians or future clinicians often have a tendency to take a tiny slice in time and make assumptions about the patient as a whole. So seeing that whatever the patient is saying to you immediately in one sitting isn't necessarily indicative of their overall willingness to change, I think is useful to keep in mind.
Yeah, that's a really good point, and thank you for that comment. And what's interesting is that motivation can fluctuate rapidly, moment to moment, day to day, week to week. And so you're right, even if right now they're kind of, appearing resistant, it does not mean that that's where they remain. It may be the context in which they're in, or the people that are around them. It could be so many factors. And so what's nice about motivational interviewing is that, as you become really, confident in it, there's a greater sense of like hope, because most of the patients we encounter, we can find change talk. We can find something to evoke and strengthen and validate and affirm and align with. And it's a very hopeful skill in a way, yeah. So thank you for that comment. I couldn't see who it was, but there's just a disembodied voice out there. So thank you for that comment.
And then Connor says, do you have recommendations for keeping up engagement and interest in a learning group?
So is there, I'm sorry, can you repeat the question? So engagement with the learning? In
a learning group. Connor, maybe if you want to unmute potentially and maybe elaborate on your question.
I did unmute. Yeah, just thinking about the learning group that you were talking about, having practitioners meeting bi-monthly or twice a month. I was just wondering how you keep everybody engaged in that.
Yeah, no, that's a great question. So our fellows are required to go. So there are addiction medicine and addiction psychiatry fellows. We have a whole bunch of them, and they are required to attend. And so as part of their rotation, they're required to bring one tape. And it's usually in the hospital. They record a conversation and we listen to it as a group and we give feedback. And so, but we invite clinicians from across the hospital system to come. And so people can come, they're free to come and go. It's not other than the fellows, they're simply invited. But for the fellows, it's an expected part of their training. And yeah. And people learn, we're very gentle. We don't make people feel terrible about their skill set. Most folks, because they're fellows, they have some experience with it already. And but it's a really wonderful way to develop skills and to get feedback.
I guess just branching off of that, I was wondering specifically how to keep it up when people are not required to go, when you're not in just a training context.
That's a good question. And so if they're not interested in coming, we keep the option for coming. This 1 hour talk that we just did is the strategy. This is not going to train people. This is getting people interested in doing more training. So in a way, the sort of meta idea here is this is sort of serving like I'm inviting people to consider doing more training. I'm not telling people to take the training. I am, hopefully this evokes from you the internal motivation to want to get more training. I hope that meta concept is kind of coming through, but I can't force people. So your point is well taken. If they're not coming, I'm not going to make them. Oftentimes, for most clinicians who do motivational training, it's triggered by their own experience that this feels better. Even as medical students, I'm pretty certain that you've had enough encounters with patients to know that some types of encounters are not comfortable. You're like arguing, you're fighting, you're wrestling with people, like, just take your medications, like, just stop injecting drugs, you feel like you want to wrestle with them. But when you actually try motivational training and it actually feels better, like you're collaborating, and we call it the dancing and not wrestling, and you're seeing behavior change, you're seeing results, you begin to realize like, wow, this actually feels better and is more effective. Like, duh, like this is better, and so that triggers people to want to get more training, for example. In my mind, that's the best like advertisement for motivational training, is when people experience for themselves how this feels different to them. And yeah, wow, I want to keep doing this.
Thank you.
So I know that you guys have lunch, and I don't want to cut into your lunchtime and break. You guys are doing this on a weekend, and I'm sure you want to take a little break. So Priscilla, I really appreciate the invitation. I'm always inspired by the next generation of folks. You guys are the next generation in the field, and so we need more psychiatrists. We need more addiction specialists too. And so if anybody has questions for me, please let me know. Good luck with the rest of your medical training and your residency. Good luck with the match. And thank you for paying attention.
Thank
nice
you
to
so
see
much.
you. Yeah, and hope you all have a nice Thanksgiving.
Thank you. And so for anybody that's still on the call, just if you want to go to the next talk, it's the recovery panel, and that's going to be in about an hour, and then I'm going to stop the recording.
Would you like me to begin, Priscilla?
Yes, go ahead.
Okay, my name's Lori. I usually start when I speak about this as my name's Lori and I'm an alcoholic. And that's what we kind of say in my recovery community. My story began kind of when I was very little. I don't remember my first drink. I was a toddler in diapers sucking on a beer bottle, and they thought that was cute. And we got whiskey with a tablespoon of honey in it, and that was good for you. And my father was an alcoholic, imagine that. And the chaos of alcoholism was alive and well in our household. When he was sober, he was the most kind, compassionate, loving man. But when he drank, well, bets are off. He turned into a very vulgar, violent guy that liked weapons. I saw him throw a knife at my mom once, and she stepped aside. It hit the counter right where she was standing and ricocheted under my chair. So that chaos, I've been, shot at, things like that. So I just thought that was kind of normal, and went on about my life. And I discovered daily drinking at about age 18. I worked for a hot broker, and we had a fridge of beer in the office, and I thought that's what you did at work. And I met my husband in a bar, married him, married into a drinking family, keg on tap in the basement. I just thought it was all very normal. And, it worked for a while. And unfortunately, this is a progressive disease. And when I realized I had a problem, I thought, well, I'll just quit drinking. And I found out I couldn't just quit drinking. And so for about 4 years, I made attempts at getting sober. And I got sober. My sobriety date currently is September 20th of 1998. And back then, basically what was around my community was AA and NA. And my drug of choice is alcohol. So I would go to a couple AA meetings. I would arrive late. I would look for the differences and think, I'm not like these people. And this foreign language they were speaking was like, what? And leave immediately. And I could say, I went to an AA meeting, but I was not really attempting to be a part of AA or practice any of their principles or work the steps or work the program at all. I was still running on self-will, believing I could do this by myself. And I'm a strong, intelligent woman. All I have to do is just not drink. And then again, drink, and the bottom would be dropped lower. The yets, I haven't driven my kids in the car yet. I haven't done this yet. I haven't done that yet. All started happening. And I started to realize what a powerful foe I was up against. And so my sobriety date is not the date I walked on to our treatment center in Newburgh, Oregon. It's the day I woke up there. I finally, at that point, the only thing I had was willingness. I finally got to a place where I was willing to go to any lengths to get sober. And what a relief it was to get to that treatment center and realize that I was not a bad person. I was not a weak person. I was a very sick person with a disease that was treatable. And what a relief. And in that treatment center, you know, I found out I can't see myself. All of my self-power and all of my intelligence and all my wherewithal was not going to beat the disease I had. I needed help. I needed to be open to suggestion. I needed to listen to what was told to me. And I needed to become a part of. And from my childhood, I had decided to run on self-sufficiency. I had decided I was not going to let anyone know the reality of my life or who I really was. I was so busy putting on the look good out there for everyone and spending all my time and energy on the look good. And I finally got to a place where I realized I need to stop spending my time and energy on how I look and start spending my time and energy on how I am. And I did not understand that I needed not only to just quit drinking, I needed to do the repair work in my life. So I did not want to run from my life or hide from my life or feel guilty and shame and all the rest of it about my life. And so one of the greatest things that happened to me was that in that treatment center, I got the understanding, compassion, and love that I needed to let my guard down and actually start doing that work internally. And I got the ability to be safe enough to be transparent with the counselors there and with the psychological folks there and address my trauma issues. You know, my brother kept telling me, you've got PTSD, you've got PTSD. And I'm like, no, I don't. You're the one that went to Vietnam, not me. And lo and behold, of course, I did have, and along with some other things too. And the wonderful thing about going to treatment was we treat the whole person, address all the issues, and get people on their way, get people healthy. So what I will tell you is that I was a patient there in 1998. I became a volunteer as soon as possible. So I stayed connected with my treatment center. And then I have been an employee with many different hats off and on over the years, but I've always been either a patient, a volunteer, or an employee since 1998 there. Some of us are sicker than others. I've never left, right? But anyway, so, you know, when I left treatment, though, that was a real dicey place. How do I leave that very safe cocoon, very safe container, and go out there and make it in life in the world? And so they suggested going to 90 meetings in 90 days, and I didn't do that. I went to 365 and 365 because I found out if I went more than 24 hours without getting centered and focused again, that I call my addiction my idiot committee, it would have edged me out and I wouldn't even have noticed that. And so I stayed very, very close to my people in recovery. I became very transparent with a sponsor and with a few other women so that I could be honest and open, because that was very difficult for me. And that was a process. I didn't go from 0 to 100% honesty in a week or a month. It took a long time. And in my world, I worked the steps of Alcoholics Anonymous, which in hindsight took care of everything I needed to. It got me reconnected with something greater than myself. It got me so that I could be open and honest with other people. It got me so instead of running from everything, I had the ability to face everything and recover. And that included my own character defects, which were just really annoying and biting me and causing me to make mistakes in life. And then I got to clean my slate, make my amends to people so that today there's not a person, place, or thing that I'm uncomfortable being in the same room with or talking about. It's a beautiful way to live. And then maintenance steps so that I don't slip backwards. And one thing I have to say about the 12 steps, they are packaged today so many ways. A person does not have to belong to an AA program or an NA program or even a 12-step program to work them. And I am currently at an area assembly for AA, and within AA, there are secular meetings, there's like all kinds, men's meetings, women's meetings, there's meetings in every language actually. And so there are many, many ways to work the program that work for me, and I offer that to anyone I meet. But today we also have SMART recovery, we have Dharma recovery, refuge recovery, and the ingredients in the original program of AA have been replicated. And so, you know, I'm grateful that more people are being reached. But I guess the most important thing is that when a person wants help, that they get the help. And I'm so grateful to all of you for caring about recovery and caring about learning about addiction. So thank you all, whoever's listening, for doing that, because the disease has been misunderstood and we've made a lot of headway, but there's still a huge stigma attached to it. There's still a lot of misunderstandings and myths attached to it. And, there is a solution, and the solution is wonderful. And to watch people in my current position at Hazel and Betty Ford go from, day one or week one or wherever their starting place is, to watch them get into recovery and to have, all of their time, all of their energy, all of their money instantly refunded. And then down the line to watch them grow into the healthy people they're intended to be is the most fulfilling thing I've ever done. And recovery to me is the most fulfilling thing a person can do. I'm happy to talk about anything. I'm very transparent, and I don't want this time to be about me talking at you. So please do feel free to ask any question you care to. Life went on. That first year, like I said, I really took care of myself. I didn't go anywhere dicey without another person in recovery with me. No weddings, no funerals, no concerts without someone with me. And then I edged out a bit, and I started doing more things that, quote, normal people do. And I learned how to use the tools of recovery to keep myself sane and sober. And life went on. I can tell you a bunch of stories, but I'm not sure how much time we want to take. Like I said, I think I would rather answer questions you're curious about than tell you about what I think I should tell you about. Should we go to questions, Priscilla? And if not, I'll tell you stories. I got a bunch of them.
Sure. Why don't we start with some questions, just see how many people have, and then I have a few myself, but I'll wait and see if you have a question, you can put it in the chat, or you can raise your hand and talk to it also is fine.
I'm going to tell you a story then.
Well, I have a question. I was just going to wait and
Okay.
just to let somebody else go first. So you had said that when you got to Hazelden, that you had this really wonderful experience, really supportive, back in the 90s, but that, the alcohol use got pretty serious before you got to that point. So I'm just wondering, along the way, prior to you getting into treatment, how do you think anybody in the healthcare system, whether it be primary care, psychiatry, counselor, whoever, what do you think could have helped that happen earlier, or maybe you have been open to it a little bit earlier on, rather than when you actually did get treatment?
Thank you, Priscilla. Yes. Back then I ran and hid from any doctors or anyone that could spot me. I didn't want anyone to spot me. My goal in life was to keep drinking. And so I actually avoided all the doctors and things. However, I would end up in the emergency room, unfortunately, from being intoxicated and hurting myself. And so I think at that time that no one was really being honest with me about what they saw, if they saw it. And I think that sometimes a person's journey is not that particular moment, but several moments adding up, several people saying the same thing. After more people tell you the same thing, it's pretty hard to ignore that. And like I said, I couldn't see myself. And so I really, like I said, I appreciate people educating themselves about addiction and spotting addiction. And then, you can't tell somebody, but you can certainly suggest when a person's really sick, and maybe suggest some help tools for them, or taking an assessment of how their drinking or using is affecting their life. And there's a lot of tools out there. But perhaps if someone would have been honest with me and put the tools to assess myself in front of me, I may have used them earlier. The wonderful news is here we are 25 years later, and people don't have to have the low bottoms now to recognize they have a disease that needs help. We are seeing people with higher bottoms, and I'm so grateful, and younger people realizing they don't want to go to the depths that they may have seen parents or grandparents go to. There's no reason for a person to do that if they realize they have this disease now. So we've made a lot of headway.
Yeah, thank you for that. And I think it's really interesting that you mentioned going to the ER because maybe you were injuring yourself when intoxicated. That reminds me when I was on my family medicine rotation, actually, there was a patient who came in for a physical exam and that we had noticed that he had some scrapes on his knees. And he said it was when he fell, when he had been drinking. Um, the provider I was working with didn't really address it though, which I thought was interesting. Is that could have been a really good segue. But I'm hoping though that all of us being here, we know not to just look for it when they're already coming to us, but what are signs in primary care clinic, at the ER, just in all different spaces to really look for it. So it looks like Cecilia has her hand raised. If you want to
Yeah, so I had a question about when you found resources that you could be honest with later on in your journey, what initially were you looking for in those supports?
Well, I got told to, my life, before I got to treatment, was surrounded with people that drank like I did. And all of a sudden, I couldn't hang around with them anymore. That was dangerous for me. And so I had to create a new network of friends and places to go and people to see and things to do. And what I got told is to look for people that had what I wanted. Look for the people that I wanted what they had and stick around with them and do what they did. And so fortunately, one of the nice things about COVID is we have got virtual, we have got in person. We have got so many ways to cast a wide net now to find those people and then connect with them. But it was trial and error. And I was very fortunate at that time. Meetings were brought onto the treatment campus and we got acquainted with people outside living sober. And so when we walked out the doors, we had that bridge of being able to go where they went to, meetings they went to, spend time with them. And find that safe place of transparency. Fortunately, recovery is an amazing deal. I've never seen anything like it. We all want each other to stay sober and we're all willing to help each other. So it's pretty incredible.
Oh, Lori, can you see the chat?
I do now, yes. Okay. So I was talking points about reaching someone that's out there. And I think it depends on if they're the tad bit open, not open at all, where are they? Are they got no, or have they already realized that they have a problem and they just don't want to face it yet? And so I try to meet them where they are and just talk about where they are and what they would like to change and where they would like to be in a month or in a year or in 5 years. And sometimes I also ask, what would they like to look back on? And one of the big things I use, it's later than you think, because procrastination about getting help is huge. And so perhaps it's more about them and their health. I mean, it is all about them and their health, but finding some kind of common ground about where they are to build that connection. So we're not just another talking head, if you will, and moving them forward into what they would like for themselves. And it has to be about them. It's like it seems like when we're doing it for somebody else down the line, there's a resentment about that somebody else made me quit drinking or things like that. And so it's really beneficial for it to be about them and their health and what they want for themselves. And I also make sure that I tell them that they deserve to become everything they're intended to be. Is your addiction or drinking, is it hindering you becoming everything you are intended to be? Because you deserve to be everything you intend to be. And the people around you that love you and care about you deserve to have you present and whole and healthy. And often that will hit them pretty good. I'm a peer support specialist right now, guys, so I do get to talk with newcomers a lot, and it's wonderful.
You had mentioned that you pretty much it sounds like maybe you cut off a lot of the people in your life because they were drinking, quite a bit. And one thing that I've heard a lot from people is, oh, well, all of my friends drink. It's how we spend time together. And another one is, well, I don't drink the most out of everyone I know. I hear it in my age group, but really amongst everyone. So I was wondering how you made that work for you, but then also being a peer support specialist, what have you seen work for other people?
So I got out of treatment right before the holidays. And as I said, I married into this drinking family that drank more or as much as me. And I knew that to go to those gatherings where it was just a big drunkathon was that just not going to work for me. And so I kept it right now. And I just said, right now, I just can't be around drinking. I love you all very much, but right now I just can't come. Maybe next year. But I kept it in the present. I kept it honest with myself about who I could be around and who I could not be around. And so that worked really well. Everyone understood, everyone was fine with it. And I spent my holidays with sober people. But down the line, so I would go to those gatherings, have dinner, but I'd always have my own car. I'd have, ways for me to keep myself safe if I needed to. But I found out that after they all tipped over into, an intoxicated state, I didn't want to be there anymore. I would rather leave and go do something I wanted to do. But so being honest with the loved ones, and then I guess, as far as my drinking friends too, I was invited by a couple that used to drink with us to New Year's Eve that year. And my girlfriend said to me, and we won't have any alcohol. And I said, oh my gosh, I can't ask you to not have alcohol on New Year's Eve. And she looked at me and she said, Lori, we don't drink like you do. And I was like, oh. And I found out there were a lot of people that really didn't care whether they drank or not. And so if I requested there not be alcohol or just said, I'm so sorry, I can't be around alcohol just yet, they would just say, okay, well, we just won't have alcohol. So my perception of the world was pretty warped in that I thought everyone drank, and that's not true. And alcohol and drugs are really not important to a lot of people that I knew that I was friends with, but I just misinterpreted them. Does that help?
Yeah, definitely. Thank you. And then maybe we have time for one more question specifically for Lori, and then we can move on to Brian telling us his story. And if there are no more questions for Lori, we can also just go ahead and talk with Brian.
Should I look at the chat?
Well, hi. Thank you, Priscilla, for inviting me. I'm so happy to be here. Lori, thank you for sharing your story. Such a great story. I got sober in 1987. I went to a place called the Van Ness House. And let me back up. One of the questions you asked earlier, Priscilla, was about how people and how medical professionals have approached people with addiction when they go in for either primary care or whatever it is. And the first year, the first HIV test came out in 1985, I went to get tested and tested positive. And at that point I had AIDS. And what the person, called me in to tell me my results said to me was, now you're infectious. So be careful, you should probably start getting your affairs in order. And at that moment, I just felt so dirty and so disposable. And I know that kind of manner, bedside, office side manner, whatever you want to call it, is very different now, but that's how it was back in 1985. And I went a little bit off the deep end. I'm an alcoholic. I'm also a recovering meth addict. And so I went off the deep end for a little while, but eventually, in 1987, I found myself homeless. And I'm the oldest of 8 kids, by the way. My parents were very religious. My dad was a really violent guy. I think he had some mental health issues. He also drank, and really wanted things done the way he wanted them done. And despite the violence, we would all go in for the hug, hoping that maybe one day he would wrap his arms around us and tell us he loved us and he was proud of us, and so, and that's how we just lived our lives. We got so sensitive in our feelings that we could tell by the way he drove up the driveway whether we should scatter or whether we should greet him at the door. And I think that those early kinds of intuitions and and experiences have shaped the way I listen to people now. I got kicked out of the house for being gay. My brothers and sisters were not allowed to talk to me on the phone because my father said that he didn't want them to catch gay. Really an awful sort of experience all the way around. When I got sober in 1987, I went to a place called the Venice Recovery House. I was homeless. I'd heard about this place. It's an LGBT rehab in Los Angeles, and somebody dropped me off in front of it. It was a rainy night. I'll remember, 1987. I knocked on the back door because the front door was locked, and there was a lady there who said she couldn't let anybody in until tomorrow morning. Could I come back in the morning? Because they were already closed up for the night. So I went over behind their dumpster and opened the dumpster lids and had them rest on the fence. And I slept underneath the dumpster lids that night. And then I got sober, and I stayed sober for 5.5 years. And I got very involved in AA. And my life began to change very quickly. Within a few years, I'd become the general manager of the Improv Comedy Club on Melrose. I got to meet a lot of comics. And then I got cocky. There is actually a picture that I have with my feet on my desk, wearing my sunglasses, and I was wearing a tie that Jay Leno gave me. And I keep that picture because I was so arrogant. And I remember looking at that picture and remembering that the next day I went out and relapsed. And then I got sober again for about 3 years. Again, I disconnected with my peers, my AA meetings. And then I got sick. I moved in with my brother in Venice. In 1999, I was living with my brother's best friend, who was his roommate. He was sort of a pothead, and I was a pothead, and he was a coke dealer. And I was drinking still, and I remember watching TV in my room and hearing a gun go off. And it turns out my roommate was teaching they were both high. He was teaching his sister-in-law how to clean a gun, and it went off and it killed him. And the next day I went back to meetings, and that was May 2nd, 1999. And that is my current sobriety date. One of the things I talk about with some of my patients is just because they relapse does not mean they have lost the time they were sober. Even after they relapse, they always think they have to start over. And I have found that recovery is progressive as well as the disease of addiction. Having said that, there's something that truly comes with long-term recovery that you never really get otherwise. This time I found a sponsor and a small men's group. I did the steps in a way that I had never experienced them. One of the things that people most seem to be afraid of is the 4th step, which is where we do a fearless and thorough moral inventory, and we list our resentments. We list our resentments, our fears, and our sexual inventory. And my resentment started out with my dad right away. First one, boom. I'm resentful of my dad. In the second column, because. In the third column, what it affected: self-esteem, personal relations, ambition, pocketbook, or sexual relations. I never really, I know that he affected my self-esteem. He never really thought much of me, any of us really. He was very controlling about who we hung out with as personal relations. I will say my poor dad, I'm the oldest of 8, and I think he wanted me to be a linebacker on the high school football team. And that just wasn't in the cards. I wanted to be a jazz choir. So my ambitions were kind of squelched. Pocketbook, my dad used to make us work, and he would, we would have to turn our money into him as an investment in the family so that when we needed it, it would be there. Of course, it was never there for any of us. We either got kicked out or ran away before we ever saw any of it. And there was never any money to be had. My parents are kind of grifters. I never really considered my dad having an effect on my sexual relations, but being gay, he created so much shame around it that it did ultimately have an effect. It wasn't because I was molested by him or anybody, you know, or anything like that, but it did have effects on me. You know, in the fourth column, we have to identify if I were to let go of some of these, which character defects would I have to let go of to be free of that resentment, basically, you know, and I didn't understand the concept, you know. I said, you know, I don't, none of my character defects, you know, I didn't have anything to do with what happened. And my sponsor says, you know, it's not that you had anything to do with what happened, it's that you're still carrying the resentment. And here it is, how many years later, how many years have you been away from your dad and you're still resenting him? So what is it that you're missing here in terms of character defects? The first thing he said was, are you unwilling to accept your father as perhaps being a spiritually sick child of God, just like you? I was like, wait, what? You know, and what I realized is that we're all really have our spiritual maladies show up in many different ways, you know, and mine showed up one, my dad showed up in another. And the other thing was that he said is, how about a lack of compassion? And I go, what do you mean? He says, think about it for a second. And I realized at that moment, how must my dad have been treated to treat his 8 kids this way? And it was like the room got bright and this weight was lifted. And I'm telling you, the resentment was gone so profoundly that I could not deny that it had worked. And that gave me hope to do the rest of my 4-step, to do all my amends, and really put trust in the way my sponsor was going to direct me to go through the steps. You know, interesting story, you know, when I did my amends step, my 9th step with him, my father was again at the top of the list because, you know, I'd stolen from him and lied to him, and I still had to make amends to him, even though, you know, what I thought he did to me was worse, you know. But when I make amends, it's cleaning up my side of the street, right? So I put together this letter that, you know, where I apologize for many different things. I put a lot of cash in there for the money that I'd stolen and things that I'd stolen from him. And my sponsor says I always put cash in the envelope because people won't always cash the checks. And then my sponsor also told me to thank him for all of the things that I learned from him, like my work ethic, my sense of humor, my taste in food and art and music, you know, and I went through that list too. And it was a really cathartic experience for me because, you know, I'm one of these people that is so used to looking for what's wrong with people that for me to have to step back and look for what's right in people, despite how they treated me, was a great new perspective on how to live. And so it turned into a 6-page letter, and I ran it by my sponsor, Brad. He says, this looks great. So I put a stamp on it and popped it in the mail. And Brad said, don't think about getting a response at all, because my parents haven't talked to us in many, many years. But, you know, about 6 weeks later, there was an envelope in my box from my father. I called Brad. I said, looks like my dad wrote back. Would you meet me early at the meeting so we could open it together? So we opened up this letter from my dad, and it was my amends letter corrected in red ink. He had corrected all of my spelling errors, punctuation errors, grammatical errors. The money was gone. And there was no other note, just red markings across the letter. And I was like, are you, you know, I had that fire starting to, you know, that, and Brad says, wow, your dad still loves you enough to want to teach you better English. I just went, wait, that's the best you can do right now? And he says, look, you just got rid of all those resentments, you know, go correct the letter. So I rewrote the whole letter and made every correction. And I put it in an envelope and I put a stamp on it, and I called Brad. I said, I'm going to pop it in the mail on the way to work tomorrow. He says, no. You only make amends once, but you needed to make those corrections. And it's that kind of sponsorship that turned me into the kind of man I never knew I wanted to be. You know, what I did differently this time was I went back to school, and I got my bachelor's in social work, and then waited for years, I don't know why, to finish my master's. But after I got my bachelor's degree, I started to become a counselor, and I moved up from being a counselor to being an executive director at an LGBT community center in Los Angeles, in an LGBT rehab, I should say, and then I loved that job, and then I moved up to the desert about 13 years ago, and started all over again as a counselor, as a tech. Actually, I started as a behavioral technician. You know, one of the things about recovery is, you know, if you can get your ego out of the way, you can, you know, it's not so bad to start out at the ground floor anymore, right? And so I started out as a tech, and quickly moved into being a counselor, and then moved up to being an executive vice president of West Coast outpatient services for this big rehab company. And I had that job about 2 years, and I realized that I didn't have the one-on-one connection that I needed to have with patients. And so I gave up the job, and I gave up the money, and I went back to being a counselor, and I have been entirely fulfilled ever since then. You know, some of the things that I have learned along the way are to listen to what people are not telling me. One of the things that I talk to patients about often is, I work with men at Betty Ford, and I will ask them, what kind of man do you want to be? And they just look at me like, what are you talking about? I say, you know, getting sober is so much more than just putting down a drink. Have you ever thought about what kind of man you would like to be? And they get really quiet for a second. And sometimes these guys who are big, you know, burly guys start to tear up and think, I never really thought of it like that. I said, you're getting sober. You kind of have a clean slate to start with. You get to become any kind of man you want to be. Let's figure that out. When we take away the alcohol, then you get to start living the life that you've always wanted to live. And that's what worked for me. You know, there are, you know, one of the things that I did with my amends step, you know, sometimes there's what we call a living amends. And, you know, all my brothers and sisters got splintered off from the family because of my dad, you know, kicking us out or people running away. And we all just sort of scattered. And my amends to my younger brothers and sisters were to bring us all back together. And although it was very difficult at first, and some of them didn't want to talk to me because of what they've been told about me by my dad, eventually I succeeded. And to this day, all 8 of us kids are so close. This daily thread that we have is so hilarious and so full of life. And we are all each other's most important person in each other's lives now. My parents have chosen to stay away from all of us. They I think a lot of it has to do with the fact that my dad might not be capable of looking at the things that he did to his kids, and that's okay. I have love for him. Some of my brothers and sisters are still very resentful. You know, it's interesting. My sister Pam got a DUI, and she stopped drinking in January of the same year that I got sober. I got sober in May. She never lets me forget that. She's, you know, 5 months more sober than I am. But she never worked a program, and she never went to meetings, and she never got the recovery that I did. And to this day, she lives a very bitter life, and it's very difficult for her. And I just, you know, I think it's so important that we maintain our recovery by sharing what we have learned with people who are new. That's what keeps us fresh for us. We have a tendency to forget what life was like before we got sober. And when we work with new people, it reminds us, oh yeah, that's why I don't drink. You know what I mean? And so these things have all worked for me in such a way that, you know, when I left my job before this one, it was because I had put together a family program, and the new clinical director started taking it apart bit by bit, and I just couldn't handle it. Didn't know what I was going to do. Posted on LinkedIn that, I was looking for something, and within a couple of days I got a call from Betty Ford. I wasn't even looking. I would never even apply to Betty Ford because I just thought, they'll never hire me. They're like the biggest, the best. And I interviewed. They hired me. I couldn't believe it. I spent the whole first year waiting for somebody to walk into my office saying, we really figured out you have no idea what you're doing and it's time to go. But here I am 5 years later. I can't believe I get paid to do what I do. I can't believe the stories I hear back from the people that I have worked with. Never mind the fact that the people that I have sponsored over the years have the ones that have stayed sober, stay in touch with me. The patients stay in touch with me. It's a really gratifying experience to not only see the light come on, but to see how the seeds that we plant begin to blossom and grow. And it's not always a thing that, a counselor gets to see. Even when you sponsor somebody for a long time, they sort of don't need their sponsor as much as they used to, and it gets to be a little lonely sometimes. But I can tell you this, that when I got sober this time, my sponsor told me that having HIV, being gay, and being an addict had to become the 3 best things that ever happened to me. And when he told me that, that was way over there. And I knew it was my job to get there. And I can tell you without a shadow of a doubt that I got there. I get it. In Japan, I talk to my patients about this all the time. In Japan, when a bowl breaks, they put it back together with gold so that the cracks become more valuable than the bowl. And what I tell them is that this disease is their gold. And how are we going to honor it? I think that's a great place to stop. If you guys have any questions, I'm open. I just want to share one more quick thing. When my grandmother passed away, we found out in the newspaper. So I rented a van, and all of us kids drove up in this van to Napa Valley and drove up to the monastery in Oakville. And there my parents were in front of the monastery, acting like parents in front of everybody. And I let my brothers and sisters out, and they went and got their hugs. And I parked the van and walked up. And when I walked up to my dad, I stuck my hand out. I'd never shaken my dad's hand in my life. And he had this confused look on his face. And in my head, I'm thinking, Brian, what are you doing? My dad shook my hand, and that was it. What I realized was that because I had done all these other things, the way my sponsor suggested, that there were things getting fixed inside of me that I didn't even know were broken. I could have never thought I would not need my dad's hug. And I just want to share that last story because that has been one of the biggest gifts that I have received out of staying sober, working the steps, helping patients, and helping sponsees. There you have it.
Thank you so much for sharing. And again, if anybody has a question, please feel free to unmute, or you can put it in the chat or direct message me. This is not a question, but a little bit of a comment on something that I saw in both of your stories. It was actually a quote that one of our earlier presenters had in one of their PowerPoint slides, but I think it said that the opposite of addiction is connection. And I thought that was really powerful because I think a lot of people say, oh, it's abstinence. But I think you both touched on that it's a lot deeper than that, and how both of you have, not lived a bitter life and enjoying your life is you've connected with people, the recovery community, family, friends, etc. And I think that's really a wonderful thing to be able to do, is to make connections.
Yeah, it's what sustains us. It's what nourishes us. If we, what we end up doing is we usually end up isolating, and then blaming everybody else for abandoning us, right? And because we think that if we're isolating, we're not hurting anybody, but even that's not true. our mere absence makes people have pain, so yeah, it's important to be connected.
And I think it's also important to let people know that they don't have to keep living this way if they're really, really sick and in that place. And, I mentioned like they immediately get back their time, their money, their energy. And I also tell them that down the line, if you stay the course and you do the repair work, you also get back the trust, the respect, the love. And, I could have never imagined my life like it is today when I was sitting in a treatment center. And enough that, my kids wouldn't trust me to go in the other room because I had stashes hidden everywhere. I might come back drunk. And my daughter trusted me enough to allow me to be her birthing coach for both of my grandsons. And my son-in-law trusted me enough. He handed me the scissors and I got to cut both their umbilical cords. And, so it goes from sick of the sickest to that. And I just wish everyone knew what's possible ahead for them if they get in recovery.
Yeah, well said.
So Brian, I had a specific question for you. So you had mentioned that you were drinking alcohol and had issues with alcohol and meth. And I was just wondering what the recovery process was like for those different substances, because from my limited clinical experience, it seems to look pretty different, just the treatment process for meth versus alcohol.
Well, I have to tell you that the detox from alcohol is actually much more dangerous, and really does need to be treated with comfort medication and anti-seizure medication. The detox for methamphetamine is very different in that you really just need to sleep and not get high. Having said that, there are many lingering effects with the effects of methamphetamine, especially if you're a heavy user. There might be audio and oftentimes visual hallucinations, delusional thinking, grandiosity. There's a lot of different things that people will be sober maybe for a month or two and there'll still be something is a little off. They still could have internal dialogue going on. I know that when I was on meth, I would see tree people. And that's about as much detail as I want to get into about my psychosis. But there is something known as crystal meth psychosis, and it does linger into recovery. But generally speaking, that stuff clears up, in a month or two, or maybe 6 months, sometimes as long as a year. I've seen it last as long as a year. So it doesn't really get diagnosed as schizophrenia or anything, but we can treat the symptoms. The symptoms are very similar. I think it's also very important to treat a crystal meth addict with some sort of an antidepressant in the very beginning, because what happens is when they get sober, there is this sort of pink cloud, this novelty of being sober, but there's always this heavy crash that happens sometimes 3 weeks in. And if they start their antidepressant, which usually takes 2 to 3 weeks to have an effect, it can catch them at that crash and carry them through to develop a longer sense of recovery with a stronger foundation. It may not be a forever medication, but certainly something to help keep them engaged through longer term recovery. Does that answer your question?
Yeah, definitely. Thank you.
Has that been your experience, Lori?
I didn't do meth myself.
No, but I mean, when you see the
yeah.
patients, yeah.
Yes, yeah. And I had a roommate that she was she would hit like pockets of fat where she would just totally go haywire months later. And so to be aware of what that is and that it might happen is really important for them too.
Brian, something you had mentioned when you were talking, I thought was really interesting. Just having come off one of my psychiatry rotations, you had said that people often get overconfident, and that can be a big problem sometimes for returning to use. And I saw it a lot when I was on inpatient psych, is that people would say, oh, I'm really confident to be discharged, and then they'd be back a week later. And so what kind of things could you know us as future physicians do to talk to patients about that overconfidence, so it doesn't seem like we're saying, oh, you're gonna start drinking again, but we can also help them be aware of that?
One of the things that I talk to my patients about is, one of the first things that I say is, I just want you to know you're going to begin to start feeling really good. And I do this on day one. I also want you to know that probably around week 2 or 3, you're going to begin to think, I've got this. And what I want to tell you right now is that when you get to that point, we're going to have a new conversation, because we never got this. But I also want you to be aware that that is part of the recovery process. This little moment of overconfidence, and so when that moment comes, they're like, oh, so this is what you were talking about, right? If we can give them a little heads up that this is going to be part of it, then they have a tendency to stay longer. Does that make sense?
Yeah, definitely.
Yeah, that's definitely one of the things that I do.
And then I think Cecilia, you have your hand raised. You can go ahead and unmute.
Yeah, hi. So on the topic of maintenance, being,
I'm having trouble hearing you, Cecilia.
clear about boundaries.
Hey, Cecilia, do you want to put your question? Do you want to put your question in the chat, and then I can read it off? Because I think your sound is a little bit off.
You think she heard us?
Cecilia, does that work to put the question in the?
I'm kind of driving right now, so I don't think I can text it, but that's okay then.
No, I can hear you now.
We can hear you now.
Oh, okay. Okay. Yeah, sorry about the connection. I just had a question about making amends and boundary setting. And what helped you when making amends, but also being clear on your own boundaries.
So it's really important to do no harm. One of the things that I stress over and over and over again is that you should, to my patients, is you never make amends without your sponsor's direction. Mm-hmm. They have a tendency to see a bigger picture, right? Because and you know what? And we want to hurry up and make amends to everybody, when we get sober and shout it from the rooftops, right? But the first amends people need to make is to shut up talking about the recovery. Never apologize, never, discuss it. You can acknowledge some of the behavior, but you do not apologize for it until you get to step 9. And here's what makes the difference. And I also tell them this when they first get to treatment, is I suggest that you only talk to your loved ones once a week, because if you talk to them and text them every day, they're not going to hear any difference in you. And they also want to, it will be a distraction, and, they also need their own space. But if you wait and talk to them once a week, they're going to begin to say things like, wow, you sound so different. And that's the best kind of validation for you. And it's a good way to give them some hope. Having said that, we have to be very careful with our amends. It has to be measured and planned and put on a list and done so with our sponsor, because there are different ways to make amends for different things. And everybody in our lives have heard, I'm sorry, enough. I apologize, they've heard it enough. This is going to have to be a sustained change in behavior over a long period of time, where people begin to see the change. And sometimes it might be best to make an amends 6 months to a year down the road. And sometimes the opportunity to make certain amends won't come for 2 or 3 or 4 years later. So it's really important to have a sponsor that guides you through that, so that, like when I made amends to my dad, you get the biggest fulfillment out of it. Bill and Bob were brilliant when they wrote the big book, because, they talked about how, we make amends so that we get the payoff, right? Because alcoholics and addicts don't do anything without a payoff. And, but yeah, so never do an amends without a sponsor.
And that's what I tell newcomers too. It's like the steps are in order for a reason. Do the steps in order only, and never do an 8, 9 without the help of other people with their eyes on it. Because we sometimes can't see the harm that we might cause. And there's such thing as living amends where it just takes time to make them. And then there's also indirect amends for people who have passed away, or people who we have lost contact with, that we can do to do our part. And the most important thing is to be willing to make the amends. And some people will not accept them. And that's okay. Everyone's entitled to their journey. But as long as a person has fully become willing to make the amends, then that's the most important thing for them. And as far as boundaries, I tell people new, especially, when I was drinking, if a person, place, or thing got between me and my drink, they were out of my life immediately, right? And so I had to take drinking out and put recovery there in that place. So that if a person, place, or thing was getting in the way of me and my recovery, or jeopardizing my recovery, I needed to eliminate them, at least temporarily, until I could get enough tools or enough stability to maybe interact with them. But the boundaries are what keep people safe, and it's okay to make them, and they might be temporary, and hopefully they won't be permanent.
Well, thank you so much, Lori and Brian, for talking to the students. It means so much to us to hear from your experiences and to learn from you. We're just really appreciative and grateful you're taking time out to do this for us.
My pleasure.
Thank you so much for having us.
Okay, so I think we're gonna take a quick 1 to 2 minute break before our next session starts, just so we can stay on track. So bye, Brian. Bye, Lori.
Bye.
Hi, Priscilla.
Hi, Michelle. How are you doing?
Good. I just noticed my camera is a little blurry. I don't know why. That just started yesterday afternoon, and I've cleaned it about 5 times.
That's definitely okay.
Okay, good. Good, good. Have you had a good day so far?
Yeah, this is our 5th session. So yeah, so I think students have been kind of picking and choosing which sessions they've wanted to go to, but there have been some people that have gone to, I think, every single one. But it's been really great so far. All the speakers have been wonderful. Our last session was Lori and Brian. They were talking about their recovery experience, which was truly just incredible.
Yes.
They both work at Hazelden Betty Ford Foundation.
Very good. Okay.
Yeah. So that's pretty awesome. Yeah, and I made you co-host, so you should be able to share.
Oh, great. Okay. I can go ahead and pull up my slides.
Okay, that would be great. Then maybe we'll just wait like 1 more minute or so, and then is Dr. Vito here yet? I don't think so.
Oh, I'm getting the option to turn on subtitles. Would you like me to do that?
Sure, you can if you want.
Great.
And then if you want to put it in presenter mode.
Oh.
Maybe under display settings, possibly.
Different screen now that I've done the captioning.
And you can also take the captioning off too. I think having a bigger screen might.
Okay.
More
Here, let me stop share and do it again.
Okay, that's fine.
Is that now showing up as slideshow?
No. Do you see at the top where it says display settings? Would that be up there? No, to the right of that? Or do you see in between in slideshow and taskbar where it says display?
So I'm seeing the taskbar. I'm seeing the show taskbar, and then right after that is mute. Stop video, security, participants, chat, new share, pause share, start summary, AI companion.
Oh, I guess that's okay. I mean, I think we can still see it. So that should be fine.
Okay. Yeah, it's not really giving me the option anywhere. All right. Should I go ahead and get started?
Yeah, sure. Go ahead.
Great. So hello, thanks so much for having me here today. My name is Michelle Dirst, and I'm the Associate Executive Director for the American Academy of Addiction Psychiatry. And I am going to talk today about policy. Really appreciate you all inviting me here today, because one thing we're very interested in is how do we try and get medical students more interested in treating patients with substance use disorders and into the pipeline. So I do have to do a plug because we have our annual meeting coming up December 7th through the 10th. In San Diego. Next year, we're going to have it in Naples, Florida, but we do have travel awards available for to attend our meeting, including for medical students. So that's going to open up. It's closed this year. We've given them out, but that will open up next year, probably in April, June. So we would love to see more medical students apply for it. We've had some really good candidates that have come, or people that have received the travel award that come back year after year, but we're very excited about trainees and really want to make sure that you feel involved, included. We do a number of trainee events leading up to the annual meeting. We do a prep call for the trainees to let them know about the annual meeting, make sure they know each other, and that they're connected going into it. So hopefully that's something that you'll look into. And if you have any questions, please don't hesitate to ask. So we do represent addiction psychiatrists. So these are our physicians that go through after psychiatry residence. They do that additional year of fellowship. One of the big issues that we have is a shortage of addiction psychiatrists. So when working with our members to identify what are our key priorities for working on the Hill, we're a small organization. We have about 30 staff, and we have grants that we run from the Substance Abuse and Mental Health Services Administration. And then we have the academy that really represents addiction psychiatry and trying to make sure that we're meeting their needs. And so working with our policy committee and our executive committee, we think about what do we need to go to the Hill with congressional members, and then also policymakers and the administration about how do we improve access to substance use care. And one of our big issues is improving the workforce through improving the number of addiction psychiatrists. 1,400 across the country really makes it difficult to meet the need as we keep seeing the rising rate of overdose right now, especially due to fentanyl, and has really become an issue across the country. And so we keep seeing those overdoses rise. And so we really need more people that can provide that evidence-based treatment, which is medication for opioid use disorder. We're also seeing methamphetamine increase in different areas. So making sure that we're delivering evidence-based care for stimulant use disorder as well. We actually just released a practice guideline on that with ASAM, the Addiction Medicine Organization, that we're very excited about. But the challenge that we're having right now is that only about half of our residency slots are actually filling. So we're really trying to think about how do we incentivize more people to go onto the fellowships. And we understand the challenges that you all have to be facing with obviously debt coming out. And so if you have the decision to continue to go on to do a fellowship or to continue or to go into the workforce. You know, obviously a lot of people they're starting to have families, and so they go into the workforce instead of that additional fellowship. Especially one of the challenges that we also have is parity in payment. So addiction psychiatrists, for providing the same service that a primary care provider provides, gets paid 23% less. So the other thing that we're really focused on is trying to do advocacy for parity in payment, because usually if you go on to get additional education, there's additional support for that, funding for that, reimbursement for that, but that has not been the case for addiction psychiatry, and something that we're trying to address, because obviously if we don't have the clinicians, then patients can't access the treatment. And so a little snapshot on our 3 priorities, because how we use these is when we're going to the Hill or talking to the administration, these are the 3 points that we hit on over and over again. And it takes time for a bill to usually pass in Congress. It takes 7 years from the time it's introduced. So my previous experience, I was policy director or policy expert for the Substance Abuse and Mental Health Services Administration. And I was also the lead staffer for the Senate Health, Education, Labor, and Pensions Committee, which is a Senate committee focused on health issues, discretionary spending. So it's not Medicare and Medicaid, but it's funding that needs to be appropriated every year. So I was the policy advisor to the chairman for the Senate Health, Education, Labor, and Pensions Committee, focused on mental health and substance use disorders. And so what's really helpful for us is, if you have organizations coming in, being very clear about what their asks are, and it takes time, and it's not just a meeting or 2 meetings to really create change. It's really thinking about, how do you build coalitions? How do you get your message across in different ways? And really what's important too is making sure that you have for the different delegations, the different congressional offices, that you have members engaged. So that's why you all are so incredibly important when it comes to our policy work, because especially when I was on the Senate Health, Education, Labor, and Pensions Committee, I knew what I didn't know. And I really needed that expertise of those people that were working in the field. I loved it when I would get a meeting with clinicians coming in, and they would talk about what they were seeing on the front lines. And, sometimes when you get lobbyists, which I have also been a lobbyist, we have our talking points that we go into. And so it was always very refreshing to hear from the people that are on the front lines. So really getting involved in the advocacy work and the policy work, trying to help wherever you end up landing, getting involved in your organization, whether that's American Psychiatric Association or a subspecialty like ours, which I hope that you do. It's getting involved because we really need that expertise to help us set our priorities, but then also raising awareness and visibility on the Hill and reaching out to congressional staff. So kind of our main priorities are the Health Resources and Services Administration, their Substance Use Disorder Loan Repayment Program. This was a program that was created 5 years ago to provide a loan repayment for substance use disorders in general. And then also there's another program that was created called the Addiction Medicine and Addiction Psychiatry Fellowship Program. And the goal of that program is to incentivize people into addiction medicine and addiction psychiatry. So it creates spots, but then it can also help to improve the experience of those in the fellowship by expanding where people may do their rotations, such to underserved areas. So that's been a very valuable program that we've asked Congress to continue supporting. And then the provider clinical support system for medication for opioid use disorder. And this is beyond addiction psychiatry. This is a program that hopefully you all are aware of. It is for education and training for substance use disorders. It was started when the data waiver was first created. So it provided that 8-hour training that was required to prescribe buprenorphine. The money has stayed about the same for the past 13 years, but we've really been able to use that money more efficiently. And so in addition to that 8-hour training, which now has been repealed, but there's still an 8-hour training if you want to prescribe controlled substances through the DEA, you have to receive 8 hours of training. We do have free and quality courses that will meet that requirement. They're virtual, so that's something that we're really promoting because, again, it's free. There's a lot of organizations right now that are advocating for the 8-hour training, but they cost money. So this can help to meet those that need to meet that requirement. But then what we found is when people take one of our courses through PCSS, it's a starting point to learn about substance use disorders. They need more courses. So we've added on to it, and we see people taking our 8-hour training and then our webinars, and we have clinical roundtables and a mentoring program, which I think could be of interest to you all as well. There's where you get connected with a veteran prescriber, and that's where we found has been really important to make people feel more comfortable treating patients with substance use disorders, especially with medication. And so one thing with for the HRSA loan repayment program, we call it the STAR LRP program. So we're asking for $75 million, which Congress is in the process of reauthorizing a bill called the Support Act, which created this program, and it was passed 5 years ago to address the opioid crisis and the rising rates. So it's up for reauthorization. The House and Senate are working on bills. The House has passed a bill through the key committee that drafted its bill, and it included this program to reauthorize, a little bit lower number than we wanted. I believe it's 15 million, and we want to increase that to 75 million. And then the Senate is in the process of working on their legislation. We're hoping that it would get done this year, but it looks like because of everything happening right now with the Speaker of the House and the need to get through different appropriations bill, it might be pushed until next year. But one thing too that's been really important with this program is it's something that we supported, but when we started talking to our members, we found out they were not eligible for this program. And when we dug in a little bit deeper, it's because there's this direct service requirement that you have to provide 90% direct service to be eligible. So you see the statistic that there were 255 awards given out by HRSA, but only 5% went to physicians. And we think because physicians are also required to do the consultation work, the administration work, education, research. So for them to actually only be doing 90% of direct service is really difficult. And we've had members one in California who said, I do 80% of the work that I do is for Medicaid patients, but it's consultation. So I'm talking to primary care providers about how to address an issue. I'm talking to other providers about how to improve the treatment that they're providing for substance use disorder patients. None of that counts, so he is not eligible. And we keep hearing those stories over and over again. So again, that's why it's really important to hear from you all and your experience, because nobody was really aware of this until we started speaking out. And really what Congress wants with this program is to make sure that we're improving access to medication. But if physicians who are the prescribers are not able to access the program, that's an issue. So now it's something that we're working on to address that and try and provide more flexibility. And then, as I mentioned, the addiction medicine and addiction psychiatry program is another one, really trying to figure out how do we incentivize more fellows into the program, both trying to improve that rotation experience, but then for those areas that want to add slots, we've heard from, I think it was Massachusetts, one of the academic centers there went from 1 to 3 slots, and they have been able to fill those 3 spots. So that's been really helpful. Others have been able to go into communities and have a rotation for their fellows in underserved areas. That has been really important to get that exposure and that access. So something that we want to make sure continues. And when we decided to advocate for this program, what we also have done, we pulled together a work group of all of our members who are program directors who received this grant. And we said, okay, what did you learn about this program? What was helpful to this program? For our members that might be applying for it next year, what should they be thinking about lessons learned for them? So really that education between each other to understand how to, apply and be competitive for these grants. And then also just sharing lessons learned and how important it is. So again, that expertise, that networking between our members is really important and helpful. And then, as I mentioned, PCSS, the Provider Clinical Support System, this is really focused on providing free and educational training. And if you go to our website, we have over 1,000 trainings that have been created since 2008. And I would say what's been really valuable about this program is our coalitions. And what has been so important to AAAP, being a small organization, is our coordination, our collaboration with other groups, because obviously we all need to work together to address this crisis with the opioids, but then also improve access to substance use disorders and treatment for substance use disorders. So really working, you can see we work with the American Academy of Pediatrics, American Medical Association on this grant, Society for Academic Emergency Medicine, National Association of Social Workers. So that really helps our reach to make sure that we are reaching not just with this grant, not just addiction psychiatrists, but all clinicians to make them feel more comfortable reaching patients with substance use disorder and really reducing that stigma that we know that clinicians feel with treating this patient population. And we have two really important curricula we have that might be of interest to you all. We have a Substance Use Disorder 101 core curriculum, and that has, I think it's about 23 modules focused on substance use disorder. Again, free. I keep on hitting on that number. It's free, it's free, it's free. But last year we had 22,000 participate in the core curriculum. And this year we already have 50,000. So we have really seen our stride with PCSS, the visibility of it. I want to say 6-7 years ago, we had a couple hundred in some of our trainings, and now we're having, you know, close to 100,000 a year, which is exciting because it shows obviously the interest now in treating patients with substance use disorder, but this need for education and training. We know clinicians need this education training, and it's incredibly important. So some more highlights. Like I said, we have in our mentoring program that I said would be available to you all free. If you want to mentor, you would be connected with a veteran prescriber. We have 203 mentors and 1,251 mentees. And then we also have, as I said, what we found is when people take one course, they want more to feel more comfortable to prescribe medication for substance use disorders and to treat this patient population. So we also have, it's called PCSS Exchange, which is 6-week sessions for people, kind of ongoing learning collaboratives that have been incredibly helpful. And then also for those that want to do that 8-hour training to meet that requirement, we have a free training for that. That SUD 101 would meet it. And then also an 8-hour training that we have. And then, so one of the challenges with this program, which is interesting, and it's a unique challenge, is because it was created with the data waiver, it does not have a specific, it's called an authorization. So when a program is created with legislation, it usually has, it's called an authorization that creates the program. And then the next step is to go to appropriators. And when I worked for the Senate Health, Education, Labor, and Pensions, I was an authorizer. So we just created programs. And then the next step was groups had to go to the appropriators to get it funded. So this program, because of the X waiver, it created it without a specific authorization, but it was tied to the X waiver and that requirement for that 8-hour training for education. So now it no longer has an authorization, but it has the appropriations, it has the money. So what we're asking from Congress is, could we codify this program and create it so that we can make sure that it continues ongoing, just because right now you never know, a program could be cut. It's a $1.5 million program. That's not a lot. That's kind of easy to cut or reduce. And it could be at the discretion of the administration to reduce that program. So we'd feel a lot more comfortable if we have an authorization. So that's been one of our main asks from one of our main congressional asks. And so how we really use the clinician expertise is we just had a virtual advocacy week. It was middle of October. And so our board met with their congressional delegation, the staff, and I think these meetings with the staff are incredibly valuable. It's helpful to meet with the members, but with the staff, you can sometimes have longer discussions, more candid discussions, and really get into the expertise. But it's to connect our members with their delegation and their staff members and create that relationship that we hope will continue to be ongoing, and also let them know, hey, we're here to help you. You have some amazing expertise in your district, in your state. Please feel free to use us anyway. And what kind of came out of some of these meetings, which was really helpful, is an organization might say, oh, I'm introducing a bill on substance use disorders. Can you look at it and support it? And so we ended up signing on and endorsing a couple pieces of legislation that came out of our members making those connections with their delegation. And again, that's where we really need, it's helpful to have clinicians be involved in the advocacy work and taking the time out to meet with the congressional staff, because it's really effective, and congressional staff do appreciate that expertise and hearing what's happening on the front lines. So then we followed up that advocacy week with a congressional briefing that just took place on November 5th, I believe it was. And it turned out it was very helpful. We had about 75 people register for the meeting, and we went over the key asks that you just heard, and we had experts talk about these, and we had it supported by the Addiction Treatment and Recovery Caucus in the House, which is bipartisan, Republican and Democrat. Because one thing we want people to understand is this is a bipartisan issue. This is a bipartisan bicameral issue. And what we have seen on the Hill is both the Republicans and Democrats have found that this program have understand the need to address the issues with substance use disorders. The amount of education that has happened since I started on the Hill. When I started on the Hill back in 2005, what the discussion was, substance use disorders is a moral weakness. I have not heard that in any meeting in probably a decade. When I started, we didn't have parity. And there was a concern. I was one of the staffers that helped with negotiating the mental health and substance use disorder parity bill. And, you know, it was a real uphill battle getting parity initially. And then that was kind of the passage of the Mental Health Parity and Addiction Equity Act came right before the start of when the Affordable Care Act was considered. And Senator Kennedy's staff, he was the ranking member when my member was the chair, said at the time when they started working on the Affordable Care Act that I think what we had put together for the Mental Health Parity and Addiction Equity Act, working in a bipartisan manner with stakeholders, kind of became the model for the Affordable Care Act. But when it came time, what we realized with the Affordable Care Act is that they included parity, but it would have not really applied because parity only applied to the large group market. And we really need, and the Affordable Care Act focused on the individual and small group market. So we went and let members of Congress know, like, this does not include the small and individual market. And I'll never forget, there was a finance markup, and it was brought up that the fix for this issue, and it was just, 3-4 years earlier where there was a lot of disagreement about parity. And the chair said, we should pass this amendment. Quite frankly, this is the right thing to do. And it passed unanimously, which was unbelievable. And then when there was the effort to repeal the Affordable Care Act, and some of the main reasons, and we had many different groups coming out and saying why we shouldn't repeal the Affordable Care Act, is because people with mental health and substance use disorders need this coverage. So you can really see that change from Congress. Just 2005, us having to just felt like it was those groups that represented mental health and substance use disorder groups that were really saying we need parity. And now you see so many groups that recognize it and are advocating for it. And so that's when, kind of looking back, you can see that we still have a long ways to go in breaking down stigma and making changes and reducing barriers, but you can see the progress, and to see that bipartisan support is really important. And then the other thing is obviously the expertise of clinicians on sharing testimony, testifying before congressional staff, attending federal meetings for us. And then, as I mentioned, how we created our policy priorities is a policy committee. So participating on that policy committee and providing feedback on legislation, on regulations is so valuable to us, because again, you all are on the front lines. You are the ones that can tell us what really needs to be done, what is really happening, what are the barriers, what are the opportunities. So with that, I see Dr. Vito, who is one of our fantastic members and also a lot of experience with Congress. So he is going to take it over. And just a final, here's our website for the Provider Clinical Support System, and then AAAP. And I will.
Great. Thank you so much, Michelle, for that. I guess I'll be sharing my screen. Can you guys see my screen?
Not right now.
Oh, sorry. Okay. We'll wait for you, Priscilla, then. Can you see it? No?
No, did you go to the share screen down at the bottom?
Yep, I'm on the shared screen, desktop, sharing. Still
Dr.
not going through.
I think you sent me. Do you want me to see if I can pull it up and you can just tell me next slide?
Sure.
Okay, I'm happy to do that. I'll just pull it up.
Thank you.
No problem.
And Michelle, I can also do it too if you can't pull it up for some reason.
Great. I think
I'm so fortunate to have like two backups, a backup and a backup and a backup.
actually I know you sent it to me, but for some reason it is.
Priscilla, can you pull that out?
Yeah.
Yeah.
Okay.
Give me 1 second.
Oh, actually, I just got it. Okay.
Oh wait, here we go. I got
Oh,
it.
you got it? Okay, perfect.
Okay, but let's see if I can put it in slideshow from the beginning. Okay, can everyone see it?
I can see it.
Okay.
Okay, fantastic. Thank you so much, Priscilla. So, hello, everyone. Thank you for joining us. I'm here to talk about advocacy, why each one of you need to be an active advocate, and how to become an effective advocate. My goal of this talk is for you to be comfortable doing this. Next slide, please. So my name is Jose Vito. I'm one of the co-chair of the membership committee of the American Academy of Addiction Psychiatry. Just one of the things that we do at AAAP is that we match mentors and mentee. And just a little plug, hopefully we'll see some of you next month in San Diego. That's our annual meeting. We always give travel grants for trainees. I have no disclosure. Next slide, please. So why should I advocate? It is human nature that we tend to make excuses. I'm too busy. I'm just a student. Who will listen to me? My opinion really makes a difference. Next slide. The answer is an emphatic yes. Yes, you can. Legislators see us as experts in medical health, including mental health issues. Next slide. You're probably saying, what made you, Dr. Vito, such an expert about advocacy? Just a quick background. In my 4th year as a psychiatric resident, I applied and was awarded the Congressional Fellowship in Capitol Hill, Washington, D.C. I was fortunate to have mentors who recognized that besides Dr. Vito complaining, they recognized that advocacy is my passion. I did not know that at that time. And my program director allowed me to use this as my 4th year elective. I was actually one of the staff in Capitol Hill in Washington, D.C. And at that time, I was working with a Democrat, Senator Hillary Clinton from New York, and also the Republican Senator Gordon H. Smith from Oregon. I was thrown in, started working as a staffer on day 1 as soon as I got my ID. I have to quickly learn and adapt to the different lingos and languages of legislation. I have to learn how to move a bill and how a bill becomes a law. So this really brings back good memories for me when I was a medical student, my first day at the unit or emergency room, and I just have to keep up with my assigned patients. Next slide. As a congressional fellow, what was my typical day like? My training helps me explain complicated medical terms in layman's terms, such as what is substance use disorder? What is bipolar disorder? What is K2? I advise them where the system falls apart and what alleviates the issue. Workforce issues such as student loans. Next slide. When I worked in the Senate as a congressional fellow, part of my role was to meet with the senator's constituents. That means you who are voters, and hear the concerns. They would hand me written documents with data about why their issue was important. I communicated their concerns to the senators and also kept the handouts and their contact information in our files for future references. As bills were introduced, and some of the staff would call these contacts and relevant documents in deciding how to vote. Next slide. So you're probably asking, why would an elected legislators listen to me? Why me? Because you are experts and you are who the legislators want to hear from. You, all of us, are all on the front line and you know what is going on in your school, your student loan, your hospital, and where you rotate. Therefore, you are an asset for them, especially if you mention that your constituents and that you vote, because you will be the voice of your patients and you represent our profession. Next slide. So there are different ways to be an advocate. Michelle Dirst mentioned this. You can meet them with your legislators in person or virtual, attend a town hall meeting where legislators will be speaking, call your representative's office with a clear message. Next slide. When you do have these meetings, here's just a couple of do's and don'ts to guide you. The first 5 minutes sets the tone. You usually be meeting with the key staff instead of legislators, so do not be disappointed if you meet with the staff instead of legislators. The key staff aide are more often more familiar with the specific policy issues than their bosses. They're the best positioned to listen to your point of view and advise the legislators of your concern. Let's take the analogy of the emergency room, right? So the patient usually meets the nurse, then the students, medical students, social worker, psychologist, and lastly, the attending. So keep in mind about gatekeepers. Next slide. It is so important to establish a good rapport. Generally, politicians want to avoid controversy. They want to get re-elected. As seeing a patient for the first time, it is important for us to develop a rapport, make them feel at ease, facilitate the process. Start with a compliment. Thank you for taking the time for meeting with me. Believe me, this makes a big difference. They think that you are not hostile. Remember your psychiatric rotation. Next slide. Preparation is key. You have about 10 to 15 minutes to present your case. It's imperative that you know exactly why you are meeting with them and what you hope to accomplish. Remember, you are an asset to their office. You offer a professional expertise and the knowledge that goes with it. When it comes to mental health issues, you possess a wealth of information regarding the current state of mental health back home. Next slide. Communication is critical. Be concise, be clear. What is your message? Try to pick 3 points that you want them to remember. Since time is limited, try not to cover too many issues in one meeting. If you talk about too many things, your message might not come across. For example, when I saw a constituent who actually brought a laptop with a PowerPoint, and she was talking 100 miles a minute without taking a breath. My boss actually had to stop her because she was talking on and on and on. So therefore, keep this simple. Next slide. Don't threaten, insult, offend, preach, or write off anyone. Try not to be too confrontational during your meeting. Present your case in a straightforward and persuasive manner. Be proactive and make sure you have enough time to discuss your issue. Next slide. Do take the initiative, offer solutions, and ask for specific action. State the issue you want to discuss. What is your position? What action you want the legislator to take? Back up your positions with facts and personal anecdotes about why it's important for the legislature to take your position. Next slide. Do tell personal stories. Explain how your issue affects real people. It's not always clear to legislators how their votes on the bill impacts their constituents. If you illustrate how individuals are personally affected, the legislators may realize the impact the bill in question could have on the people they represent. Show how the issue affects everyone, not just you, how the policy is or isn't working for you, your practice, and your patients, how the policy can be improved to make things better locally. Next slide. Stick to the issues and remember that you are educating the staffers. Avoid clinical terms that could be misunderstood and medical jargons. This actually happened one time, and the staffer actually walked out, not just feeling stupid, but feeling offended. So the message did not come across. Therefore, focus on limited issue. Next slide. You as constituents carry a lot of weight. You are a priority because you vote. So if you are the constituents, identify yourself as such and describe your role within your community. Remember, you are not just an asset because of your knowledge, you also vote. Next slide. So why should we advocate? Because student loans, right? And access to mental health care remains to be an issue. There's a persistent restriction and discrimination in the treatment of psychiatric patients. I learned that stigma is alive and well in Capitol Hill, and the severely and pervasively mentally ill population that we serve is often ignored during budgetary decisions. Next slide. Research have shown that if students see mentors and role models engage in advocating for patients and the profession, they will experience advocacy as part of their professional identities. Research has also shown that if students learn advocacy skills during your training, they will be empowered to use them in whatever setting they choose. So this is not just based on research, but this is also, I'm speaking from my own experience. Next slide. So medical students are increasingly interested in being more effective advocates on behalf of better care for our patients and our communities. As professionals, we are all very frustrated by the cultural stigma of mental illness and the misinformation about emotional and mental disorders that's very rampant in our society. And student loans. What was the experience for the students who did advocacy? They find it energizing and empowering. They realize how that legislators know about their training and the medical profession. They were an integral part of grassroots efforts that they can improve people's lives and about our profession. Next slide. So just remember, yes, you all can make a big difference. Thank you.
Thank you so much for sharing. I definitely learned a lot. I think advocacy is something that a lot of students want to become more involved in, but don't really know, how to go about it. So I really liked how well you laid that out and, just the do's and don'ts. That was wonderful. So if anyone has questions, you can raise your hand and then unmute, or you can put them in the group chat or message me directly.
And yes, please contact us at AAAP. We could be your resource. Any professional organizations that you have, there's always an advocacy department. But definitely at AAAP, or even you could contact me. I could definitely help and walk you through advocacy. And I think it's important, it's important to be part of your training, to be accountable, talking to legislators, especially that this is part of our profession. And, we need to advocate not just for our patients, but also for our profession.
I had a question, Dr. Vito. So how do you balance being a clinician, but being a clinician advocate? Because those two things are very important to me, but I think, oh my gosh, they're both huge tasks and can be very draining. So how do you go about doing that?
So I'm a clinical assistant professor at NYU. So I have students with me. Very good question, by the way. It is not a big burden to do this. It is so easy just to set up an appointment with the legislators, but making sure that I have my talking points through AAAP. They put our talking points together. And so that it's very, very efficient, meaning it only takes 10 to 15 minutes to talk to the staffers. I also sometimes bring in my students with me. So it is really not a burden. It is not a big deal. And it does not curb in a lot of time in my schedule. I think for me, the most important thing is to have that relationship with those key staff members in the legislation, because they do call me. If they have a question, they call me, they ask me questions about certain bills. And if I don't know, then I call Michelle Dirst, AAAP, and ask them, okay, what do I do now? So there's always support. I think what I want our audience here to know is that you are not alone. And all professional organizations have this advocacy department. And so if you are lost, here at AAAP, we are here and we can give you guidance. Hi, Michelle.
I spotlighted both of you just in case people also had questions for Michelle. Dr. Vito, that definitely makes a lot of sense. I think my initial perception, and probably a lot of students too, is that, you know, being an advocate takes a lot of time. And I think maybe it's just making that initial step of making contact and developing that relationship. But then from there, like you said, maybe it's just 15 minutes, you know, every once in a while, just so you can make sure your legislators know what the issues are. Maybe this is a little bit different, but I am always curious about how psychiatrists can advocate for their patients within hospital systems. I just got off of a psych rotation, and it was at a private psych hospital, so not connected to university or whatever. And I always found the psychiatrists struggling within, you know, with the hospital administration. And I know that's a little bit different than government advocacy, but I was wondering if you had any advice about that kind of situation too.
So first of all, advocacy is not hard. It can also be fun, right? In terms of advocacy, with legislators, you could even go to a town hall meeting, right? You could even do a one-to-one. Now, in terms of your question about advocacy within the hospital setting, I understand it can get very, very frustrating with administrations, right? And also trying to advocate for your patients, since sometimes administrations want certain things to happen and they don't have a clear idea what is really needed, especially we are on the front line. I think it's important to have that face-to-face with administration, make them understand the reason why whatever policies that they have at the current policy is not working. I think examples is very important. I also think making it a personal story is very important. So going back to your question, this is not different to just talking to the legislators. It's the same thing. The legislators need to know whatever bill that they have or whatever that they had signed on or not signed on, how it impacts the hospital, your profession, or even your patient. So this is not so different. I think it's important to do the personal story and how it affects you as a doctor.
That definitely makes a lot of sense. I definitely think as far as the working with hospital administration, that is 100% something all of us will be encountering if we haven't already as medical students, at least in the future.
Oh yeah, and believe me, it just does not stop there. I mean, even if you say, "Oh, I will not work in academia or the hospital, I will work in private practice," even that, you will see how sometimes it gets very frustrating how policy are done, and so it is important for us to really talk to our legislators. And as I said, it can also be fun to have that relationship. Most of these legislators also have town hall meeting, or even they have like a get together. And if you have that relationship, you get invited. For example, I could give an example. When I was in Capitol Hill, I was in the men's bathroom and I was next to, Senator Kennedy when he was still alive. And I've seen, how things are moved, they shake hands, and how bills get, how they pass, how they sign on bills. And you see how they're negotiating, and it's so fun. And not only that, is like you learn how the skills that can help you throughout your career. So this is a good thing that you guys need to learn on as student early on. And I'm still using my skills that I learned there. I'm still advocating. And I think it's also important to have this part of your curriculum to be advocates, how to negotiate in terms of policy and communicating effectively. And it's a skill that you will learn and help you throughout your career.
And I would just add, there's such opportunities too to do like what Dr. Vito did was do a fellowship on the Hill. We have right now our another one of our members, Dr. Ebony Caldwell. She is actually right now doing a fellowship on the Hill, which is fantastic to have her there, because it just helps to, again, increase that knowledge base, because she becomes a resource to not just her office, but others on the Hill as well.
And visibility. Right? If they see us and what we go through in terms of in our own setting, because remember, we are all the front line. So it's important that they recognize us. Visibility is so important. And right now, I don't think there's only like one or two physicians right now as a lawmaker. So it's like very, very limited. And these are the people that, make in terms of policy, make or break it, right? So they need to know that we exist and our priorities is for our patients. And as I said, it can be fun. And just to let you know, my experience there in Capitol Hill has been fantastic. I've met so many wonderful and powerful people. And, just being sometimes rubbing shoulders with them, you learn so much how a bill becomes a law, right? And so I encourage everyone to be part of this and be part of this system and learn how to be part of this and to learn how to negotiate and part of their career. So it's a fun thing. And those parties. So
Michelle, sorry, go ahead. Go ahead.
No, go ahead.
So I have a question for you just about how the AAAP decides like which bills they want to sponsor, which legislation. Like a month or so ago, the PsychSIGN board, we were going through all these different proposals that the AMA had published, and we were trying to see if we wanted to support them, and just going through the wording and all of that, it was really challenging. So what does that process look like for AAAP?
That is a great question, because I think that's one of the hardest things, is trying to figure out how do you prioritize, because right now there is so much interest in mental health and substance use disorders on the Hill. There was a point a year and a half ago when both the main committees Finance, Energy and Commerce, Senate Health, Education, Labor and Pensions Committee, and Ways and Means all had hearings and work underway focused on mental health and substance use disorder. As a small, and previously I was with American Psychiatric Association. I was a lobbyist with them, and then I was a policy expert. And even at that organization where we had a staff of about 20, 25 just doing policy and lobbying, still had this issue of how do we prioritize? And it's something obviously we have at AAAP as well. And you really have to figure out what are your key issues, because it just gets overwhelming and hard to track every single policy and every single piece of legislation. And then you also have regulatory comments coming out that you have to respond to. And we used to, prior to me coming on board, we were trying to, everything that came our way, we were trying to sign on to because it felt so important. So we've become a little bit more strategic and said, okay, how does this, obviously workforce has become incredibly important. So workforce is something we prioritize. Parity is something that we prioritize, recovery, prevention, some of those issues. So we've really, so we've had to kind of look at, and the best thing that I've seen done an organization do is kind of create a bubble of like, what are these big categories that are really important to us? And is the legislation within this kind of bubble, or is it outside? Like, would be helpful, but we just can't right now. And sometimes we also consider relationships with other groups, if a group, because you want to create those partnerships. So we sometimes think about when we get asked by another group to sign on to a letter or to support a bill, we think about like, obviously, if it's something, an organization we want to help out. So I think it's sometimes, what is the issue? Is it a priority that we have identified under kind of our strategic plan? Is it a group that we really work closely with that has been helpful for us, or we want to work closer with, and they ask us, then we might sign on to provide them support and help them out. So those are some of the key ways that we think about and consider legislation and which to endorse and sign on to. But it's hard. You just can't do it all. I don't think any organization can do it all with the amount and the volume that is coming out right now.
And I agree with you, Michelle. Even like all of us who are in the front line, workforce issue, that is such a big deal. I'm sure you guys seen during your rotations about the shortage of addiction psychiatrists, and it gets so frustrating. There's not enough of us. The other thing that Michelle mentioned is parity. Parity is another thing as physicians. When we even try like prior authorization, I'm sure you have seen your attending spending hours and hours on the phone trying to argue and convince the insurance company why this procedure is so important, how it saves lives, including the opioid crisis that is going on right now. Here, I'm in New York City. Michelle mentioned about PCSS training. Again, not enough of us and are comfortable in terms of doing that training, including the opioid crisis. Xylazine is another big issue that's going on right now. Fentanyl, and I'm sure you guys are exposed to this type of issues during your rotation. So these are very important issues that as clinicians, we need to bring to our professional organization, including AAAP, and say, these are important. These are what we're seeing in the front line. What can you do, or how can you help us? And then the AAAP will help navigate you in terms of making this known and present to your legislators. So talking about priorities, you matter. Your priority is our priority. So that's important.
I think maybe, oh yeah, so we have 8 student research presentations tomorrow, and one of them is on xylazine. I know on the West Coast it's actually not a huge problem yet, which I feel very grateful for, but I know on the East Coast it really is. So I'm really interested to hear more about it. I just put it in the chat just in case. We have time for maybe about one more question if anybody has one, or maybe if people need a bathroom or break or water break, that's also okay too. I know it's our final session coming up.
And if anyone has any questions about the Congressional Fellowship, interested to learn more about that, or even what triple AP can do, feel free to email Priscilla and she can forward you my info and Michelle Durst info. And I'll be happy to talk about my experience and also about what our organization can offer.
Yeah, I would definitely recommend joining AAAP and also ASAM, the American Society of Addiction Medicine. I've been a little bit more involved with AAAP lately. They're both great organizations, but just starting as a student is great, and especially because a lot of the memberships are free as a student. So definitely take advantage of that when your early career, and then you can really figure out which ones you want to invest your time in.
And I also want to plug in the thing that we do as a membership committee is mentorship. And that has been like the #1 request from students, that they want mentorship. And that's what we do well on. So again, please contact Priscilla if you have any questions about AAAP mentorship program for students, and we could make this happen for you.
And I actually got one, looks like potential in the chat that direct messaged me, which is fantastic. Very excited about that. Would love to have more. And thank you, Priscilla, too, for mentioning that it's free and available. I'm so glad that you're involved as well. And thanks for having us today. This was a lot of fun.
Well, thank you.
Thanks.
Sorry, go ahead. Go ahead, Dr. Vito.
Thank you for having me. And I always enjoy talking to PsychSIGN. I wish there was PsychSIGN when I started. So this is such a great resource for students. And again, AAAP, we welcome students. We have space for you.
Well, thank you so much.
Bye-bye.
Okay, so in just a few minutes, we're going to start our next session. Feel free to go get water, take a bathroom break, and just be back whenever you're ready.
Okay, great. Can you see that? Okay.
Yes, do you know if you can put it in the full presentation mode?
Sure. Does it, it doesn't look like it's not in full presentation mode.
It looks
you?
like it's in, I think, presenter mode. So would you the next slide?
Then in that case, yes, just give me 1 sec.
There we go.
Perfect. Okay, great. Doesn't look like it's in presenter mode for you, right?
No, it looks
Okay. Awesome. So, hello everyone. I'm Sammy Hamden. I'm one of the addiction medicine fellows at the Yale program for addiction medicine. I'm joined with Dr. Borelli, who is one of our attending faculty in the program. And so we want to talk with you a little bit about buprenorphine and methadone dosing, pearls and pitfalls, and sort of just work through some general information and then also some particular issues that you may experience or have experienced as you're working with some of these medications. I'm certainly always available for questions, hopefully at the end and then also afterward as well. So just to briefly talk about this, I think this is a pretty well sort of established figure at this point, but really since the late 90s, we've had a staggering rise in the rates of opioid overdose, of overdoses in general, but currently being really driven heavily by synthetic opioids. So that's most frequently fentanyl or other what we call high potency synthetic opioids. And really sort of, despite some treatment, we really sort of need to really aggressively pursue treating patients to try and manage and prevent more overdose and more harm. So thinking about opioid overdose mortality, of a study that showed patients who presented to the ED who received naloxone by EMS, 6.5% died on the same day and 9.3% died within 1 year, which is truly a staggering mortality rate. And really, this is a 13-fold high increase in 1 year mortality compared to the general population. When we're thinking sort of broadly about patients with opioid use disorder, so of these sort of roughly 8 million patients who are estimated to have opioid use disorder in the US, only less than 300,000 received MOUD, which is medications for opioid use disorder. Which is really a huge, tremendous gap in care and really presents a really important opportunity for us to try and provide a lot of education, because at least starting or continuing or restarting a lot of these medications should really be within the scope of all practitioners, not just addiction subspecialists. So when we're thinking about number needed to treat, this is sort of the statistical model for sort of how many patients need to receive a treatment in order to achieve a benefit. And if we're looking at some of the most commonly used medications that we have, statins, aspirin, steroids, we're talking about 104 patients needed to treat to sort of receive the benefit. Aspirin, 42 patients to sort of lower the risk of a STEMI, and so on. For buprenorphine, based on some research, to manage sort of the risk of opioid use disorder, the number needed to treat is 2, which is, basically showing that it is a truly staggeringly effective medication. Certainly some of the specific numbers will vary a little bit depending on which study you're looking at. But overwhelmingly, the data is really consistent that there's a very significant both morbidity and mortality benefit to treatment with buprenorphine and methadone. To go through some of the medications for opioid use disorder. So methadone is a full opioid agonist. It acts sort of similarly to all of the other full agonist opioids that we know, hydromorphone, oxycodone, fentanyl, but it has a sort of variable half-life that we'll talk about a little bit later. Importantly, a huge limitation for it is that a practitioner cannot prescribe methadone for opioid use disorder in the clinic. Methadone can only be prescribed in an outpatient treatment facility that is designed to provide methadone, which is a methadone clinic, or in an inpatient facility like a hospital. Naltrexone, I'm not going to talk about too much, but is an opioid antagonist. So this blocks activity at the mu opioid receptor for other opioids. And if it's given IM, the effect lasts for a month. Really, the important limitation is that it should be used 7 to 10 days after any opioid use. The data in studies looking at naltrexone has found sort of that in like ideal settings, and in some sort of real life settings, there is some benefit to it. But overall, it does pose a lot of challenges. First, that it has a significant issue with follow-up and retention in treatment. And then also practically for sort of many of us who are starting MOUD, it is really difficult to start a patient on naltrexone because they need to have been off opioids for a sufficient period of time. Otherwise, you'll precipitate withdrawal. So for that reason, we're sort of not going to talk about naltrexone for the remainder of the talk, but it does exist as a medication that is FDA approved for the treatment of opioid use disorder. And then finally, there's buprenorphine, which is a partial opioid agonist. So this acts with partial activity at the mu opioid receptor. It has a high binding affinity that we'll talk about later, and can be prescribed in the clinic, but it does require follow-up and like ongoing follow-up in clinic, usually with relatively frequent follow-up in order for patients to be able to continue on it. When we're looking at buprenorphine and methadone, there's really a pretty significant benefit to prescribing them for the treatment of opioid use disorder. So significantly, only 3 in 10 patients receive medications for opioid use disorder over 12 months, according to a study done at BMC, Boston Medical Center. However, among patients who received methadone or buprenorphine, there was a significant decrease in mortality. So along the lines of 50% for methadone and nearly 40% for buprenorphine. A huge portion of sort of the factors that affect the sort of some of these things is sort of retention in care. But nonetheless, you can see that, I mean, there's truly relatively few medications that we have that have this level of efficacy when used consistently. When we're thinking about these medications for opioid use disorder, there is overall a 40 to 60% decreased risk of death for patients who are prescribed medications for opioid use disorder. And also, importantly, a 76% reduction in overdoses at 3 months. So really, this is leading to decreased sort of risk of harm for patients, both in terms of morbidity and in terms of mortality. So I will turn it over to Dr. Borelli to talk a little bit about methadone in particular.
Yeah, so methadone, this is a really powerful medication that I think is something that especially medical students need to be aware of, because they're going to encounter this no matter what specialty they end up going into. So this is going to be kind of practically what to know about methadone. Say you have a patient coming in and they were on methadone. How do you continue it? Do you need to increase it? Do you need to decrease it? We can get into some of the details for how we use methadone, mostly focusing on in the hospital. I'm going to go next slide. Okay, so starting methadone. So for someone who's not been on methadone, they come into the hospital, they have not been on methadone recently. Typically, the starting dose we start with is 30 milligrams on the first day, and then you can give an additional 10 if they're still having symptoms. You can supplement this, though, with short-acting opioids, and you're able to use these short-acting opioids to make the person much more comfortable. Because if someone is doing like 3 bundles of heroin a day, giving them 30 of methadone is going to be a drop in the bucket. They're still going to be very miserable in terms of withdrawal symptoms. So you can instead supplement with some of these short-acting opioids instead. We usually increase methadone by 10 milligrams every 3 to 5 days due to it having a really long half-life. And so you don't want to overshoot. If you overshoot because it has such a long half-life, you are risking them having to go to the ICU to get a Narcan drip. You definitely don't want to overshoot. So we try to increase very cautiously every 3 to 5 days to make sure that we're not going past the mark. But while you're getting them up to that appropriate dose of methadone, you can supplement some short-acting things like oxycodone, hydromorphone. If you're not quite sure about their tolerance, for example, if they've only been using like prescribed oxycodone and not too much, you can split the dose of methadone while they're in the hospital. This is quite easy. You can split it into 3 times per day. For example, if someone has COPD, they're elderly, they're not using a lot of heroin. The conversion, though, is important. That you can't just do a direct conversion from, like, for example, if they're only using oxycodone, from oxycodone to methadone, it's a little bit more tricky. There's some dose-dependent conversions, and then you have to consider incomplete cross tolerance. So This is, you can't just go based on the MME conversion and go straight to, they should be on this much of methadone. So always with methadone, it's start low and supplement with short acting, because short acting is a lot easier to reverse than overshooting with methadone. So as we're talking about, methadone has such a long half-life that we like to increase it slowly every 3 to 5 days, just because if you overshoot, you might not see the effect of that until a day later, 2 days later. And so you have to be really, really cautious with increasing this. There's a few different ways to go about if someone comes into the hospital after having missed methadone. This happens very, very frequently. You'll be admitting someone for something else. For example, admitting them for like heart failure, and they say, I've been feeling so sick, I haven't been able to get to the clinic for the past week. And the question is, how much do you restart them on? And this kind of depends a little bit on if they were supplementing with opioids or not. If they were supplementing, they're a little bit less concerned about them losing some of the tolerance, but you still have that concern. But if they haven't been doing any kind of opioids and they miss some methadone, there's concern that their tolerance might have gone down. So let's say they were on 130, they missed a week, I'd be concerned to restart at 130. This is just an example of a protocol that we can use just to remember that you have to decrease the methadone dose if they miss days. But in addition to doing this, you're going to supplement this with short-acting opioids to make them comfortable. It's just that we don't want to overshoot with the methadone. There are some alternative options for someone who is not on methadone yet, and you want to get them onto a higher dose of methadone than going up every 3 to 5 days, but this requires very, very close monitoring. So for example, someone who's using a very high volume of heroin/fentanyl, let's say that they're using 2 bundles a day, they come in, like I said, 30 milligrams plus 10 milligrams, a total of 40 milligrams on the first day, probably isn't going to do a lot. So you can, instead of increasing every 3 to 5 days with really, really careful monitoring, you can increase a little bit more rapidly, but they have to be in opioid withdrawal while you're doing this, and no signs of sedation, and have a really high opioid use. So something that far exceeds, even once you get up to, for example, a higher amount like 70, that you expect that their tolerance is going to be way higher than the equivalent of 70 of methadone. If you mess this up though, you might need a Narcan drip. So really be quite cautious with titrating up methadone more quickly than every 3 to 5 days, unless you feel very comfortable with what you're doing. So a lot of our patients who have opioid use disorder, a lot of them have underlying chronic pain. And methadone for chronic pain, the pain control seems to be a little bit better when people dose it multiple times per day. So how to get people on multiple times per day dosing in the hospital, it's really easy. Outpatient, you just have to apply for like a government override from the methadone clinic. The methadone clinic has to apply for that. So in the hospital, let's say that someone before they came to the hospital is on 110 of methadone, let's make this easier, 90 of methadone daily. And they come into the hospital, they have worsening of their chronic pain, or they have acute pain, they just got surgery. You can split the dose while they're there. It's up to the patient preference. It doesn't have to be split all the way down the middle. It doesn't have to be 30, 30, 30, whatever they feel like works best for them. The trick is though, on the first day, it's going to be a little bit tough because their body is expecting 90 of methadone and they're only getting, say, 30 in the morning. So you're going to have to supplement with short acting while you're getting them onto the split dosing. But then ideally, by the time they get the third dosing, overnight, it's going to be so much easier. In the morning, it's going to be feeling a lot better. And so I just tell patients, the first day, we got to expect that we're not going to see the difference. It's really this, once you get that third dose on the first day, and then afterwards that you can say like, hey, this is working for me, or no, I prefer once a day dosing. In addition to chronic pain, some patients metabolize methadone more quickly than others. So these are the patients, they'll be on like a high dose of methadone. They'll say, hey, I keep going up on the dose, but I'm still having withdrawal symptoms. I'm still having cravings for heroin. What's going on? And then it can be, ask them like, hey, are you usually like the first person there to the clinic? You're feeling withdrawal when you wake up. They're going to say yes. You can actually do blood testing to see what their methadone level is before and after they get the methadone dose, to see if they're rapidly metabolizing, see if they're metabolizing more rapidly than other people, because otherwise you'll just keep going up and up on the methadone dose. They'll get drowsy during the day, but then they're feeling terrible by the morning, and you're just kind of not making any progress with this. And for those people, it can be really beneficial to get the split dosing from the clinics. And it's just an extra paperwork that the clinics have to fill out, another government regulation. So QTC, QTC, that's on the EKG, it's how the heart, basically the electricity for the heart for the first year medical students. What we worry about is that methadone can prolong the QTC. It seems to be dose dependent. Patients frequently, when they're sick, they will have a lot of other reasons for their QTC to be prolonged. But one of the big risks with this being prolonged is that you can go into arrhythmia that could be deadly. Especially when they're in the hospital, they usually have a lot of reasons for their QTC to be prolonged. So we say before even touching the methadone, we usually recommend just very aggressive electrolyte repletion. Make sure that the electrolytes are all especially magnesium, potassium, calcium, and then discontinuing any other medicines that prolong the QTC that aren't essential, because methadone is probably going to be one of the most essential medicines that they're on, and then repeating the EKG. And then if you do all of those things and it's still significantly prolonged, like QTC of like 600, then you talk with the patient of having like a risks versus benefits conversation. And like we said, it's usually it is dose dependent. So even making a small reduction in the dose can sometimes decrease the QTC. But I only really do this if the patient is on board with it, just because this risk of the arrhythmia, like you could take that into account, but the risk of decreasing the methadone and them overdosing is really, really high, and that's a very real risk. And then let's say that they have chronic prolonged QTC, we've done all this, it's so long. Buprenorphine is another option that you can discuss and just put that on the table for the patients. But at the end of the day, it's going to be the patient's decision if they want to start buprenorphine or not. Follow-up is super, super important. And it depends on where you are. Different places have different access to opioid treatment programs. Some places will say like, oh, we have an intake in like 14 days, which if you're starting them on methadone in the hospital, that's not at all helpful. Some places have walk-in clinics where you can walk in and get a methadone dose the same day, but frequently they're not open 7 days a week. So it's really important if you're starting someone on methadone to know your local resources. In Connecticut, we're really lucky in that we have a walk-in clinic that does methadone for 6 days a week. And anyone can walk in and get treatment. So it's really easy to establish follow-up. If it's any day except for Saturday after they got their dose, is really easy. We just have to keep that in mind, possibly keep them in the hospital an extra day, or there's a new thing where we can dispense methadone up to 3 days. But you have to keep that in mind, that you can't start someone on methadone and then they have an intake in like a week. That's not going to work out at an opioid treatment program. At first, when the patients go to the clinic for methadone, they're going to need to be taken daily. But since COVID, the rules have relaxed a little bit, and that you don't have to be on daily dosing for quite as long before you can get take-home bottles. But this is just something that patients have to be aware of, because this is a really big commitment to be going every single day to the clinic, at least at first.
So I'll now talk about buprenorphine, and then we should have plenty of time for questions, because certainly a lot of this is sort of the practice of sort of people who have seen these medications or use these medications in the hospital. So buprenorphine is the other medication for opioid use disorder that we're going to talk about. So how buprenorphine works, and so this is the sort of basics of the physiology and pharmacokinetics is very important for sort of for how it works overall and how it affects other opioids. So for a full, this is an example of a full agonist is in green. It's landing on the mu opioid receptor, and it is providing an effect in the sort of second pain. However, as you can see, buprenorphine also binds to the mu opioid receptor, but it binds much more tightly. So it still binds to the receptor and can displace a full agonist if there's a full agonist there. But it will have some effect, just not the full effect. And then buprenorphine still blocks the opioids as it dissipates. So in other words, buprenorphine's effect on the opioid receptor can last for a prolonged time. And these two key features about buprenorphine, the fact that it is a partial mu opioid receptor agonist, and it has higher affinity for the receptor than most full agonists, are really two of the key pieces of buprenorphine. There's lots of other parts, but these are really two essential parts to know about. So because of these factors, it really helps protect against opioid overdose, because other opioids will have a harder time, even full agonists will have a harder time binding and providing an effect. Unfortunately, in the fentanyl era, as in the high potency synthetic opioid, illicit fentanyl era, there is still possibility to have overdose with patients who are on buprenorphine, but still there is still some protection with buprenorphine. Buprenorphine also has a long duration of action, in the sense that it's sort of, if a person gets a dose, that dose should be felt at the very least for 8 to 12 hours for opioid use disorder, and often sometimes even up to 24 hours. And it can be given after naloxone-induced precipitated withdrawal. So if a patient is in the emergency department, they've had concern for an overdose, they've received naloxone, which displaces a full agonist opioid from the mu opioid receptor, and the mu opioid receptor is sort of sitting empty, you can start someone on buprenorphine. Otherwise, we'll talk about how to start someone on buprenorphine. It is sort of in terms of how it's administered, it's often combined with naloxone under one brand name, which is Suboxone. And I think important to know the brand name because it's by far the most common name for sort of brand name for buprenorphine, but there are many others. And when it's used in combination, the naloxone has no active effect when used orally. The only reason the naloxone is there in this buprenorphine naloxone combination is to try and prevent patients from dissolving the tablet or the film and injecting it, because when naloxone is injected, it will be active. So if you ever see someone who is receiving buprenorphine in the form of buprenorphine naloxone, whether that is Sublocade, whether that's Suboxone or some other sort of formulation, the naloxone doesn't actually have an effect. That said, like we talked about, and like we'll talk about a bit more, buprenorphine can cause precipitated withdrawal. So precipitated withdrawal is basically that diagram that I showed you briefly before. That's when the full agonist in the sort of bottom left pane is displaced by the effect of buprenorphine. So a patient is essentially like, the opioid receptor is like a car driving at 100 miles an hour with the full agonist, and then they get the partial agonist, and the car goes suddenly to 50 miles an hour. The car is still moving. There's still an opioid agonist effect, but the relative drop is so sudden that it feels like it is precipitated withdrawal, and it can feel terrible. It's not fatal, but it is incredibly uncomfortable for patients. And really one of the reasons that patients who have tried buprenorphine and had precipitated withdrawal are cautious about starting it. Buprenorphine, also just one other important point, is preferred in pregnant patients usually over methadone, but there are a lot of nuances there, and often we sort of discuss that in combination with our OBGYN colleagues. regardless of whether we start someone on buprenorphine or methadone, if they're pregnant, it's really always important to remember that whatever someone is on, it is safer than non-prescribed opioids. But buprenorphine orally is usually preferred for pregnant patients. So this is a little bit of what I was talking about earlier, and I think a really important graph to know. You may have heard, this is sort of a graph that shows the partial agonist effect. So if you have a full agonist, whether that's methadone, fentanyl, hydromorphone, it will continue to have an opioid effect up to the point of respiratory depression and then ultimately respiratory arrest. Buprenorphine as a partial agonist this is what's called the ceiling effect in green. And so that ceiling effect is basically a leveling off because it's a partial agonist and will ultimately not cause respiratory depression. There are some components to the activity of buprenorphine, like for pain, that don't seem to display quite this level of a ceiling effect. But certainly for some of the most harmful complications of opioids, especially respiratory depression, buprenorphine has this ceiling effect, which is truly the reason that we like it. And it is one of the main things that really makes it so much safer than other longer acting opioids. So precipitated withdrawal, this is, I think, an important thing to talk about because it is one of the dreaded complications of starting someone on buprenorphine. It's a thing that many of our patients who have tried buprenorphine sort of from friends or sort of, from the street may have experienced. It happens when someone takes buprenorphine while there are still full agonists on the opioid receptor, and it causes incredibly uncomfortable withdrawal, as we've talked about. So all of the things that you would see with opioid withdrawal in this diagram, including sweating, mydriasis, tachycardia, goosebumps, muscle cramps happen, almost immediately. So really, in certain circumstances, this is certainly a time that you would certainly want to talk to your addiction consult team if the patient is in the hospital, and you have an addiction consult team available. The answer is often to give more buprenorphine, but sometimes it's necessary to give full agonist opioids instead. Certainly, you essentially want to try and manage these horrible symptoms as aggressively as possible. So that certainly includes antiemetics like ondansetron, acetaminophen, hydroxyzine, which acts similarly to Benadryl, and sort of basically helps sort of soothe the patient a little bit. In certain cases, ketamine is necessary. Benzodiazepines are often necessary. And precipitated withdrawal really needs to be treated very aggressively. There are times that precipitated withdrawal is felt somewhat mildly, as in it's a mild precipitated withdrawal, in which case you may not need things like ketamine and a hydromorphone drip in the ICU, but you may need at least some agents. The COWS score is the clinical opioid withdrawal scale. For those of you who have heard of a CWA score for alcohol withdrawal, this is a sort of an adjunct. It's a thing that we use when we are worried about patients in opioid withdrawal, and is in the context of precipitated withdrawal especially useful. So it's a long scale that's done by our nursing colleagues, and particularly in the hospital, and really runs through sort of multiple both physical signs and also symptoms of opioid withdrawal, and basically can help guide management of withdrawal if it arises. So really the hardest part about buprenorphine is really starting buprenorphine, because once a patient is on it, they are on an opioid that in fact is in a lot of ways safer than most other opioids. So really the difficulty is induction, and induction particularly in the fentanyl era. So high potency synthetic opioids like illicit fentanyl are highly lipophilic. When patients are using these opioids chronically, they will have basically both a high tolerance, and they will also have ongoing levels of fentanyl despite withdrawal symptoms. So a patient, if they're, say, for example, using consistent high doses of high potency synthetic opioids, may feel like they're in withdrawal, and they may in fact be in opioid withdrawal, but they still have a fairly high concentration of fentanyl in their system partly because these are so lipophilic. And so Therefore, initiating buprenorphine becomes a lot harder because a patient will feel unwell and feel like they're in withdrawal and be seeking help. But then if you give them buprenorphine, can precipitate withdrawal. Because the subjective withdrawal is still sort of significant while there is still significant fentanyl in their system. And so that's why we have a lot of induction regimens for buprenorphine that can work in the fentanyl era. So induction is, honestly, is a fairly complicated thing. And there are, I hope many of you who may have heard of it, but it is still sometimes even standard induction is sometimes sort of not a well-known thing. So just to go over it briefly, this is sort of what we call the classic induction. So this is back in the days when patients were mostly using non-prescribed oxycodone or other short-acting opioids. This basically sort of the standard approach. So you have a patient hold their full agonist opioid. You wait roughly for their duration for that opioid's duration effect. So, for example, 12 hours for oxycodone. You monitor their withdrawal symptoms using the clinical opioid withdrawal scale, especially for the patient. And then once they start scoring, as in once they start showing signs of withdrawal, you can initiate buprenorphine, usually something along the lines of like 2 to 4 milligrams. It's unlikely that they would have had precipitated withdrawal sort of in a classic induction sort of for short-acting opioids, but you can treat it if it's present, and then essentially give additional opioids, give additional buprenorphine, usually about like an hour later. And then you after that, basically start someone on a daily dose. This really ultimately leads to a daily total dose of somewhere between 16 and 24 milligrams of buprenorphine. Unfortunately, in the fentanyl era, it's hard to do this for most patients because of the factors that I mentioned before. However, this is sort of the standard induction that we often reference. So instead of doing the standard induction, we often talk about, in the fentanyl era, a low-dose induction. And so the main benefit of a low-dose induction is that you do not have to wait for opioid withdrawal to begin treatment. The patient can have used opioids, and you can still start buprenorphine. The way this works is by prescribing very, very small amounts of buprenorphine, so that it may cause some displacement of the full agonist opioids on the mu opioid receptor, but not enough to cause true severe symptomatic symptoms of precipitated withdrawal. There is a little data. There's a pilot study showing benefits of this, and there have now been several case series showing the benefits of this, and there's some additional data that's pending. But this is an example of a handout that we actually give to patients along with some additional instructions, and it essentially shows what a low-dose induction would look like for a patient who is on methadone and taking methadone and intending to transition to buprenorphine. So the idea is that it's sort of mapping out days 1 through 7, and the patient will take small but increasing doses of buprenorphine each day. It's enough to get buprenorphine into their system to start replacing the full agonist with buprenorphine on their mu opioid receptors, but not so much to cause precipitate withdrawal. A really important point about this is that the patient needs to continue their full agonist while they're on this regimen until they reach the very last day, which is a therapeutic dose of buprenorphine. This is really because the buprenorphine that they're getting is not enough to treat any of their symptoms, whether that's opioid use disorder or for pain or for whatever else. The full agonist is really doing that until the last day. Low-dose inductions are sort of its own, many hours long course by itself. So I don't want to get into too much detail necessarily, but I do want to briefly touch on the fact that this is the protocol that we use at Yale, or one of them that we use at Yale. There are many other low-dose inductions that are developed by different institutions, and there is some case series data to show that different ones can work quite well. There's a 3-day low-dose induction, or it's like a slightly more than 3-day low-dose induction that basically works by giving patients ongoing increasing doses of small amounts of buprenorphine more frequently than sort of the protocol that I showed you before. So there's lots of different ways to do this. You will, if this is an area of interest, you'll definitely encounter different protocols. The most important thing is not so much the specific protocol, but that you're going slowly increasing the dose and also continuing the full agonist until the very end. And then briefly, a high dose induction is another sort of regimen that we use for the fentanyl era. And so in these circumstances, it's really similar to a standard induction. But the difference is that instead of starting someone on a very small amount of buprenorphine, we start them on 16 to 24 milligrams. So it's the same protocol where you hold a full agonist, wait till they start having withdrawal, give them buprenorphine, treat precipitated withdrawal symptoms, and then potentially give them additional buprenorphine. The reason that we give these higher doses are really because the idea is that, if you're going to displace the full agonist opioid, you may achieve more benefit and less precipitated withdrawal by really giving someone enough buprenorphine that they will have some agonist effect that will sort of manage the precipitated withdrawal symptoms. It's worth pointing out that this is really something that should either be done either by the addiction consult team or by a team that's sort of very familiar with doing this, or this is done sometimes in the emergency department by experienced emergency department clinicians. It's really sort of something that should be done by people who are very familiar with it, because there is certainly a risk of precipitated withdrawal with it, and so should be done carefully. This is just a brief table that goes through some of the other withdrawal adjuncts that can be used for opioid withdrawal. So this is all the way from ondansetron for nausea, loperamide for diarrhea, acetaminophen for sort of muscle aches, trazodone for difficulty with sleeping, dicyclamine for abdominal cramping, clonidine if someone is hemodynamically stable for sort of stress and restlessness. In certain circumstances, ketamine for severe withdrawal, myalgia, restlessness. The really important thing is, first off, that these medications can provide a lot of comfort for patients, but that they are never a replacement for an opioid agonist. So we use these medications when we're starting someone on methadone. We use these medications when we're starting someone on buprenorphine. We use these medications to treat precipitated withdrawal, but they're never, ever, ever the only medications we use to treat opioid withdrawal. Opioid withdrawal is really should only be treated first and foremost with an opioid, but these can serve as adjuncts as well. The DEA waiver is a sort of process that someone had to go through if they were interested in prescribing buprenorphine. It required an additional training period and some additional documentation. And the wonderful news is that DEA waiver does not exist anymore. So as of January 12th, 2023, a DEA waiver, an X waiver, is no longer required to prescribe buprenorphine. To prescribe buprenorphine, all you need is a standard DEA license, which someone who's completed residency will have, and somebody who is in residency will have sort of as part of their institution or as part of their basically under their attending. This is a really, really important point. It's sort of fairly quick, but it's really, really important because a lot of people still don't know this. And it definitely comes up a lot of the time that people will sort of have concerns about continuing someone's buprenorphine in the outpatient setting or the inpatient setting because they think they don't have the credentialing for it. And it's really important to know that this is no longer the case. Anyone with a DA license can prescribe buprenorphine. And really, this is really important because of the sort of diagrams that I showed initially with the really, really high rates of overdose and the fatalities associated with synthetic opioids. We really need to get as many patients as possible onto evidence-based guideline concordant care. And this is one of the really important ways. Another important point for buprenorphine is that it can be used for chronic pain. It can be used only for chronic pain. It's actually, that's sort of part of it was its first development, but it is really great for the intersection between opioid use disorder and chronic pain. So it is a first-line opioid therapy for chronic non-cancer pain. This is in the new VA DOD guidelines, and then it has a lot of support in the new CDC guidelines for treatment of pain. It's really important to note that this is when talking about opioids. As a side note, opioids are not first line for chronic pain, but if someone is going to use an opioid, buprenorphine is a great medication for chronic pain because of all of the safety factors that I mentioned earlier. It's also a really great medication to consider transitioning patients from full agonist to buprenorphine for these sort of chronic pain, opioid use disorder overlap. It's worth thinking about when a full agonist isn't effective, when a patient is on a high dose of opioids for chronic pain, but achieving tolerance, therefore not really having good pain relief. When someone has intolerable or dangerous side effects, so especially as someone's chronic pain is if it's not well controlled and they're requiring higher doses, or someone is starting to exhibit signs of opioid use disorder, the risk of overdose does increase, and with those serious side effects, can really be an important time to consider the transition to buprenorphine. And then buprenorphine can be beneficial to think about transitioning to when someone is concerned about central pain sensitization and possibly opioid use-induced hyperalgesia. So central pain sensitization is basically when someone has really severe chronic pain that essentially rewires the brain and sensitizes the brain to painful stimuli so that pain is experienced more severely. With short-acting full agonist opioids that give you this sort of brief relief and then let go, and then brief relief and let go, you can get some sensitization. And one of the benefits of the longer-acting effect of buprenorphine is that it may help with that. Opioid-induced hyperalgesia is also a phenomenon where patients who are on opioids, high-dose opioids for a long period of time, do actually may develop worsened pain, as in their pain tolerance will go down because the opioids seem to sensitize some of the painful stimuli. And there may be some benefit with buprenorphine. This last bullet is still an evolving area of research, I should say, but there are some hopes based on the pharmacokinetics and pharmacodynamics of buprenorphine that it may be helpful for these. And then I think certainly a really important point to talk about with buprenorphine are its sort of multitude of forms. I don't put this on to talk about sort of the brand names necessarily, but you may hear some of them. But unlike methadone, which really comes pretty much just as methadone, there are many different ways that buprenorphine can be administered. So Suboxone is one of the most common brand names. It's a buprenorphine naloxone product that we talked about earlier. It can come either as a pill or as a film. Either way, it is a sublingual administration. It's not swallowed. These are actually all sublingual administrations on this diagram. Zubsolv is a sublingual combination that's sort of designed to theoretically have some reduced GI effects. And then there's also a large variety of generic buprenorphine naloxone combinations that you may be told about if you're sort of asking a pharmacy what they have available for patients. And then there is also buprenorphine mono product, which is just buprenorphine. It comes as a sublingual tablet. This is under the brand name Subutex, but also comes with sort of a host of generic formulations. Each of these has a taste associated with them that patients may have strong feelings about, and in certain cases, some intolerance to. And so it's partly why it's important to know about some of the different formulations. Also important to know that a lot of the pharmacies may not have certain stocks. And so depending on where you are, knowing what your pharmacy has available is really important because continuity of the medication is really the key to managing someone's opioid use disorder. There are two other options for buprenorphine that are relatively new. The first one is a long-acting depot injection that's injected subcutaneously into the abdomen under the brand name Sublocade. That's basically a once-a-month injection of buprenorphine. And then there is another new formulation of buprenorphine with different doses called Brixadi. These are either 1 week or 1 month injections that are both intended to basically try and attempt to provide some more stability for patients. a lot of the data around both of these long-acting injectables is very much evolving, although there is a lot of promise that these and other long-acting injectables will help provide patients with a stable form of treatment for opioid use disorder. And that is pretty much it for our materials. Certainly, though, if we have any questions, I'm certainly happy to answer. So this was certainly a lot of material. We have our references listed as well, and the slides are available can be available, and the recordings are available. But if anyone has any questions, I am happy to answer them.
Hi, thanks for talking with us today. I appreciate everything. I'm sorry, I don't have a camera connected to my computer right now, but I wanted to ask a little bit more about opioid-induced hyperalgesia and whether you've noticed any differences in that with the rise of fentanyl use on the street compared with other opioids that people have presented using in the past, like oxycodone, hydrocodone, or like diacetylmorphine or whatever else they were using. Is there a difference with now fentanyl being more common?
That's a great question. I actually am not sure of any data that talks about sort of incidence or prevalence of opioid-induced hyperalgesia in the sort of current era. I don't know if Dr. Relli, if you know any, feel free to chime in. I should say, I think important complicating points are that there's just the high potency synthetic opioid sort of illicit market is just so variable. When someone says that they inject fentanyl, or when someone is sort of has lab tests to show that they inject fentanyl or sort of take fentanyl that's not prescribed, what that really is fentanyls, as in these are all different lab made combinations that have different sort of durations of action and all that stuff. And so I think, generating any sort of specific data is going to be hard because that all of this is evolving so quickly. There are also other categories that are sort of a little separate from fentanyls that we're starting to see filter into the sort of drug supply as well. So in truth, I'm not actually sure, but I'd say that it's whatever is present is probably going to keep changing as our drug supply continues to change and honestly become, frankly, more contaminated with a lot of these sort of high potency synthetic opioids.
Yeah, I think echoing what Sammy said, one thing that I would note though is a lot of people, I think that the difference is that the reason we're seeing this with prescribed opioids more commonly is because just like anecdotally, people using fentanyl are using fentanyl to avoid withdrawal symptoms. They're not frequently, like their primary goal is not as often just pain. A lot of times they're using it just to avoid feeling terrible, feeling withdrawal symptoms, even if pain was why they first started using it. Whereas for things like chronic prescription and oxycodone, like their goal, they have a steady supply, but they so they're not going through withdrawal frequently, ideally, but they just keep seeing that pain level escalate over time, and then because that's the primary thing that they're using it for, and they're not seeing relief, and in fact kind of seeing the opposite happening. But I think that's a good area of research to, because I don't know of any studies with opioid-induced hyperalgesia with purely unprescribed fentanyl, but definitely something to think about. And I think we do see it, like we see people like things that probably wouldn't be as painful to some people who are getting, for example, procedures, they have a higher pain threshold, even to things that probably wouldn't be quite as painful to other people. But it's not, I don't think that we definitely see it in the context frequently of people increasing their oxycodone dose or increasing their prescribed doses and not seeing the effect. And in fact, having that opposite effect.
Appreciate the answer. Actually, if nobody else has anything, I had one other question, if that's okay. I'm also curious, just with the way that people are using fentanyl on the street currently. I'm currently on a anesthesia rotation, so I'm using fentanyl on a daily basis for the reason that therapeutically it has an extremely fast offset and onset. So I know that synthetic opioids like oxycodone have a much longer duration of action. So I'm wondering if people using fentanyl on the street are having withdrawal precipitate so rapidly. All like, do they have to re-administer all day, or what exactly does that use pattern look like? And does it have implications for treatment?
Yeah. So, oh, sorry, did you?
No, go for it.
Yeah. So, like fentanyl and heroin both have short half-lives. And so that's part of the reason that it's so destabilizing for patients, is because they end up spending just all of their time in that pattern of using, finally making the terrible withdrawal symptoms go away, and then being right back in that cycle multiple times per day. And that just ends up being all you devote your life to, because saying you're going from like 0 to like the worst flu of your life, you're vomiting, diarrhea, you just feel terrible, can't function. And so you just have to spend all of your time trying to not feel this terrible. Whereas something like methadone is like, you take it once in the morning and then like you go and do your life. With Sublocade, even maybe get a shot once a month and just go about your life. So it's just, you use those medications because it's so stabilizing. You know what you're getting. You know that you're not getting methadone plus a question mark amount of fentanyl. You know that you're not going to overdose on that dose that you're taking, because you know what's in it, and you can use something long acting, so you don't have to keep going through this cycle of feeling terrible, using more, feeling terrible, using more. The short half-life thing about fentanyl in particular is that fentanyl in like single doses or like over a short period of time, it does have a really short half-life. But fentanyl, like including like in the hospital, when you put someone on a fentanyl drip, you put them on the drip for like the first half hour, you turn it off, they wake up. Put them on a drip for a week and you turn it off, they're not going to wake up, because it has time to get into the fat basically. And then by the time it gets stored in the fat, then it takes a long time to come out. So you kind of see both of those effects happening with people who use heroin / fentanyl regularly. And by now, like the whole heroin supply has fentanyl on it.
I think just the one thing to sort of add or echo is that sort of the fentanyl that you're using sort of at bedside in sort of before, during an OR case is quite a bit different usually than what's being sort of injected or sniffed or smoked sort of outside of the hospital setting. Like I said, it's just like these sort of combinations of different fentanyls which have different effects. We don't really know. There's really not a ton of good data about how much fentanyl is being used. But like, for example, you're probably, like, if you're going to give a patient a dose of fentanyl in the OR, you might be giving them like 100 micrograms. I'm not sure, it's really not certain how much is sort of being injected routinely, but whatever it is the little data that I've heard is probably like significantly more than that. And so that's partly why you see some of these other effects as well.
I really appreciate the answer. That's definitely illuminating for how methadone treatment can improve somebody's quality of life and productivity level.
So with the data /X waiver not being required anymore, I'm pretty curious just to see, I guess, if prescribing of like medication assisted therapy, like how much that's going to increase, because from a lot of the outpatient doctors I've talked to, especially in family med, it seems like they just don't really know almost anything about buprenorphine and prescribing it. So I'm just wondering like what we can do, because I think it's so wonderful that now there's not this extra barrier, but it still seems like there's not the education. So it's like one barrier is taken away, but there's nothing to kind of supplement that, if that kind of makes sense what I'm asking.
So yeah, absolutely. So the DEA has now sort of is putting in place new requirements for all prescribers, not just sort of people who prescribe opioids, but all prescribers who have a DEA license, to sort of complete some additional, like to include additional training, which can include around buprenorphine. But you're right, there's a huge educational gap. This is one of the great challenges with the X waiver, is that it really sort of put a pretty big barrier. There are certain nuances to using buprenorphine, like as I've talked about. But honestly, it's once you have some basic sense, it's not significantly harder to use in the long term than oxycodone or hydromorphone, which we actually know can cause both overdose and development of opioid use disorder. Not to say that in certain cases buprenorphine couldn't cause development of opioid use disorder if used non-prescribed, but that's a separate issue. All this to say, though, that one of the reasons I was harping on it so much is because I think you're going to be working with a lot of different doctors in the next few years, and sort of an important point is for all of us to be change agents, and to sort of really sort of spread the news about the fact that anyone now with a DA license can prescribe buprenorphine. It's truly not that hard to gain some initial knowledge. What we are really going to need to see is also a change in systems, right? So thinking about, for example, whether that's how sort of systems teach the physicians or other prescribers about buprenorphine, thinking about how sort of we can in a lot of cases get people onto buprenorphine, whether that's in the emergency room or in the hospital with an addiction consult team, or in the outpatient with an addiction consult clinic, and then sort of continued, whether we're sort of teaching general practitioners like family medicine or sort of primary care internal medicine about it. That's going to definitely be the next big step, and it's going to require system change, which we all need to be involved with. But the first step of that, at the very least, is that is this sort of knowledge that it can be now more widely prescribed, and it shouldn't be a thing that's feared, right? We all are going to we all prescribe or will prescribe medications that frankly can be quite dangerous if used incorrectly. We talked about methadone's QTC prolongation. All of the antipsychotics do this as well. But thinking about how, but that shouldn't be a barrier for us sort of using an evidence-based treatment. So I totally echo your point. I think one of the important things that we all can do is act as change agents, and also sort of while sort of the other system change is happening.
Well, thank you so much, Dr. Hamdan and Dr. Borelli, for coming to talk to us. I really appreciate it. And then for anyone that's listening to the recording, thank you as well for listening. And then tomorrow we start with the student research presentations at 9 a.m. Pacific time. So if you're interested in any of those presentations, please feel free to join us. Yeah, and thank you so much for students that contributed to the conversation today. Any final questions from anyone? Okay, well, wonderful. Thank you so much. And I hope everyone has a great rest of your day or rest of your night. And I'll see some of you tomorrow.
Thank you so much.